8th International Conclave on Orthopedics, Ortho Trends 2025 in association with Shalby Hospitals. Dr. Shekun Patel.
Yeah, thank you very much. Good morning, everyone. I would be talking on OT hygiene 360 degree prevention, practice, and progress. Why to care for OT hygiene? To fight the invincible enemy. Each infection is compromised outcome and reputation. I will start with Dr. Ignaz Semmelweis. He is considered father of infection control or as a savior of mothers. He was an Hungarian gynecologist. He advised hand washing before delivery with chlorinated lime solution, that is calcium hypochlorite, and maternal mortality rate dropped from 18 to 2%. Infection is the worst nightmare of an orthopedic surgeon. Every surgical incision opens the door to a microscopic war. Even in laminar flow operating theaters, a single stray bacterial spore is enough. Infection increases hospital stays by 7 to 10 days, multiply treatment cost, and escalate medico-legal exposure. One infection can erase years of surgical excellence. Each infection wounds more than tissue. It damages professional reputation. Studies show one dissatisfied patient influences 3 others, resulting in lost referrals and eroded trust. The goal should be transform infection control from a checklist protocol into an instinctive surgical reflex embedded in every team member. Key pillars of OT hygiene. First is environment, equipment, team discipline, and process compliance. A comprehensive infection prevention strategy rests on 4 interdependent foundational elements. Excellence in one pillar cannot compensate for weakness in another. All must function in harmony. Let's start with environment. Physical infrastructure including laminar airflow systems, positive pressure ventilation, HVAC system with HEPA filtration, temperature and humidity control, proper zoning of sterile versus non-sterile areas, specific zones, protective, clean, sterile, and disposable zones. Equipment, sterilization protocols for instruments and implants, supplies, validation using chemical and biological indicators, proper packaging and storage, and comprehensive tracking systems. Team discipline, it is the most important factor. Human factors include proper surgical attire, restricted OT traffic, standardized scrubbing protocols, minimizing conversation and movement, and fostering a culture of accountability. Process compliance, systematic adherence to established protocols, regular audits and feedback, documentation standards, antibiotic prophylaxis timing, and continuous quality improvement initiatives. I will try to go in detail with some variable subjective aspects. Surgical environment discipline, sterile instrument tables. Maintain dedicated sterile tables at least 18 inches from non-sterile surfaces. Only scrubbed personnel may approach or handle instruments. Cover tables immediately if procedure is delayed beyond 30 minutes. Traffic control protocols. Limit OT occupancy to essential personnel only, typically 6 to 8 individuals maximum. Designate proper pathways separating sterile and non-sterile zones, post signs restricting unauthorized entry during active procedures, and designate a sterile nurse. Behavior inside OT. Maintaining sterile field integrity, limit unnecessary conversation during procedures. Speaking disperses respiratory droplets and increases bacterial counts in the surgical field by up to 50%. Restrict movement patterns, avoid crossing the sterile field, maintain a 12-inch radius around all sterile surfaces. Rapid movements disrupt laminar airflow and increases particle dispersion. Control door traffic. Each door opening disrupts positive pressure and introduces unfiltered air. There is an article in JBJS. Article is of 2020. It was conducted in a hospital in New York. It is a 2-phase study in 50 consecutive primary total joint arthroplasty cases. Phase 1 was without any signs, 1,888 door openings over 25 cases. That is 75 door openings each case. Average duration of each case was 127 minutes, 0.59 door openings per minute. Means one time door opening was there every 1.5 minutes. They applied restricted signs. So after use of restricted access signs, Phase 2, 1002 times door openings over 25 cases. It is 40 door openings each case. In USA, estimated cost of a single PGI is $60,000. Implant handling. Orthopedic implants require the highest level of sterility discipline. Direct contamination of implants is a leading cause of devastating infections. We have to use sterile peak pack protocol and no touch technique. Absolutely no direct glove to implant contact. Implant handling. There should be dedicated handover system. Hand hygiene and surgical scrub. We have to follow 17 steps of WHO hand scrubbing protocol. These are the steps. Surgical team shading. The average person shades approximately 10 million skin cells per day, with each cell potentially carrying bacteria. Ends of upper limb and lower limb sleeves must have elastic bands to prevent shedding of skin cells. Cleaning and disinfection. Between case cleaning, perform thorough cleaning of all surfaces within the 3-foot radius of the surgical field. Adenosine triphosphate bioluminescence testing provides rapid testing. Results are available within 15 seconds. And advanced technologies, ultraviolet disinfection and hydrogen peroxide mist. Antibiotic prophylaxis. Timing is very crucial. Pre-incision window. Administer antibiotic 30 to 60 minutes before surgical incision and discontinue prophylaxis within 24 hours post-operatively. Surveillance and audit. Surgical site infection rate tracking dashboard and air quality parameters. HEPA filtration standard, 99.97% of particles more than 0.3 micrometers should be captured. Positive pressure ventilation, maintaining 2.5 to 15 pascals positive pressure differential, and air change range, minimum 30 air changes per hour. Human factor training, building a culture of safety, regular simulation drills, breach reporting system, and continuous reinforcement. OT design evolution, it started as a sterile rooms, then laminar airflow era came, and modular design and zoning, and now we are working in integrated smart OTs. An ideal operation theater, room size is 6 by 6 meters.
Kindly summarize, sir.
Yeah, ceiling height is minimum 3 to 3.5 meters. Take home message, every implant carries your signature. Please keep it infection free. Prevention is better than cure. OT hygiene is a team culture. Orthopedic surgery demands zero tolerance. There is a slok in Rugved, Sarire Jarjari Bhute Vyadhi Graste Kalebre, Aushadam Jhana Vitoyam Vaidyo Narayano Hari. It means when the body is suffering with the disease, medicines are like sacred waters of Ganga, and the doctor is none other than the Supreme God Narayana himself. So we should behave like this. Thank you.
Thank you, Dr. Shrikun Patel, for truly enlightening and comprehensive presentation. Our next speaker for the session is Dr. Sunil Rajan, sir, who is going to discuss on daycare surgery in India, opportunities and challenges. Please join us in extending a warm welcome to Sunil Rajan, sir.
Yeah, good morning, everybody. I'm thankful to Dr. Vikram Shah, sir, and Dr. Pachore, sir, and whole organization for making me here. So I'll be speaking on the daycare arthroplasty. What are the challenges in Indian scenario? So we all know that daycare arthroplasty is the patient admitted, operated, and discharged on the same day. It's a well-proved concept in Western world, and studied has proved the efficacy, safety, effectiveness, patient satisfaction, and functionality. So why this shift is required? Because the literature has shown the lower infection risk and faster recovery. If we see the trend, in 2012, 0.4% patients were getting operated, and in 2020, it raised to 14.1%. A recent trend from the Denmark study found that 21% of the patients were operated on the daycare basis. So what are the challenges and barriers in Indian scenario? I think the first and the foremost is the patient and family anxiety. What will happen if any complication arises? What about the severe pain if it occurs at home? Also, the surgeon is also hesitant. He is also not very confident, and he is worried about the medical legal concern if any complication occurs. Also in India, insurance companies also play a major role in this not acceptance of the daycare surgery, because joint arthroplasty is included as an inpatient only. And if the patient belongs outside the town, then it's difficult to operate on the daycare basis. So at Indore Apollo Hospital, we are performing this surgery since last 3. Our protocol is proper selection criteria, adequate preoperative planning, proper patient counseling and home care modification, and strict adherence to standard operating protocol. This is the most important step of daycare arthroplasty, the appropriate patient selection, for which various scoring systems are available, but out of which outpatient arthroplasty risk assessment score is the best one, keeping in mind the arthroplasty. A short brief, it has included the 52 comorbidities and 9 organ systems which are involved. Any score less than 60, we can go ahead with the daycare arthroplasty. But it's very restrictive, very tedious, and it's got the negative predictive value. So still we are in search of a proper scoring system for the daycare arthroplasty. We have made it very simple at Apollo Indore. The inclusion criteria is willing to participate by the patient and the family members. Patient should be independent and mobile before surgery. BMI less than 35, ASA grade 1 and 2, and patient should be well supported at home by the family and staying in the city post-operatively. The exclusion criteria is hemoglobin less than 11, pre-existing medical illness like COPD, CAD, congestive cardiac failure, valvular disease, cirrhosis, CKD, any thromboembolic history, or patient on the 2 drugs anticoagulation therapy, uncontrolled diabetes, or patient having the severe deformities in the knee joint. So PSC was done on the OPD basis, and patient was kept nail by mouth overnight at home. Patient was admitted early in the morning, 7 a.m., and patient was posted as the first case. OT shifting was done at 8 a.m., and anesthesia, short spinal anesthesia was given, and in surgery there were no rocket signs, all standard routine steps were used. Same for the pain management, similar to the standard arthroplasty, preemptive analgesia, intraoperative cocktail, peripheral nerve block, and post-op analgesia. The oral fluids were started at 2 hours, soft diet at 4 hours. Mobilization with the help of walker was done at the recovery room only, and patient was discharged before 8 p.m. So discharge protocol was that if the patient's vital sign was stable, pain was under control, patient has start taking orally, patient has start walking with the help of support, and patient has passed urine. But there is no widespread agreement on the discharge protocol. This is how patient was allowed to walk by the physiotherapist in the recovery room. In the follow-up, the hospital provided one nursing staff at the patient's home, and along with the monitor, and a WhatsApp group was made which included the management, doctors, OR staff, nurses, and the physiotherapist. And we used to get the 2 hourly WhatsApp updates in the group, and daily home physiotherapy visits was given to the patient. We operated about 44 cases, joints in 37 patients out of 7,800 joints, in which few were bilateral also, one bilateral THR in 1 patient, bilateral TKR in 2 patients, and bilateral UKR in 4 patients. Mean age was 56 years, males were 23, females at 14. The results were excellent in all the cases. Component alignment was acceptable, no complication noted. 3 unplanned visits in the OPD was seen due to the persistent wound discharge, but they were cured, and all the patients were well satisfied. These are many literatures available showing the efficacy and the safety of the daycare arthroplasty. This last systemic review was done in 2000, a latest systemic review, more than 1,000 patients, and the main discharge failures were due to the pain, increased pain, hypotension, nausea and vomiting, and there was high satisfaction score of 96%, and patient would choose outpatient arthroplasty again. So a take-away message is that arthroplasty is a safe, efficient, and cost-effective process. Proper patient selection is a key, and protocols ensure safety of the patient. So to conclude, outpatient arthroplasty is not about sending the patients home early. It's about getting them well sooner. Thank you.
Thank you, sir, for the talk. Our next presenter is Dr. Sharan Patil, sir.
Yeah, good morning, everybody, and thank you for having me here. This is such an engrossing topic. We could have an entire conference on this and still not have a formula how to make this work. and talking to the people who have done it and been there in front of them, it's quite a task. But let me give my perspective. If you want to have one vardhan, one blessing from above, and if you could do this, the best, I think the time is 14 minutes, not 6 minutes, 12 minutes. It's up to 51 to 11, 10:03. I'm not sure if I prepared for 14 minutes. So the best math you can learn, can you change this? Yeah, no, my screen is, okay. One vardhan, one blessing you want from above is if you can have this ability to calculate and learn how to calculate the future cost of the decisions you make today. I think this is the toughest one. But interestingly, as you gray your hair and lose your hair and do this day in and day out, one gets the pulse of what works and what doesn't work and how to calculate this. I'm sure you agree with me, sir. So, is there a way of predicting the successful ones? Look back at your college days, look back at your friends, look back at a class of 100 when you started your medical school. Was there a way of predicting who's the one who's going to be successful, who's going to be a surgeon, who's going to be successful? Probably a very tough one. But I can tell you what makes this work, because the education system doesn't say whoever is the best will succeed. In fact, it is the other way around quite often. A very typical scenario, a young girl playing, and this was a little mill which was spinning, and it was outside the building. Her dupatta got caught in it, and this is what happened. Both her hands were pulled off her. She was rushed to the hospital, and this is exactly when you're just done with your day and home for your dinner or to your mess, whichever age group you're in, and you're called by the casualty to come in and see. And when you're called in, it's very easy to say, this has never been done, give up, amputate, wind up, and go home. But when you put an entire team together to do this and have a reimplantation of both the arms, you know what it takes. It takes a tremendous lot of abilities to do this. When you do this, and you see 2 months later, this is how the arms look, and 2.5 years later, this very girl who belongs to a family, who belongs to entire ecosystem where the science can do this, and this is what is possible. So I was looking at a definition of an effective leader. And when you look at this definition, these are the things what I saw. Being a leader involves having a vision, thinking on your feet, taking charge and quickly solving problems and managing situations. And look at all the qualities which make a leader. I truly believe to be a surgeon, one has got an inclination to be a surgeon. These are the natural qualities, especially an orthopedic surgeon who's a madman. Generally, in the whole of all the postgraduates, you'll see orthopedic surgeons are very different. This whole act of reimplanting these two limbs with a multiplicity of team, what did it require? Inspiration, motivation, communication, empathy, flexibility, persuasion, talking to the relatives, getting the anesthetists, getting the scrub nurses, getting them dosa, getting them to get into the theater, middle of the night. You know it's going to be 12, 14, 18 hours of surgical work. And the relationship you maintain with all the colleagues, and the bias of action you have, and the authenticity with which you need to deal, and how you look at, when you do this, you're not looking at how tired you'll get, but you'll see 2.5 years down the road how this life is going to be changed, what it means to the family. To have all of this, I truly believe, if anybody, as a junior doctor, as a mid-level guy, or a senior leadership guy, if somebody can be involved in an act like this, that person is 100% certified to be successful. So constructing a professional life has got many aspects. How do you construct a professional? I use the word construct very carefully because it is you have to put many building blocks to reach where you do. And construction is a progressive thing, and it is something which we need to plan and do. Of course, one needs to be intensely involved in training. You don't want to sit in a flight where the pilot is not trained. When you're trusting people trust you with their lives, you have to be intense. You have to be good at your job. And that's why when you pick this profession, it's extremely important to learn the ropes and do the job well. How long do you train? Because there's no end to the amount of training you have to do. But if so many people, the family situation doesn't allow you, need to somewhere wind up, start your life. Everybody's situation is different. One thing is for sure, the longer you train, the better differentiated you're going to be. You will have a niche where you can be. Where to settle. And those are very, very important decisions. The place itself can be the size at which you can grow. And what is your appetite? What is your circumstances? Where do you want to settle? Do you want to do an institutional practice or do you want to do an individual practice? Big decision again. With times, institutional practice, I believe, and team practices, I believe, is where one has to go. And the other thing one, as a young person, one has to watch out is never have horizontal movement in life. And you change a job just because you don't like the boss or just because you don't like the place is not the way life has to go. It has to be a vertical movement in life. And remember one thing, effort to reward is never the same all your life. When you're young, you make a huge amount of effort and the reward is very, very small. And as time goes by, effort and reward becomes equal. When you'll reach a stage when less effort will give you a huge amount of reward, and that's the formula of life. One needs to understand it. And I've seen a lot of young people, they join medical schools. This is the salary which is paid, and I'm not going to work beyond 4 o'clock in the evening. It's okay. I mean, they may be paying you less salary, but you've got only one life. And in that life, you want to be your maximum. You don't worry about what is paid. Don't join. If you join, give everything you have. So the effort to reward, and I got into, England is it's a very pretty country, and it's very easy to lure you back to locums and all of that. When you don't have a practice, you feel like running back and doing some locums. One thing I consciously did is never took a locum job ever. Because even in that 6 weeks, I saw 5 patients, operated on 5 patients. I know that is a multiplier. Those 5 patients in a long career of 30 years will give you multiple of that. And the power of those little engagements, little relationships you build is so important. You need to invest yourself fully in that. And that's when you hit the glory. Success is not where you are. Success is from where to where you go. Some people start from the 10th floor, some people start from ground floor. Success is from where to where you go. And never compare yourself with anybody else. And success is a habit. Once you succeed, it's intoxicating and you keep doing it. So it's so important to have small successes and build on that. And I also seen, it's so amazing, this observation. You see the best of lawyers, a Supreme Court bench in Delhi here will have a lot of judges from the same office. You look at the Palkiwalas, and all of these people have come from the same ecosystem. Don't hesitate to imitate success. There is something in the formula. If you're in Shalby Hospital, there is a formula why it has succeeded. It's great to imitate that, and you will see you'll branch out into something special. Success should be imitated many a times in your own way. And I can tell you it's a team sport. This is a team sport, for sure. You may be one piece of this team, and this is a fabulous statement which I like the most. If one is not bothered who gets the credit for success, a lot more will get done. Because you're always watching, I will talk only when everybody is watching, that big slows down the system. It's very important. A true definition of a professional is the one who is working hard unsupervised. An unsupervised worker is a true professional. And building a team, nothing can be more emphasized than building a team, because it's all about this. People who have the same team through their career have enormous efficiencies. Your secretary, your assistants, your technicians, if you can hold them together and take care of them and build a team which doesn't move, the kind of efficiencies you get, the kind of time you can save is enormous. So this is one more thing when you lead a team. When you are in a team, what you think comes from your upbringing and the way you think. What you say and what you do should align. Then you become very predictable. Your team knows when you say this, this is what you mean, and you will do that. Your family knows when you say it, you will do it. Your friends know what you're thinking, what you're saying, and what you do. When you put all of these three together, that's when life is harmony. That's when you're predictable. That's when you can do great stuff and people rally around you. There are many things in this building blocks. Let me talk only about two of these. Kaiguna is a Kannada word. Kaiguna means you got a good pair of hands. Some people, oh, this pair of hands is excellent. You go to him, you'll get cured. What does it mean? In my thought, Kaiguna is actually your love to the patient. If you love your patient, drop your ego. If the dressing is required to be done twice a day, you have to see him every 3 times a day. That's where you do it, when you love your patient. And those are the doctors who have greatest success because they're so intense with their patients. And that's one. Second most important thing is, don't wait for the opportunity to come and then get ready. One needs to be ready. This is an opportunity which I got. This was an 8-limbed girl from Bihar whom I operated on, and I separated this conjoined twin. This was done for the first time in our country, and this is what we got immediately 2 months after. And today she's cycling and going to school, and this is an enormous opportunity. We Sparsh forever, and Sparsh came to a different stratosphere, and this was done without expectation. It was done for my foundation. And I keep saying, when you do something without expectation, the returns are exponential. Everything else is transactional. It'll take 30 more seconds to finish this. Good news is, we are the most happening country. World respects us. We have the opportunity to lead the world. And great platform has been built in this country by the seniors, and now it's up to the younger generation to take it to the next. This is my last bit, which I truly believe in. I was traveling in South Africa, and I was near Cape Town, and I saw this board, the Baker's Dozen. I went in for a cup of coffee there, and if I noticed they have written dozen as 13, not 12. And I said, you guys don't seem to know you got your board wrong, is what I told the waiter inside. He said, sorry sir, you're the one who's stupid. In this place, you pay for 12, we'll give you 13. And that's the Baker's Dozen. Of course it has got a history, it's got a story behind how this happened. In my view, if you can live this life, which is non-transactional, you pray to God every day morning, give me strength, God, can I give back more than what I take? We're all busy squeezing maximum out of life. Can we give a little more to our friends? Can I give a little more to the work? Can I give a little more to my spouse, my children, my parents? You will be the most invaluable human being on this earth. So a life led in a non-transactional way is the best life, is my belief. Goodwill and reputation capital are something which is not measurable, but they are. A doctor's life is an ikigai. You are good at your work, you love the work, and the world needs you, and you get paid for it. What better? I don't think ikigai's definition is a doctor, is an orthopedic surgeon in my view. A life from which you don't need a holiday is the best one. Thank you so much for having me.
Thank you, Patil sir, for laying out the perfect path for success. Moving on, I would like to invite our next presenter, Dr. B.S. Murthy sir, who will present on bone cuts in TKA, how I do it right.
Good morning. Thank you very much for calling me here. You need to do a TKR. You should have an aim that you should have a balanced knee. Both extension and flexion spaces should be equal in all the range of movements. This can be achieved with gap balancing or with a major resection. And in gap balancing, there are two techniques. You can balance your gap in the flexion, then go on to the extension, or vice versa. Major resections, you have to cut your bones based on certain bony landmarks. And spacer block or spacers are used to assess your extension flexion space. Soft tissue is least handled in this major resection, and most of the surgeons do this with a little bit of balancing at the end of the surgery. So taking into consideration femoral rotation, this is very important that you should set your femoral rotation. During the surgery, preoperatively it is very difficult to assess, but if you see your gaps, you can adjust your femoral rotation, because otherwise you'll have a problem with the patellofemoral and other flexion gap and extension gap inequality. Femoral sizing is also important, whether you are anterior referencing or posterior referencing, depends on what type of gap you want to measure, but you need to keep thinking that what is my extension space, accordingly you should size your femur. Tibial axis and rotation and slope also is very important, because there patellofemoral other impingement syndromes can occur. Proper rotation and sizing is very important. And pre-op planning is, as usual, very important for your doing the bone cuts. You must know how much of valgus or varus you are going to cut your femur and tibia, and you must decide beforehand. And then go ahead and do your templating is of course very important to know the sizing and the rotations out here. Basic surgical skills need to be for the younger guys. You must know what exposure you use and go on do it, and develop a routine so that everybody, your assistants, learn and follow you. Have control over the saw. That is what I learned from my teacher. I was just watching, he's sitting here, how he used to hold his saw, and then how he used to manage and what retractors he used to. These are the simple things. Femoral canal entry is very important while doing a bone cut. If you do it too anterior or posterior, you end up in flexion or extension. Then, second thing is that IM drilling is very important. Gentle rimming, don't push it through. Pre-op valgus is set on the jag as you have decided. And you should touch your stick onto one of the condyles, and gentle rimming should be done. Tibial cut accordingly you must see, and you must align your thing depending on the 4 types of, that is medial or medial third of the tubercle, parallel to the shin, second toe, or check posterior slope and angle, keeping it a preoperative what it was. Then be careful about cutting it. As I told you, you need to control your saw. And I usually do extension first and see how much of my gap, what are the opening and where it is opening. And then I do the femoral sizing and rotations. Depending on that, keeping my paddles parallel to the tibia cut that I've done to the mechanical axis, or might be a little varus or valgus where I've decided, and keep the rotation, posterior referencing or anterior referencing, that depends on your choice. And in between sizes, you know how to do it. And sizing and rotation has to be done. Then you do 5-in-1 jig. These are the simple things that I need for the younger guys to see that. Check for notching. You should not be doing any anterior notching. Finish the anterior cut, flush with these things so that there is no overstuffing of the patellofemoral. Posterior condyle cut, depending on, it should be parallel, and you should have equal flexion space on both the sides. Accordingly, you have to adjust your rotation. Posterior chamfer cut, this I will not go detail. If you are a PS surgeon, you do bone cuts. And check extension and flexion spaces. This is very important. At the end of surgery, you must have equal flexion and extension spaces. As you extend the knee, it should be, if it is not a Smith & Nephew, the old one, then it's difficult. Otherwise, if you do see that and how much is the flexion extension space, you have done your surgery 90%. And do the trial and then see where it is. In this case, a little bit extension was tight. So I did a little posterior, and I do the rotation of the tibia intraoperatively, see how much of my tibia is rotating. It should rotate a little bit internally when you are doing a flexion, and that is your, the lateral rotation is good. Tibial keel preparation, this I will not go detail. Once you have done that, you see that your extension is corrected, it was tight, and I got it. Now the most important part is the adjustment of the cuts, which is very important. Bone cuts have to be adjusted during the surgery, because this is a thinking surgery. Soft tissue release are to be kept to the last. If the extension space is tight in both the sides and both medial and lateral, then you need to cut your distal femur by a little bit, if it, particularly in flexion deformity. If it's not a flexion deformity, you find osteophytes, you do not adjust your cuts, because it will get corrected automatically once you finish your cuts. And if you release your PCL, then it becomes more easy. Only medial lateral extension space, then you need to remove the osteophytes. If the flexion space is loose and the extension space is tight, then posterior slow release, upsizing the femur, implant femur in slight flexion. Flexion space, similarly, vice versa, you adjust your cuts and you can do that. So keeping that in mind, you have now your robotics, but robotics doesn't do your surgery. You have to keep thinking how to adjust. And when you are doing your segmentation and this thing, you should be the main one who is doing it, not the robot which is doing it. Flowchart, CT scan with 3D segmentation, registration, gap checking, everything need to be done. Preoperatively, CT scan has shown something, you need to adjust your cuts accordingly. So for example, this one, I saw that my flexion extension space is increasing very high. So I proximalized my tibia and then I did it. and it came down to be 3 and 3 in preoperatively, and intraoperatively, see that I have just put my tibia up by 2 millimeter, and I got away with it. And this was while doing the gap balancing before putting any cuts or anything, I found this one that it is not corrected. So I needed to adjust my rotations and everything according to my basic principle which I learned earlier, and then from there I just did it and I got a beautiful balance. So at the end, I would like to say that TKR is a thinking surgery. Concentrate on your surgeries. At the end of it, you find a beautiful 10 to 10 space on flexion extension on both sides, and adjustable. So TKR is a thinking surgery. You must think while doing surgery. Don't get distracted with the music or anything or talking on the table. But it should be adjusted accordingly, flexion extension space, so that you get a perfect balancing in your knee. Thank you very much for your attention.
Thank you, Murthy sir, for absolutely meticulous presentation and art and science of bone cut in TKR. For the next talk, I would like to invite Dr. Sanjay Gupta sir, who will present on the patellofemoral offset in total knee replacement.
Good morning, everyone, and thank you, organizers, for having me here. ये ऐसे बीच में चलेगा क्या सर? Right. So I'll be speaking on this topic, patellofemoral offset in TKR. Though not very well described in detail in literature, however, there are certain parameters that one can look at, to get some idea about your patellofemoral offset. So, for example, the anterior patellar displacement is the vertical height of the anterior surface of the patella from the trochlear groove, or anterior femoral offset, which is the vertical height of the anterior femoral condyle from the anterior cortex of the femur, and the posterior femoral offset, which is also the posterior condylar offset, is the vertical height from the posterior cortex to the posterior condyle to the posterior cortex of the femur, or the actual anteroposterior femoral diameter. And in this study by Pearson et al., they looked at various parameters, and if the parameters such as APD and AFO, if they are increased by more than 1 millimeters, or the APFD increased by more than 12%, or a combination of APFD and APD increased by more than 15%, this would account towards patellofemoral overstuffing. Now, certain other parameters have been looked at, such as the teardrop distance or the MPFL distance. Teardrop distance is the distance from the anterior surface of the horizontal distance from the anterior surface of the patella to the most posterior point of the teardrop on the lateral view of the knee. And the MPFL distance is the horizontal height from the interior surface of the patella to the most posterior point of the teardrop on the lateral view of the knee. And they made a ratio of these distances with the anteroposterior diameter of the femur and worked out a ratio. And if these ratios are altered, one can get an idea about derangement of the patellofemoral offset. Now, a very simple parameter is to look at the anterior femoral offset, and if it is increased by more than 15% of the femoral diameter, or if the posterior condylar offset, if it is increased by more than 95% of the femoral diameter, that would also count towards increased offset. Now, in this X-ray, it's clearly visible that one has overstuffed the patellofemoral joint. Now, we know from the biomechanics of patellofemoral joint that the patellofemoral joint reaction force is the resultant vector of two forces, the quadriceps tendon force and the patellofemoral and the patellar tendon force. And more you anteriorize the patella, more is the joint reaction force, and can have problems with the biomechanics of the patellofemoral joint. We also know that increasing flexion increases the patellofemoral joint reaction force, and also we know that with different levels of activities, for example, Plain walking, the patellofemoral joint is about 1.3 times body weight, and it increases to about 7.8 times body weight during squatting and all. So one has to be really mindful of the fact that one has to try and restore the patellofemoral offset in order to have an happy outcome for your patients. So what are the issues that can arise with altered patellofemoral joint? Well, patients can have anterior knee pain, which is as high as 23% in various literatures. One can have reduced range of motion, and it is estimated that approximately 2 degrees reduction in range of motion happens with 1 millimeter increase in offset. Patients can have more crepitus, feeling of tightness in the knees. So whether this theory, this concept of altered patellofemoral joint affecting the outcome of the knee replacement surgery really translates into clinical practice or not is to be looked at. So we ought to see as to what the literature is saying. And well, there are studies supporting either ways. So for example, this study comprising of 168 patients published in Journal of Orthopedic Surgery 2024, wherein almost 65% patients had overstuffing of more than 1 millimeters. In this group of patients, they had longer recovery time and also reduced flexion at the end of 2 years. Also, it was noted that the risk was higher in females, and especially in patients who had smaller thickness of the anterior femoral condyles. Now, this other study published in JBJS 2012 looked at the effect of upsizing of the femoral component on the joint reaction forces, and it was found that upsizing does increase the JRF in various degrees of flexion. Now, there are studies which actually say that it doesn't really make a difference to the outcomes. For example, this study, big study comprising of 970 patients, done by Jacob Martis et al., published in Arthroplasty 2017, wherein the altered PFO did not really change any of the outcome scores. And similarly, this another study of nearly comprising about 1100 patients published in JBJS 2012. Again, the findings were almost similar, that altering PFO did not make any change to the outcome scores in their patient group. So are we at the crossroads, not knowing as to what is right, what is wrong? Well, one thing remains for certain: whilst doing an arthroplasty surgery, one has to be really careful to avoid any amount of overstuffing, especially when you are sizing the femoral component, or else if you do a patella button replacement, you have to be mindful of the thickness of the patella button. At the same time, understuffing is also not good, because if you understuff, you end up with a loose flexion gap and can have problems with flexion extension balance of the knee. So one has to strike a good balance between overstuffing and understuffing while performing the surgery. So the take-home message is that overstuffing is very common in clinical practice. It doesn't necessarily translate into adverse outcomes, adverse clinical outcomes. One must try and recreate the anatomic dimension of patellofemoral joint to obtain a joint within safe margins of error. One must try and choose implants with thinner anterior flanges and trochlear-friendly designs. And now that we have newer designs available with in-between size options, which should always be preferred if choice is available. And one technical tip which I use during my surgeries, if intraoperatively I find that my patellofemoral joint looks as if it is overstuffed, after having done the trials, I do not shy away from shaving a few millimeters from the undersurface of the patella in order to get better tracking and better range of motion. Thank you.
Thank you, sir, for such a wonderful talk. Now, please welcome Dr. Raj Gopal, sir, who will be delivering on the talk, The Alignment Discussion, Mechanical versus Kinematic versus Functional.
Good morning, and thank you, Vikram and Vajre, for this very kind invitation. It's always a pleasure to be a part of this wonderful meeting. I'm going to talk to you on the intangibles in a tangible world, the alignment discussion, which has been sort of touted as a major issue in the past 3 to 4 years. So why is alignment important? Because it reduces mechanical and shear forces on the bearing surfaces. It reduces the stresses in the cement bone and bone prosthesis interface, and it helps to dissipate the forces within the soft tissue envelope, which eventually will affect your functional outcomes. So what is the real issue? Despite improvements in design, surgical precision, and functional outcomes, the role of the time-honored mechanical aligned knees, and when you go back historically, the work of Chitranavath and John Insall and several of these people has been questioned. And today we have a plethora of alternative options, from the anatomic to the adjusted mechanical, various iterations of the kinematic, the reduced kinematic, the constitutional, functional, and the personalized. There is a whole plethora of these options available to us today. So this is the alignment conundrum. You have these various assortment, and I think if that was not enough, now we have this orientation of the CPAC optional alignment, which has really been sort of somewhere demystified into what is easily called or loosely called the functional alignment. So when you look at the time-honored option that Chitranavath and John Insall mentioned, the distal femoral cut being made at 3 to 6 degrees of valgus, tibial resection at right angles, and the femoral component rotation at 3 degrees to the mechanical axis and the axis of rotation. So the adjusted mechanical alignment was a sort of compromise to undercorrect the constitutional frontal deformity to a maximum of 3 degrees valgus. You had a 1 degree varus on the tibia, so this was really a compromise alignment that was introduced in keeping with the kinematic slash mechanical adjustment. So the adjustment was done on the implant positioning on the femoral side, with the tibial component kept at 0 or 1 degree of varus. This gave very good functional outcomes and long-term survivorship in deformed knees. Correspondingly, Hollister in 1993 came out with this concept of the kinematic alignment, which was really what he called the true knee resurfacing. This was a 3D dimensional alignment concept, which was patient-specific and ligament-sparing. Now, in a patient who has this kind of a deformity, it's somewhat a bit of an oxymoron to believe that you can do these without releasing the soft tissues. So the kinematic alignment technique, the thickness of all the resections matches the thickness of the femoral component. The intraoperative alignment is done by caliper measurement, and in a kinematic alignment, the femoral cut is made in 1 or 2 degrees more valgus, and the tibial cut is made in 1 or 2 degrees more varus as compared to the mechanical alignment. Dr. Pachure and myself had the opportunity of being in Rome not too long ago, about 2 weeks ago, for the Italian arthroplasty meeting, and they talked about the unrestricted, one of the sessions was on kinematic alignment, where the tibial cut was taken at between 12 to 14 degrees of varus, and the guiding principle was the keel should be touching the lateral cortex of the tibia. When I sort of asked the question that what happens to the patellar alignment, they said almost always it dislocates, and they treat that by tibial osteotomy. That's taking sublime to the ridiculous. So we next come to the constitutional alignment, which reproduces the pre-arthritic condition. The only challenge here is some of our really severe deformities are almost impossible to align as to what our pre-arthritic alignment should be. So you can use the kinematic principles to restore the natural alignments and post-operative varus. What is clear, however, is that knees done with a tibial slope within 2 degrees of the natal slope will give you better proms. The constitutional alignment was popularized by Johann Bellemans. He suggested the concept, introducing the varus in the articulation. We next move to the functional alignment, which respects the native femoral and tibial joint surfaces and heights, avoids soft tissue releases, It achieves gap balancing by adjusting the bone resection, implants, and guided by soft tissues, and adjusts the patellofemoral compartment by adjusting femoral positioning. So you can see that there is a lot of gray area and overlap between these alternative alignment options. So when you come to the functional alignment, you look at generating a balanced gap through the arc of motion, and it has two start points. You can do this either the kinematic way or the mechanical way, and you can have this as a principle which aligns itself to the mechanical principle or the kinematic principle. The kinematic and functional alignment reaches the same goal, matching the soft tissues and establishing a pre-disease alignment. Personalized alignment is again a more confusing option because it differs from the alignment that has been described. So it's inclusive of the kinematic, functional, and even an adjusted mechanical alignment. So personalized alignment respects individuality of each person, but what individuality is for that given individual is unclear. So as you can understand, as you go down this path of alternative alignments, you just keep getting more and more and more confused. So when you compare kinematic alignment and mechanical, which are two of the most popular alignments, you'll find that these are the differentiating principles between the two. But when you look at the advantages, pretty much almost 85% of all knees implanted according to various registries are mechanical or adjusted. You have decrease in the lift-off motion in the mechanical alignment. The disadvantages of kinematic alignment is the contact stresses in the patellofemoral, tibiofemoral joints are increased, and the very fact that you have a choice of at least 4 kinematic alignments alludes to the fact that there is no conformity or universal agreement on what the right kinematic alignment should be. So these are some of the articles. Kinematic alignment does not result in clinically improved alignments after TK compared with mechanical alignment. And there are plenty of literature when you look at historical data from Merrill Ritter's group. He alludes to the fact that mechanical alignment is the way to go with longevity. When you look at earlier articles from 2017, even the gait analysis demonstrates better heel strike and lift off with the mechanical alignment principle. When you look at the robotic intervention, this was 4 RCT studies in very recent articles, no difference in outcomes. And again, when you look at 3 RCT studies between robotic and conventional surgeries, none reported differences. A summary based on the RCTs, and I would ask all of you to refer to this article. This is Joe Matar, 2020, May edition of Journal of Arthroplasty, who did a review of meta-analysis, almost reviewing 47,000 patients, 7 RCTs, no differences in clinical outcomes. And he mentioned that newer technologies must be embraced and encouraged, but with caution and judiciously, and recommended following established practices. When you look at literature search, a safe range of alignments is unknown regardless of choices. K is equal or marginally better alternative to MA, but the results are very marginal. And comparison of mechanical alignment and functionally alignment in robotically done knees have shown no significant difference. This is John Insall Award of 2025 from Simon Young's group. Functional alignment required fewer soft tissue releases, but outcomes were very similar. We next come to the CPAC, the new spin, the 9-grid quadrant that Sam McDessie mentioned. What does the literature say? Changing CPAC does not change outcomes. Pre-op and post-op remain elusive, and CPAC may identify phenotypes that could possibly benefit K. In conclusion, it is important to understand that regardless of alignment, outcomes in literature have not really demonstrated superiority of one alignment choice over the other. This is Mark Coventry's paper. Does matching native CPAC improve outcomes? Answer is no. Standardized balance goals are not able to reconstruct individual laxity functional phenotypes in more than 50% of the knees. In conclusion, I think it's fair to say that mechanical alignment or one of its variables is the most explicitly studied option of alignment in TK. It's still considered the gold standard. And rather than blindly trusting one single method, an orthopedic surgeon should be well versed with concepts like ligament balancing and measured resection to achieve the best possible result. Clearly, there is no standard options that work best over time. There is no best way to perform a knee, nor a way that unequivocally improves the outcome. This is the article that I was alluding to. I'd like to thank you for your kind attention.
Thank you, sir. Now for the next, I would like to invite Dr. Ashish Sheth, sir, who will be presenting real-life surgery on the anterolateral approach for the primary THR. For that session, I would like to invite our moderators, Dr. Sataj Gill, sir, and Dr. Narayan Hulse, sir, to be present on the stage.
Good morning. Our patient is around 50. This video. Can I control from here? Our patient is a 52-year male having the pain in the left hip from last 2 to 3 years with a global restriction of movement. I am going to show this total hip replacement surgery with the anterolateral approach. We are going to use in this patient a CS2 acetabular cup system and the tapered hip system. These both are the implants. The femoral stem is having the two types of the stems, the standard stem and the stem with the reduced distal profile. And the CS2 cup comes with all the unseparated options of the multi-hole and the three-hole options. The surgical planning starts with the tabulating on the opposite normal hip. First we try to measure the size of the cup and the size of the femoral stem on the opposite normal hip when it's possible, and according to that then we try to tabulate on the pathological hip. So the pre-surgery templating is a very important part of any surgical planning. So you are having the rough idea of what implant you are going to use during surgery. So in any patients having the proximal distal mismatch, you can have your proper inventory ready on table. We are using the anterolateral approach for the hip surgery from last 25 years. We are doing this approach in all the primary cases, in all complex primary cases. We do this surgery in the lateral position. The incision starts with 4 to 5 centimeter proximal to the tip of the trochanter, and the distal part of the incision is around 7 to 8 centimeters from the tip of the trochanter. Need to put this skin incision somewhat on the anterior part, so the acetabular brimming becomes easy. Cut the tensor fascial lata. Try to cut inferior part of the tensor fascial lata towards the thigh bone. Split the tensor fascial lata and put the Charlie's retractor. The ideal exposure is your trochanteric area is in the center of the incision. You can extend the incision according to the patient needs. This is the minimus. We usually put stress sutures from the entire 1/3 part of the medius to whole of the tendocapsular junction of the minimus. These stress sutures will help to put them back when we are going for the closure. In this approach, you just need to take care of the inferior gluteal nerve. From the anterior 1/3 of the gluteus medius, you can split the muscle fibers into the line of direction of the fibers. Go deep up to the anterior 1/3 fibers of the gluteus medius. Split them into the direction of the fibers. If you are around up to 5 centimeter proximal to the tip of the trochanter, then there are very less chances of injury to the inferior gluteal nerve. Then from the entire 1/3 fibers of the vastus lateralis, try to erase the whole muscle capsular bundle from the entire part of the trochanteric area. Go deep into the entire trochanteric area. When you are going for the deep dissection, your assistant will try to flex the hip, adduct the hip, and externally rotate the hip. It will pop up the entire part of the neck. Go deep up to the neck of the femur. Release capsule from the entire part of the neck of the femur up to the piriformis fossa. You can go for the release as you need. It's very important to see the neck of the femur and then go give down up to the proximal part of the neck. Go deep up to the piriformis fossa. Try to dissect this whole gluteus medius and capsule as a single soft tissue sleeve. So it will be easy to repair later on. When there is enough soft tissue dissection, with the flexion and the external rotation, your femoral head will pop up. This is a very easy and good approach. There is no any neurovascular structures coming in between. We usually start with putting one bony landmark in the intertrochanteric area and one landmark on the head of the femur and try to measure the offset of the head. Just mark what is the initial offset of the head of the femur and put on the board. We want to reproduce this head neck offset later on. The neck osteotomy you can do according to your prior preoperative planning. In this anterolateral approach, if it's a very small patient, then you can go for the more basal neck cut. And you can just remove all the osteophytes and the soft tissues from the inferior part of the neck. It will allow the easy retraction of the trochanteric area while exposing the acetabulum. Check for the length of your neck cut. If you need, then you can always go for the recut. We are usually a femur first surgeon. Before preparing the acetabulum, we try to check the anteversion of the femur with trial. Removal of the soft tissues from the piriformis fossa is one of the most crucial steps to put your femoral stem into the valgus. The preparations of the femur start with the broaching of the lateralmost part in the trochanteric area. In the patient with the narrow femoral canal, you need to be very much careful. When the canal is very big, then it's easy to get entry to the femoral canal. Just check your femoral entry with the right angle or any blunt instrument, so you are very sure you are not perforating anywhere. Then you can start the preparations of the femoral canal. The small first lateralized blotch is very important to put the implant into the valgus. It will remove the bone from the lateralmost part of the femoral canal. After doing the first blotching, again check for the neck and then start preparing your femur. Start with the smallest size 5 femoral blotch. Try to keep it into the maximum valgus so the most of the lateral part of the trochanteric bone is removed. Then go for the sequential blotching. This is a very easy system for the even beginner. With the sequential blotching, you are going to prepare your femoral canal. In between, remove the whatever ridges and bone is on the lateral part of the femoral canal. Go for the sequential blotching. This implant fits very well into the Indian femoral canal. Go for the femoral blotching till you are able to see your blotch is having the proper fit and fill. When you get enough stability, your femoral bone is moving with the trial, it's a proper size. Remove the trial blotch, put your neck and head and again check for your offset. This will help to not to have a major limb length discrepancy. You are very much clear from where you begin and now what is the femoral head offset. So you can plan according to your pre-surgery shortening or lengthening. Pack your femoral canal with any gauze piece or the roller pack, so the bleeding coming from the femoral canal will not trickle down into the acetabulum. Now, whatever antiversion you are having into the femur, you can adjust your antiversion into the acetabulum. It's very important to put a proper retractor while exposing the acetabulum, and in this anterolateral approach, you can see the acetabulum much better than the posterior approach. The proper 360-degree acetabular exposure is the key for the proper placement of the acetabular cup. Preparations of the acetabulum starts with the removal of the fat and the pulmonary fat from the inner part of the acetabulum. Remove the labrum from the anterior part, superior part, posterior part. So this will not impinge while putting a final implant. Measure the head size, and according to the head size, either you can start the rimming of the acetabulum with a very small rimmer, or you can start rimming your acetabulum with the same size of the femoral head. First rimmer, we should start rimming the middlemost wall of the acetabulum. After rimming the acetabulum, just try to middleize your rimmer so you can reach up to the floor of the acetabulum. Now, depending on the pathology of the acetabulum, you can plan your rimming. Go for the sequential rimming. As you increase the size of the rimmer, the cartilage of the acetabulum will start coming. Your direction of the rimming will be around 45 to 50 degree and 10 to 20 or 15 degrees of the antiversion. You can increase or decrease the acetabular antiversion according to the what you got your antiversion into your femoral trial. When you start getting the friction while you are rimming, that's going to be your probable size of the acetabular cup. This CS2 cup system, they allows for the one size under rimming. I usually try to go for the two size under rimming and check for my initial trial cup. Try to put your trial cup. If you are able to have a good hold in the trial cup, your acetabulum and the acetabulum is moving with your trial cup, means your implant is going to fit very well. This is the antiversion. And the 45 to 50 degree of the inclination. Again, you can go for the rimming with the two size less or one size less. Go for the final acetabular rimming before putting your cup. This CS2 uncemented cup, it comes with the porous coating with the center beads. All options are available of the 3-hole, multi-hole, and this fits very well into the Indian patients. There was some space was there onto the inferior part of the acetabulum which was filled with the bone graft. Decide the proper place for your screws. rotate your acetabular cup. So you are, if you need, then you can put your screws into the safe zone. This is the stability. So we are not going to use the screws for this patient. You can check the final stability with the help of the coccus or artery forceps. If your pelvis is moving with the implant, then you are sure your implant is very well fixed. This is a vitamin E poly liner. This comes in a various options: 32 head, 28 head, 36 head. Also in the neutral lip with the 10° or the 20° inclination. Check for the final stability of the liner with the artery forceps. Again, remove the canal packs and clear your femoral canal with either scope or any instrument. Put a trial. Again, put the same neck and head. Check for the stability, check for the reduction. We don't usually locate the head of the femur. Just try to check if the reduction is possible or not. There should be a gentle reduction with the trial. Once you are happy with your trial, you can take a final implant. Remove the bone from the lateralmost part of the femoral canal. Remove all the blood clots and the tissues. This is a taper set size 12.5 stem. This is with the reduced distal profile. So even if patient is having the narrow distal femoral canal, this implants fits very well. Before going for final implant, again put your head, check for the offset, check for the trial reduction. If you are happy, then you can take your final implant. Go for the proper lavage of the acetabulum, go for lavage of the femoral implant before putting your final femoral head. This is size 36 head. You can put a stretch sutures into the anterior capsule and the posterior part of the capsule, or you can just hold with the instruments and go for the final reduction. Now check for the stability, check for the impingement. This is one of the very most important tests when we are going for the anterolateral approach. If your hip is not coming out in the flexion, adduction and external rotation, then you can allow the cross-leg sitting in this patient. Check for all the other range of motion. It's very important to repair the anterior capsule because the anterior capsule is the toughest capsule of the hip, and if we have cut during surgery, either T or L-shape incision, then we should repair this with the ethimond. We usually put all the anterior capsule back to the trochanteric area with Dr. Ranawat like technique. We are doing this surgery from last 25 years, and when we have entered for the revision surgery after 10 or 15 years, we have seen these all capsules, they usually get attached to the trochanteric area. This is a post-op X-ray of the patient. We are using the anterolateral approach for all types of the primary, complex primary, and in the simple revision cases. And this taper set and CS2 implants, they works very well in the Indian scenario. These are a couple of cases where the surgery is done by the anterolateral approach and with the taper set system. Even in the simple revision, if proximal bone is proper, we can put these proximal coated implants easily, and the growth is also there. Thank you.
Nice presentation, Ashish. Ashish, one question. Okay. So this is the lot of approaches, and I think we're going to talk more about the direct anterior and everything in the next few hours. So the main criticism about this approach is that you are cutting the main workhorse of the hip, the abductors. So what are your tricks or suggestions to make it heal better or you repair it better? Is there any modifications like taking the sliver of bone or you do, cutting approach?
The key for this approach is not to cut abductors and to avoid the injury to the infragluteal nerve. So we even don't take the anterior 1/3 of the medius. We try to go as anterior as possible. Try to keep your anterior incision into the medius as anterior as possible. So you can just cut anterior 1/4 of the abductor muscles. Now, if you are not going more than 5 to 6 centimeter proximal to the tip of the trochanter, then there are very less chances of the injury to the infragluteal nerve. And post-surgery, hip abductor.
Why you asked that? Narayan, you're a very naughty boy. So Narayan was laughing when he was asking and looking at me. Because
yeah, so he's
we actually go a long way, and he knows it. I've been doing anterolateral for the last 20 years now. And patients don't limp and lurch, including all revisions.
No, what
the
I was
trick here is, the trick here that I learned very early was that the anterior, what you said right, we don't cut the abductors.
Capsule.
So what we do is, we cut the anterior 1/3 or just short of the anterior 1/3, there is a sliver of bone. I lift the sliver of bone so that my abductors are separated. They are not cut. And
So
when you bring back, the trick is to repair bone to bone. And if you repair bone to bone, your patients do not limp and lurch. I do not see limp and lurch in my OPD if the abductors have been tightened well. So it's like a bone has to heal with a bone. Rest all you're just separating it, lifting it up and bringing it back to where it is.
So that is the point I was trying to bring out, that the taking the sliver of bone so that you can suture it back. Just another point. I think Dr. Pachara is going to come there. I think he's going to answer my next question also. So I'll just add this on. So you have done the femur first very nicely to get the the version nicely, but should you have not done the trial of the hip before putting the acetabular linal in and then go for the final implantation of the acetabular side?
Two things regarding anterolateral. We do agree the old thoughts of lymph was there, but today we are repairing that so beautifully. We take a stage suture actually, and once you take a stage suture, then the problem of getting back is very easy, very easy. For slivers, I little disagree with my Ramanik, because it has been reported by this Liverpool group at that time when I was in a training, little ossification becomes slightly more. But I did that for a long time. Regarding what you're saying at trial, yes, I agree with you. But we are actually, he is unable, he didn't mention, we look at the TAL quite a lot. And once you are really good at TAL, so probably that solves quite a bit of problem. I do agree that we will try to do the reduction and then do, that is another way of it, another way of doing it.
Just to make use of doing femur first.
Yes. That we have been doing for the last 20, 25 years from there. We learned from Larry Dorr actually. So because you can't adjust more uncemented hip, you cannot adjust much anteversion in the femur. So acetabulum you can 5 to 10 degrees here and there, but you can't have mismatch between the two of them.
Great, thanks a lot. Amazing.
Thank you, Ashish sir, and thank you, Narayan sir, for such great academic session. For the next talk, I would like to invite Professor Vijay Kumar sir for the topic Modern THR Insights, Acetabular Placements and Femoral Selection.
A very good morning to everybody. I would like to thank Dr. Pachore and Dr. Vikram for having me here. Well, I'm going to speak on, well, this has been given to me on acetabular placement and femoral cup positioning. Traditionally the anteversion is around 15 to 20 degrees, goal is 20 degrees, and this has been the Levnick-Jones. But these are three ways or three parameters that you look for: the height, depth, and the angulation. As far as the height is concerned, always the attempt is not to have a high hip, because if you have a high hip, it would result in a lot of problems, and patient is not happy and might even result in a dislocation. And the accepted high hip is around 15 mm from the center of rotation, and this and it can only be high, not lateralized, because if you lateralize, the amount of loading is much higher if lateralization is done along with the high hip center. And another value that you need to understand is it is 15 mm from the center of rotation and 35 mm from the interteardrop line. That's the maximum that you can go high, not higher than that. As far as depth is concerned, here again the center of rotation should be within 3 mm superior and 5 mm medial. If you go beyond that, then you are not restoring the offset properly. Now, on basis of this, two types of reaming are there. One is the conventional reaming, in which is basically taught to all of us that the first reaming is towards the floor and you progressively increase the reamer size until you have a capture there. But this has been found to decrease the acetabular offset. So what is the in thing is basically the anatomical reaming, which depends on the head size, and you start with the higher reamer and you ream in that, not exactly going to the center base of the acetabulum. So this has been found to maintain the acetabular offset as well as the center of rotation, and various studies are now being there that if you do the standard reaming, you tend to medialize more than is required. Even in CT scan, they have found that medialization of greater than 5 mm was seen in more than 40% of hip when conventional reaming was done. And these studies with simulated acetabulum have also shown that if you do the anatomical technique, there is much less macromotion stress concentration with this. So as far as the depth of the cup is concerned, here you have now two options. A medialized cup position is preferable in patients who have got a smaller or smaller acetabular floor depth. Like the A and B figure, which is basically a smaller bone structure, a shallow acetabulum, and you want to achieve a lateral coverage. However, if it's a larger bone structure and you have an adequate acetabulum, here you can use the tal and labrum to guide the depth, and you can do what is known as the peripheral reaming or the anatomical reaming. The angulation is concerned. Angulation here again, you need to be careful if you're not using technology that the table can move. And here you can use the anatomical parameters to see your version as well as inclination. The tal is a wonderful way to keeping a check on it, and always aim for more anteversion, because it has been seen that if you aim for around 20 degree of anteversion intraoperatively, the radiographic would be 16 degree. Similarly with inclination, you need to keep the cup more closed. If you aim for around 36 degree of operative inclination, it would end up around 40 degrees of inclination. And these are the anatomical landmarks. In addition to that, you can even use you can use your cell phone with inclinometers to say the inclination you can get. The anteversion still is a problem. Here again, the transverse acetabular ligament really helps you, or if you have navigation or robotics with you. But in addition to that, it was seen that even if placing this cup within these zones, there were a lot of dislocation. This was because of the spinopelvic movement which occurs here. And here you need to now also assess, get your patients sitting and standing, sitting and lying down X-ray or standing X-ray, then calculate all the parameters and identify whether there is any deformity or stiffness. So this is very easy if you can identify whether there is any change in pelvic tilt, or if there is a mismatch between the pelvic incidence and the lumbar lordosis. Most important is if if there's a change in sacral slope from standing to sitting of more than 10 degrees, then you are fairly okay. But if less, then you need to do something with positioning of your cup. So it has been defined to whether there is any deformity or not, and whether it is associated with any stiffness or not. If so 1A group is something which is normal, you can put the cup as it is. 1B is in which there is no deformity, however stiffness is there. Here, these patients are those who are stuck standing. That means the pelvis doesn't move, doesn't open up on sitting. Here you need to put more antevision in your cups. So this is an example of the same. If however, if there is a spinal deformity also, the stiffness is there, here you need to reduce your anteversion. This is basically stuck sitting. Mostly in Angstons, the pelvis is open forwards and there is more anteversion, so you need to decrease your anteversion in these patients. A couple of examples of stuck sitting patients in which you need to decrease your anteversion, and this also has been classified into a lot of classifications. I don't have the time, but the easiest way, what we see is a kyphotic spine with an open acetabulum. Here, you need to decrease your acetabulum. An example of the same, if you see here, this is the forceps, it is pointing where I would have put the cup normally, but how we put this in a less anteversion in these patients, and especially if patients who have got fixed spine, here best thing is to do a dual mobility and get out of it. Robotic THR is a big advantage. If you have, this takes care of a lot of impingement, tells you all the position, is a real game changer as far as total hip replacement is concerned. Now coming to stem selection, the other part, you traditionally have two types of stem, cementless and cemented. Well, cemented stems are basically very good for dot type C femurs. Dot type B is good for a cementless stem. Type A for a cementless stem. However, there are concerns with use of some type of stems in type A, so you need to be careful. A cemented femoral stem has found to have a very good result in patients who are elderly, femoral neck fracture, dot type C, as well as severe osteoporosis. And the other two philosophies. However, the important thing that I would like to point out, the composite bond fixation, these are the same stems. So you can use the same. If you're doing a cementless and want to convert to a cemented, you can use the same rasp and then convert it into a cemented. That's the advantage of using a shape close sort of a cemented stem. Otherwise, the results of force close have been better. So a couple of examples of the same. Now coming to the cementless femoral stem, well, they have been classified by Kanuja et al. And it's very complicated classification, which also had an update, and this is the latest classification. Basically, they are either of flat taper type, which is basically your ML taper log or trilog, or quadrangular type like the Corel or a polar stem, or a fit and fill type like the synergy stem. But these classifications don't really help you much. So how I usually decide is, whether I want to put in a stem which has to have a fitting in the metaphysis, diaphyseal or diaphyseal, because accordingly I would only broach or a broach ream or a ream. And in addition to that, we also now have started to look at the neck shaft angle, the offset, as well as the neck length of these stems. And this is the paper just recently came from Vellore, in which they have found that there is a lot of variation between the horizontal offset along with the neck shaft angle even in our population. So these are the normal stems which are available, and we have stems right from 123 degree to 135 degrees which are available. And preoperatively, we nowadays always calculate your neck shaft angle. And important thing in this is that selecting the stem, if you're using a Corel type of stem which has a single neck length, as even for a size 9 stem or a 15 stem, as compared to some other stems in which the neck length changes as the size of the stem increases. So you need to keep that also in mind. Certain examples, so this was a 132, with a 127, there's a short neck in which you, so you have to use all of this in your armamentarium in order to restore your offset. The other controversy is whether to use a collar or not. Well, collar has been used especially for the surgeons who are doing DA, as it adds to increased primary stability and reduces subsidence. And if you are wanting to put in a cementless stem and osteoporotic bone, it's better to use a collared stem. Now coming to the dot type A, which is basically the most common stem that we are using. There is a lot of, if you are not reaming the canal and just broaching in a dot type A, then you would result in something which is known as spotting, in which the stem gets fixed distally but is loose proximally in the metaphysis, and it has a short-term failure later on. So you can use cementless stem in osteoporosis, but it has to be used with abundant caution. Short stem is another thing which is really helpful in patients who have got, deformed canals. And the advantage of short stems is that, if you want to do a revision, you can very well do it with a normal stem. Later on, a modular stem in difficult cases like the dysplasia or deformed femoral anatomy or fused hip or, fixed spinal deformities, these modular stems are there, and this is the latest classification that I come across. This is something which, we, in failed intertrochanteric fracture, how to decide. So they have classified whether the fracture is healed or not, how is your proximal femoral bone support, whether how many holes are there. So the type 1A is in which, the fracture is healed and, there is proximal support, so you can get away doing a standard stem. Type 1B is in which, again, it is healed, but you have multiple holes there. So here you would require a long stem so as to bypass these stress risers. Type 2A again is an unhealed fracture, but only a single hole is present. You can get away doing a single, normal stem. Type 2B is in which multiple holes are present and the fracture is not healed. Here you will require a longer stem. Type 3 is something in which, there is no proximal bone support. You have multiple holes also. Here definitely you would require something like a S-ROM or a longer revision sort of stem in these patients. So to conclude, non-cemented stem is something which is, in India at least, most surgeons use a non-cemented stem for your routine primary arthroplasty, but you need to know whether you need to just ream or ream approach. But you should always have a cemented stem as a backup, and especially if you're using in a osteoporotic or pathological bone. And for complex cases, you would require a diaphyseal bearing stem. And now, you cannot just use one single design to restore biomechanics. You need to also take into account the neck shaft angle offset as well as the neck length so as to optimize the joint function and clinical outcomes. I thank you for your attention. And I would also like to invite you to the revision arthroplasty meeting next, I think the first weekend of December that we are having, and we are having all the who's and who of arthroplasty. I thank you for your attention.
Thank you, Vijay sir, for presentation. Any questions for?
Thank you very much. Thank you.
Thank you. For the next session in the conference, we have symposium on complex TKR, which will be moderated by Dr. Ramnik Mahajan sir. I would like to invite Dr. Ramnik Mahajan sir on the podium. And we have first topic, severe varus, by Dr. Parag Talikar sir. And I would like to invite panelists, Dr. Pradeep Agrawal sir, Dr. Narendra Vaidya, Dr. Bhupen Patel sir, Dr. Amit Pispati sir.
You're the one. Which laptop? This one? अभी इनका इसमें ये बाद में नेक्स्ट है. Okay, I think we will not waste much of a time. We'll keep our answers crisp, short. So we have to cover around 5 cases. So let's have Dr. Parag with his case on varus knee. Parag.
Yeah, good morning all respected seniors and distinguished guests. I would like to present total knee replacement in rigid varus osteoarthritic knee with medial bone defect. She was a 58-year-old female.
Dr. Amit.
Full length X-rays.
A scanogram. Do you have one? So one. So that's the other knee.
That is the other knee, left side. This was the clinical picture.
Yeah. So now that's the scanogram. So Dr. Amit, you asked for a scanogram. Here it is. Now what would have go through your mind? Go through your mind.
So
Well, both knees will have to be operated, but the idea of that was to make the calculation in terms of how to plan the bone cuts and how much would be the correction achieved. As Dr. Vaidya said, we need one stress view also to see how much is the correction, and presuming that this is rigid like you said, some correction is going to come from removal of the medial osteophytes on the femur and also reducing some of the osteophytes on the tibia.
Yeah, come. What did you have? What do you have next? So that's the intraoperative. So, before we go here, so how much would you say would be your view when you take this patient into the OPD now, into the OT now? Would you like to see something when you take the patient into the OR, or you're happy with so examination under anesthesia? How does it change your thought process in these patients? Because in the OPD they might look stiff, but what happens into the OR does make a difference. Sir, Dr. Vaidya.
Yeah, so we'll check the under anesthesia also, and as you rightly said, they may be correctable partially at least, and these deformities look more benign after examination under anesthesia. I think we should have our inventory also properly planned, in which if the defects are more, then we may require a screw fixation or bone graft, and then stems also should be kept ready for this.
So basically, when we order implants for these cases, so as Dr. Vaidya just pointed out, screws, stems, maybe some augments, right? Dr. Amit, would you ask for something else?
As a backup, one would also keep a constrained knee, just in case needed.
So that is the take-home message actually for these X-rays. So whatever they look like, they always a backup plan, plan B should be there on table. Now, let's see what was done. What was the thought process? So here somebody has mentioned it on his slide, where he talks of constraints. So we added a constraint, management of defects. Now he's added a role of robotics. Does all of you agree with robotics here?
I will definitely
Sir,
take
you've
help
been
of
sitting quiet. Dr. Patel. But no, I am sorry, Doctor. Sorry, Doctor. Dr. Pradeep Agarwal. Yes, Doctor.
I don't have much experience of robotics, but we can do away with the conventional way.
Okay. Right. Dr. Patel.
So we can plan this case in robotics, but the exposure is main part, because we want to lessen the pathology by removing good exposure and removing the maximum number of osteophytes we can remove beforehand.
So what comes first in your hand? Exposure means would you be releasing, or would you be cutting out the osteophytes?
No, I would be releasing like a routine case,
What
not
is
extra,
routine?
no extra release till equator on the medial side of tibia, and then we will remove the medial and medial femoral and tibial osteophytes, notch osteophytes, patellofemoral osteophytes, means anterior part of osteophytes.
I know Dr. Vaidya has something else.
Yeah, actually, such rigid joints, it is very useful to move, have your periosteum elevator or osteotome to strip off the anterior part of the quadriceps and make it free. So that will make the exposure much easier. And I do it anteriorly as well as mediolaterally. So the quadriceps, not release, but makes kinematics throughout the range of movement, and then that will give me. I can adjust my component positioning so that my soft tissue releases remain minimum, and they are very much calibrated. Because in such situations, for especially the junior surgeons, we tell them that you do adequate release or something. They have got no sort of objective endpoint for that. So if you have a technology, navigation or robotics, then we can sequentially release it, calibrating our release and the gaps throughout the range of movement. Otherwise, in conventional, we do it in extension and only in 90 degrees flexion. So throughout in a range of movement, I'll know more about the soft tissue envelope.
So the word here is calibrated, and to differentiate the word calibrated from adequate, if I could pick up that from your thing.
Right.
Okay. Come next. So what was done?
So extensive soft tissue release was done on the medial side.
Use the mic.
Extensive soft tissue release was done on the medial side, including joint capsule and the deep MCL. All osteophytes were removed. Posterior femoral condyle and posterior medial tibial were checked for osteophyte for tight and extension gap. As the gap was tight only medially in extension during varus valgus stress, posterior oblique ligament was also superiosteally elevated, was done in figure of 4. After assessing flexion extension, we are using laminar spreader and components, as tightness was there in both. Superficial MCL was slightly released. Pie crusting was done. Yeah.
So come to the final X-ray. Come to the final X-ray then. So,
for bone defect, bone graft with screw was done and stem was used, and we could come out without constraints.
so this was left side and the right side?
On the right side, we could do with a bone graft and screw and without stem.
Okay. Now, my question to you, sir. Yeah, you want to say something?
Yeah, just one thing, that when he's mentioning about releases, especially joints who are subluxated joints, it may be useful and required sometimes to release the popliteus also. So the subluxation part gets immediately corrected.
So that is what I was about to come to. I knew, but you were going to jump on it. See, the thing is, all these varus knees, they are pure varus, very good. But the moment you start seeing subluxation and they are rigid, in a varus knee, it's very difficult to fathom, but yes, it's the tight posterolateral corner which needs to be addressed. Otherwise, these varus knees refuse to come back in. So that is one, when you touch the posterolateral corner in a varus knee.
And secondly, we should take minimum bone cuts, because after release, it just opens up and you may run out of the poly sizes. So release, if you are planning for extensive release, then be conservative in bone cut. You can always cut more. And don't go to the base of the defect, rather build up the defect rather than resecting it.
Yeah. So building up of defect is the most important thing. Taking it up, cutting less, and that is probably the go-to. Anyone would like to add something more after seeing the X-rays? Dr. Pispati.
No, just one thought. On one side we have a bypass stem, on the other side there isn't a bypass stem, that's all.
So that's what I was coming down to. Because the standard teaching for us is that if you have used a graft with a screw, then it is a good idea to bypass this graft, so that allows the graft to consolidate more. That is
especially when you are using a short keel.
Yeah.
So I think
this is striker. The keel is very short. So this is 25 mm. Then normally, if it was, let's say, someone else with a 50 mm keel, we would have probably still gotten away with it. This is a very thin 25 mm keel. Anything else you want to show? Yeah. Yeah, that's beautifully done. Otherwise, we should appreciate him. Thank you so much, Dr. Parag. So the next is that laptop, the valgus knee. So Dr. Sumit is not here. I'll just put up one case from my laptop. So we have a 79-year-old female, diabetic, hypertension, rheumatoid arthritis. Standard routine, what you find. Now these are the X-rays that she comes into the OPD with. So let's start from Dr. Patel on that side. Dr. Patel, that's the X-ray, the female, not very obese. You can see from the side, they lean thin, not very obese. Soft tissues are telling you that.
So in OPD clinical examination, correctability of the deformity is important.
So number one, you check for correctability.
Yeah, and how is patella?
So you can see the patella there. It looks something like a bar, but not island.
Yeah, it's not subluxating.
And it's not sub.
Yeah.
That's what two. In a valgus knee, where the patella sits makes a lot of difference. That's again very important. Correctability is important because on the right side, maybe the defect that you see, the defect could be actually increasing the valgus, and the moment you put them to 10 degrees, you might see them correcting out. Anything else, Dr. Vaidya?
Yeah, in valgus, I think most important is to examine the knee throughout the range of movement. The valgus can be classified into 3 subcategories. Yes. One is completely rigid, not correctable, in which the lateral structures, the lateral, collateral, and all the complex is definitely going to be, contracted. Deformity which gets corrected either partially or totally in flexion, that means your lateral structures are attaining the normal length and you may not require very massive releases in those things. And you need to understand where is the deformity, because the deformity can be in femur especially, so you will have to plan accordingly. So if it is only distal femur, then accordingly you will have to keep your armamentarium. These patients also sometimes will be having recurvatum deformities, so you should rule out that also in preoperative examination.
So what scares you? Now if I might ask all of you, when you see a valgus, what scares you? A valgus in extension or valgus in flexion?
Valgus in flexion definitely is this thing.
But which is more difficult to correct? A valgus with flexion or valgus with extension? Which puts your mind,
No, in that extension, I think it's fine, means we can manage relatively easily. But if it is continuing in flexion, then it's a bit of a problem, because the defect can be combination defect on tibia as well as posterior condyle of the femur. And once you correct, there may be peroneal palsies and all those things. So I think definitely I'll be careful in even counseling the patient.
So valgus in extension actually is more problematic inside the OR. They're more rigid. They are the ones who probably would end up with giving you all those foot drop palsies and other things, would need some more releases. Anything else? So all of this, when you see the femoral hypoplasias, they can also be one of the causes of potentiating the valgus. You might see them more. And with valgus inflections, the problem is that the moment you start flexing them, so how do you like to, let's say, Dr. Patel, how do you like to start your balancing with a valgus knee? How do you balance your valgus knee? Let's say your releases is done. Whatever approach you use, your release is done. Most of us use standard medial parapatellar, so I'll stick to medial parapatellar. So we do a standard medial parapatellar, then you balance. So how do you like to balance first? You in flexion or extension?
So I'll first balance in extension, and then in flexion. Before putting the jig and deciding the rotation, I'll just lift the femur up, so I can judge which side structures are tighter, so what should my rotation be. And after putting the all-in-one cutting zig, even we can check with flexion block that is it stable or not.
Anyone would like to add? Dr. Amit?
Yeah, so in extension, initially the iliotibial band, and release really as much of it as possible. Thereafter in flexion, before doing the soft tissue release, I'd proceed with the femoral bone cuts. Manage the femoral lateral condylar hypoplasia, sort out the rotation and match it to the epicondylar axis, complete that part of the femoral bone cuts. After that, assess with the spacer block what kind of flexion gap I have, and then proceed with the releasing posterior-laterally around the femur, and then decide whether I want to do a popliteus release or either do a lateral collateral release or not, one of the two, based on what kind of tightness I have.
Do you agree with that, sir? Or you want?
In very rigid valgus deformities, I am resorting to more and more lateral epicondylar osteotomies, and because it gives me a secure and good fixation. Once you do that and you put the leg straight, then the lateral epicondyle, but it has to be a thick bone and a wide bone also. So it slides distally as well as posteriorly. And I think then you don't have to release all these popliteus and all those things, because popliteus is a dynamic stabilizer, and I put it 1 or 2 screws across and they get corrected quite well.
So is your release first, or you straight away plan that I want to do an osteotomy?
If it is a completely rigid, I will go for osteotomy. That's I have changed from releases and now I'm resorting to more bony
So most
sort
of the
correction.
literature now says that if you plan an osteotomy, if you've done all your releases, then osteotomy is not a good thing to do. But if you are planning an osteotomy, then it is a better idea to go and do your osteotomy first than doing your releases. That's one. Anybody? Narayan, you want to add something to it? Yeah.
It's almost a similar way, but I think the osteotomy in this osteoporotic bone, especially a lot of these valgus are rheumatoid. So it can be very small sliver of bone and can be difficult. So I just leave it to the last and do if we have more than 7 to 10 degrees of valgus still persistent even after doing all releases.
It's many times, even if you don't fix that, this thing, the knee still remains quite stable. And if you cannot, means in osteoporotic bone, the fixation may not be very secure.
So
but
there are papers on that fixation of the lateral condyle, and some of them have been earlier have been published, Ing et al. By not fixing them at all, just leaving them alone, but they've seen over 70% or more of non-unions of that fragment. They have reported as if functionally they are okay, even though it is not united. But the problem has been that there are very small studies and not big numbers, they're not randomized, so difficult.
Compared to the medial epicondylar osteotomy versus the lateral. The medial side, we know that even if it does unite, it works well in the organ lateral. The lateral is the same or is it different?
Sorry?
Medial epicondylar osteotomy.
Yeah.
I've done a few of them. I've not done many of these, but the medial epicondylar osteotomy even doesn't unite that well, or if they work quite well. Is it the same? Does the same rule apply to that?
On the contrary, medial has to unite, because in a knee, I feel that is sanctum sanctorum, the MCL. So if you don't have a proper MCL, you're actually not at the right. Lateral, we all know now, with all this alignments and the CR, everything, that sometimes what is happening is that lateral you can leave some amount of laxities with robotics. That is what we have realized, that you can still leave a lateral side slightly lax because of everything that I do. Like right now also I'm standing, my lateral is slightly lax and I'm putting more pressure on that, it's like a varus I'm standing. So everywhere.
And also, the most of these knees where the osteotomy has been done, either on the lateral or medial side, people also have added these, the varus valgus constrained poly. So that itself will give some stability for the, laxity of the medial or lateral collateral. So I think sometimes it's difficult to assess exactly is the function of the MCL is restored or not restored, whether it's the knee is functioning well is because of the MCL or is because of the post in the middle. So, and also they're all, you see, it's very small, tiny series, difficult to arrive
So I was
at.
waiting for you to comment on, or someone to comment on the use of constraint, because in the valgus knee, you sometimes actually end up using some constraint. CR knee probably never comes, not never, but most often you end up using some kind of a constraint. That's what was done in this patient, and you can see on one side, we had to use a constraint to balance the patient out. After all the releases, I was just not happy to leave the right side.
what scares me very much in valgus knee is the laxity of MCL rather than tightness on the lateral side, because you can release the tight structures, but to have so bony cuts again have to be very, very conservative, and you shouldn't even put a retractor also very carefully on the medial side.
So medial side, actually, when I am doing a valgus, I don't even release anything. I don't even touch the medial side. Even the anterior medial capsule, I don't release. So when I'm actually dislocating it already, it helps me that whatever it is required, it will peel on its own. Kyle, you want to say something? I can see it on your face. I agree. You want to come here? We can have the US opinion as well here. Huh?
They
You
don't
sure
get
about that?
these deformities there.
Okay. Although you see more of valgus deformities actually, with obesity as well. Sir.
Can we go back one slide? One should get varus valgus strain X-ray beforehand, and you can see on this side there is a laxity of medial collateral ligament because of the long-standing deformity. This side there is no opening on medial side. So it is very important and prudent that you get a varus valgus strain X-ray in higher deformity, varus or valgus, number one. Number two, deformity in extension only, biggest culprit is TFL. You correct TFL and you are there, unless your medial collateral is loose. And medial collateral is a very strong ligament. It goes bad only with long-standing female. Male, you will not get this picture. Another thing is, putting constraint implant, you are not correcting. No. Putting constraint implant, you are not correcting the varus valgus balance. And then you end up putting a thicker plastic, and the closure of valgus knee is difficult. If you increase the length of the leg, it is very difficult to close the wound later stage when you have implanted already. When there is a deformity in flexion, there are higher chances there. See, ligaments never get shortened. It can get stretched. Tendon gets shortened. Lateral collateral doesn't get shortened. So if you release lateral collateral for the sake of medial collateral, it is wrong. You tighten medial collateral, elevate the epicondyle.
Yes, sir. Agree. So that's it. I think probably we'll have now Dr. Akshar for this. Yeah.
So there is one more point, most of them.
Yeah.
So in that scenario, when you decide the rotation of the femur, it is not the posterior condylar axis that you look into. It is the intercondylar axis that you take into account when you decide the rotation, because that rotation will decide the balancing in the flexion.
So I agree with you. So what I have learned after, because I've been using navigation with you, sir. So what we started, this was also done actually with navigation. So what is, I have decided is that tibia first becomes the standard. Calculate your MPTA and whatever you are happy with. After you have your tibia, you have a platform. And on the platform you build up. And then I always like to balance first in flexion, because that is helping you with your rotation, that is helping you with your posterolateral femoral hypoplasia, that is helping you with how you want your trochlea and the femur, where you want to place it. Your tibia then becomes the guide for your placement of medial and the lateral. That corrects your rotation, and if once you're balanced in flexion, then you come back and balance in extension, because your releases that you talk of in most of the anterior structures are affecting in extension, and most of the posterior and the lateral structures are affecting in flexion. But in here, in the valgus, it is different from varus. Here it is the IT band, as sir also just mentioned out. It's the IT band which is the first thing that needs to be corrected. And that is why the sequence in a valgus slightly can be played around and to balance the rotation, because the problem with valgus is the rotation. Am I correct here?
Absolutely. I think one more thing we need to discuss is the patellar tracking in such scenarios, because you will have to do probably lateral outside in release in this, and sometimes, rarely, I shift the medial osteotomy and take it medially also, because that can be really troublesome.
Okay, I think we will move on. Dr. Akshar?
Just one question.
I think we're probably running late. Dr. Akshar? Yeah.
Dr. Akshar is not there, so Dr.
Yeah,
sir will present on behalf of Dr. Akshar.
Okay. Connect laptop.
Good morning, everyone. Dr. Pradeep Agarwal here. Presenting on behalf of Akshat, he is my consultant. It's a case presentation. Here is a case of hereditary multiple exostosis. The causes of extraction deformity are inflammatory arthritis, post-traumatic, hypertrophic osteoarthritis, post-infective or tubercular arthritis, hemophilic, and Charcot's. Now the problems related, when you see the X-rays, you will find the joint space narrowing, you will find osteophyte formation.
Pradeep Agarwal, sir.
Hello.
Sir, from here, sir.
Sir,
sir, we would like to go with a case, sir, with X-rays.
Okay, sir. So articular defect, associated coronal plane deformity, posterior capsule contracture, tight hamstring and gastrocnemius, and skin contractures. Now they lead to 3 different grades of deformity. If it is up to 15 degree, this is grade 1.
So can we see the X-ray? Can we see the X-ray?
Yeah, next I'll show, sir. I'll show, sir. If it's 15 to 30 degree, then it is grade 2, and beyond that it is grade 3. It's a 55 years old female who presented, and probably she was unaware of the underlying problem. She had an insidious onset of pain, which was gradually progressing, and she could barely walk with support and was on practically wheelchair for the last 3 months when she presented. And on local examination, swelling of the knee was more on the right side, deformity was windswept type of deformity, right valgus with grade 3 valgus opening. And these were the X-rays.
Okay, who would like to take this case? Sir?
I'm unable to see the right side patellar, this thing clearly here. So was it a fused knee or stiffening or range was there in this?
Sir, it was 30-degree flexion deformity on the right
So
side.
patella is still there,
Fixed.
I think there.
Yeah.
Patella is there, sir.
It's just
Okay.
sitting there.
And further flexion was possible up to 100, 30 to 100.
So in
Ankle area also, though they didn't much change the planning. Now the issue was plan both at the same time or one at the same time. So planning was done for bilateral subject to approval from anesthetist. And luckily, right side did very well. It didn't take much of the time, as sir has said, same approach was taken. And anesthetist allowed the other side also. Intraoperatively, FFD was found to be 15 degree. So instead of 30, it remained 15 only. And valgus stress was also done. So on the right side, medial parapatellar approach, intramedullary femoral jig, valgus 3 degree, distal femur cut, as sir said, 8 mm plus 2 mm. And for tibia, it was extramedullary, left side, there was not much of a problem. So these are the post-operative X-rays. Constraint was used on the right side.
Okay. Are you happy with this?
I think the stem is touching on the cortex and we should be careful, especially when he was saying that there is osteoporosis or something. You see the medial cortex on the right side.
And
You
the
should be
lower
very, very
portion.
careful and patient may complain of pain in the shin after that. So probably I would have, if there is a semi-constrained or constrained liner, then I'll use a shorter stem if my, reamer is touching the medial cortex because very likely that he will get a periprosthetic fracture if it is like this.
Yes,
And a
sir.
shorter femoral stem should have been also added, femoral side.
I don't think so. Because a lot of times now it's very well. If you have stem on the tibia, it's not necessary to put a stem on the femur with a
No,
touch
because of
stem.
the osteoporosis, what you are saying, that
unless if you have
exostosis.
intraoperative osteopenia, then yes. Because but the problem is that all systems do not allow stem on a primary femur. So there are only one or two who would tell you to on a primary femur. So the moment you talk of using it, a stem on the femur side, then you have to open a new set, which is the constrained set, and cut a bigger box and leave a smaller, thinner one. So probably that is where you can, if required, yes, otherwise you can actually bypass it. A short, stubby stem is probably what we are now looking at fully cemented instead of these longer stems to take care of that distal tip pain. You have any other thing, sir? Yeah.
Yeah.
Right. Right. Thank you, sir. We move forward. You want to add something? Right.
Just one, this, if it moves, I don't know. Like patient was very happy finally, but yes, we keep our fingers crossed for the tibial side. Thank you, sir. Thank you very much.
Okay. I think now we have Dr. Somesh coming up on a case on a previous HTO.
Good morning to everyone. There is a patient, 60 years old.
Hang on. Yeah, no.
There is a patient, old female with multiple comorbids, came with a right knee pain since 10 years, and he underwent a HTO on 2009. On inspections, where skin showed a linear healed surgical scar, not associated with swelling and varus alignment of the tibia. On palpation, where tenderness is present over the medial joint line, crypt is felt, and there is no FFD, norm is 0 to 100, no ligament elasticity, and distal neurovascular status was intact. This is a pre-op X-rays, which it shows medial joint space reduction and with the medial tibial plate in situ. In lateral X-rays, it shows a patellofemoral arthritis. Further, we move on to the HKA.
Just stop here now. So if this is the HKA, you just go back, and that is the pre-op X-ray. So let's start from the other side. Amit, you've been quiet.
Yeah, so I mean, this is a typical HTO to TKR conversion. And so other than the scanogram X-rays, I think one varus valgus stress view also to see if there's any laxity now on the medial side. This is a medial open wedge osteotomy. The problems that one might anticipate will be some scarring, retroquadriceps, because the range of movement is only 0 to 100 degrees. I think the tibial slope is not much altered over here, but there's definitely some patella baja over here, which is likely to cause some trouble. So these are the sort of problems that I anticipate. There's an implant here which needs to be removed. So accordingly, a prosthesis needs to be planned accordingly, because this is now going to be a stemmed implant going in here to bypass the last screw hole.
So that's actually a good point to take home is, you look for what? Scarring in a previous HTO. There is an implant. You need to understand the position of the implant. As Dr. Vaidya was going to raise up his hand, you do not need to remove the implant always, but you need to plan that can you do a TKR without removing the implant, or you need to remove the implant. Slope and patella baja on the lateral view again are very important, because most of the problems which were coming after in these HTO patients is the tibial slope. Then, so what happens in these, and now we are getting more of the medial. Earlier we were getting the lateral. The use of more offset stems came into the picture. Let's see, next move forward.
This is a further analysis for HKA, where MPTA shows 90 to neutral, and LDFA shows 93, where femur is in little varus, and varus is 10 degree, and CPACM 4. We underwent a procedure, medial parapatellar approach, where initially implant removal was done, plates and screws, and pre-registration for bony anatomicals was done. This is an initial gap showing.
Just go back. So here we have the first view from the Mako screen. So this was done robotic. So with this, that is what you have. Move forward.
Where we correct planning was done for bone cuts. Bone cuts were taken via the robotic arm. These are the trailing implants. The flexion and extension gaps were assessed with bone blocks, and PCL was found to be non-functional, so it was sacrificed. Where final posterior stabilized implants and tibial stem were inserted with stamen, and the final stability and alignment was found to be.
Stop here. So if we stop here and we look at this, so this is what I was also mentioning, and Dr. Vaidya, you also were about to say, is that you do not need to remove the implants, but these are a few cases wherein technology helps about where to keep your implant, whether you need to remove implants or you need to take out them. But one thing which is he has not mentioned, and I am looking for one of you to tell me, is in your OPD before this patient moves to the OT, what would be the thing that would be coming into the mind? A metal infection. A metal you have to rule out in these cases is any quiescent, nascent, some infection there in the OPD, and if the patient has been complaining of pain, we don't want surprises inside the OR. Am I right here, sir?
Absolutely.
We have to, in these cases, wherever there are previous metal, and then plan our surgeries accordingly.
How was the lateral condyle in this?
So I am the operating surgeon. So this is coming from my unit, so I am the operating surgeon. So yeah, the lateral condyle was absolutely fine. So
will you consider a partial in this?
Partial in
UK.
this?
Because I have done some old HTOs who don't have sagittal plane deformities, or a slope is not altered, and there is no, like you rightly mentioned, the old closed wedge osteotomies had a three-dimensional problem, but here it looks pretty okay. So probably just remove the two screws and give a conservative sort of surgery.
Would have done that. I have still not done it, but it is, I'm waiting for it to do that. Okay. But the problem that comes to the mind, like in this case, was, one, I was not happy with the tibial slope. It was literally like a reversal of slope boiled down to zero. The next thing that you see is the implant. Implant is actually coming in my way. I could have just removed the screws and we've done few cases. But in this particular case, even the plate is very high. So with the cut, the plate would have gotten exposed. So that is why the implant has to come out. Otherwise, we've done cases now where we've not removed the implants, just pulled out a couple of screws and we are out. So let's see what was done. So that's the post-op X-ray. Any comment, sir? So Amit, you wanted a longer stem to bypass the last screw. That is there. That is there. That's the PS, because PCL was definitely non-functional, so I had to sacrifice. I didn't have a choice. Sir?
Instead of removing, just cut the upper part of the plate, couple of screws, leave them lower down.
I am waiting for the hospital to buy me the Midas Rex, sir. My problem is that I would have loved to do that. Anything else? Next.
So post-op care where immediate post-operative physiotherapy was started and patient was discharged on the second post-op day and patient was given IV antibiotics. This is a post-operative follow-up of 4 weeks where a patient has no FFD and the range of movements came to 120 degrees. This is a video.
Okay, so that video is basically at 4 weeks, she could get up from a sitting position unaided. So that's stability part, nothing else.
This comes the final alignment of SKA where MPT is 91 and LDFA shows 94, whereas decreased to 2 degrees.
Okay.
And in this discussion, conversion of failed H2O to robotic assisted TKA is technically challenging the primary TKA due to changes in mechanical axis, tibial anatomy, and ligamentous imbalance. It requires surgical planning and attention because of the various anatomical deformities that occurs following osteotomy. Robotic assisted TKR in failed H2O could improve the mechanical axis, increase the accuracy of component positioning. It helps to deal with implants which are already in place.
Sir, one question, sir.
Yes, sir.
How do you ensure so good centering of the long stem? Because this is sometimes an issue when we do, like how you ensure a proper centering of the stem.
Sir,
it sometimes tends to go either way.
So basically, the first is the entry point. The pre-op X-ray has already told us where the alignment would come out. So with the pre-op X-ray and the calculation, then finding the middle point on the intercondylar eminence, I think probably those are the only standard. And the first reamer that goes in, which is like, let's say a thin, it helps us to know where the cortical chatter is also coming in contact.
You can, in tibial case, this, if there is, any doubt about extramedullary jig, you can use an intramedullary jig for this thing, which will ensure your central placement. Okay. Because as it is, you are planning for a stem, better put a intramedullary jig and take a cut. That will be perfectly centered.
Thank you.
Right, thank you so much. We have Dr. Mudassir, who's an associate consultant. Mudassir has his case on extra-articular deformities.
Good morning, everyone. My case is total knee arthroplasty in extra-articular deformity.
Wait, hang on.
My patient is a 55-year-old male, presented with a pain in the right knee and difficulty in walking for 4 months. So the patient has a history of gunshot injury to the right thigh 30 years back, sustaining injury to the distal shaft, for which open reduction internal fixation was done in 1997. The patient got the implant removal done after 2 years and sustained again injury around the same site, for which in 1999 he got operated with bone grafting. The final implant was removed in 2003, and for the past 4 months he is having difficulty and pain over the right knee. Examination finding: the varus is 20 degree, the FFD is 10 degree, and the range of motion is 10 to 120 degree. These are some of the clinical pictures. This is the walking video. Range of motion is 10 to 120 degree. This is the pre-operative X-ray, which shows osteoarthritis of the right knee with deformity over the distal shaft of the femur, both in coronal as well as sagittal plane.
Okay. Dr. Vaidya. Sir.
Yeah, so in extra-articular deformities, we should take the axis of the proximal or distal proximal in case of femur, and see where that axis is going. It is, if it is falling within the collateral attachments, then we can definitely, correct it intra-articularly. I'll be definitely using a robot in this particular case and correct it intra-articularly. So that becomes very simple, and you don't have to release a lot of ligaments to get it right.
You want to add something, anyone else?
So often one has to see how much exactly on those calculations and is the intersection point and the cora. And like he said, if it's within the collaterals, it can be done with a single stage intra-articular resection with a robot. It pretty much looks like this can be done with a single stage intra-articular with a robot offhand. But in general, for the femur, if you're within 10 or 15 degrees, then it can be managed robotically.
Okay.
Generally 20 degrees in femur and similar on the tibia has been the guideline.
Tibia
and
takes a little more.
Anything more than 15 to 20?
More distal is the deformity, away deformity.
I was waiting for this.
Yeah, so then it is easily, correctable from inside.
So here what looks like in an extra-articular deformity is any deformity which is far away from the joint is slightly easier to correct as compared to closer to the joint. And we have to plan beforehand that where you are, if you are doing it standard cuts, when you take a standard cut, is it violating the collaterals or not? Because if you feel it is violating the collaterals, then you have to think of something else. And of all the debates that we talk of robotic, no robotic, technology, no technology, Sir, Bharat sir actually on this floor agreed that probably extra-articular deformity is one where robotic and technology it helps. So so this is probably one scenario where technology and robotic per se actually helps. So let's see what was.
So the plan is to go, so the options we have is go for a single stage procedure, two-stage procedure. The single stage is intra-articular correction with ligament balancing, or simultaneously extra-articular osteotomy with TKR, and two stages extra-articular osteotomy followed by TKR later, and the role of navigation or robotics in this. So the challenges we had in this case was, this was a multiplanar extra-articular deformity which was closer to the knee with compromised femoral canal for jig placement and the femoral stem placement. So the plan we had before going was total knee replacement with the help of robotic and PS implant and higher constraint as a backup. So the advantage of using a robotic assisted TKR in this case is accurate multiplanar deformity assessment. 3D robotic modeling quantifies the extra-articular and intra-articular deformity precisely, avoiding errors from distorted canals and eliminating the need of intramedullary guides. The precise bone cuts with protection ensures the planned resection without breaching the collateral ligaments, maintaining joint line, obliquity and slope. Predictive soft tissue balancing and improved alignment and rotational accuracy. So these are the few. So we used a Mako robot for this, and these are the pre-cut resections showing the mechanical plan for this.
Okay.
This is a CT based, and the maximum flexion we could achieve was 143 degree. There was some, on the gap assessment, there was some tightness on the medial side.
So now we are looking at 16 degrees of RS, which is native, and 9 degrees of flexion deformity, FFDs, and which is correctable to 12 degrees. So this is not a very big one compared to the extra-articular deformities that we encounter. But the gaps and the mismatch is, when an extension is slightly lax as compared to flexion on the lateral side, and on the medial side around -5. So probably these are something which can definitely be balanced. So this is how the balancing page looks now, wherein we have a lateral laxity in flexion of 1.5 vis-a-vis 1, And minus 3.5, 6.5 with a slight reduction osteotomy on the tibia. And we are using a 3 degrees of varus on the femur and none on the tibia. That probably should be, go ahead. Next.
These are the bony resections.
So we have 4 mm of bone is being cut on the lateral side, tibia 2 and 6.5, 5.5.
So this is the trial. 145 degree of flexion could be achieved.
So that's the final gaps, where a final native of 3.5 degrees of varus and a relatively a very well balanced knee, intraoperative very stable, was achieved.
So what makes this case challenging and unique is post-traumatic limb with altered femoral anatomy, extra-articular deformity influencing the mechanical excess, the scarred tissue and potential altered vascularity, and need for precise balancing due to chronic medial tightness. The post-operative outcome and follow-up for the patient was painless, stable knee with corrected mechanical excess. The improved range of motion of 0 to 120 degree was achieved.
Next.
These are the post-operative X-ray.
HK. So that's the long leg film in a sagittal balance. So probably the role of technology is actually now is the sagittal balance that we were missing initially. And that is where it is now helping us, and with these extra articular deformities you can actually balance them very well sagittally as well. And that is where this patient ended up. Right? Yes. Right. I think probably that is what, I think we should give all of them a good round of applause for their presentations, and we can thank you so much to the faculty for being there.
Dr. Narayan Hulse sir, who will be presenting the talk on the art of science of gap balancing, navigating the challenges in the complex TKRs. Dr. Narayan sir.
Everybody, and at the outset I would like to thank the organizers, Pachure sir and Shalby group for having me here today. So already the show has been stolen by the Ramnik. He has discussed everything, and the cases of similar types have already been shown, so it's going to be easier for me. So what are those complex cases we mean by, in my own series, it's about 10%. So basically you can say that we need to modify the techniques, or you may need a different processes, or sometimes both of them. And the most important thing what we should understand is they can result in inferior result because of the technically demanding nature of these surgeries. So they can be severe coronal deformities, extra-articular deformities, chronic patellar dislocations, genu recurvatum, previous osteotomy, and previous incision scars and the soft tissue issues around the knee. So how do you balance these cases? It may be one of these steps. You do bone cuts and recuts if needed. Soft tissue adjustments, which we have already discussed so many cases, examples, change in terms of the constraint and the type of the implants, including the augments and stems if needed. Cement adjustments, questionable, should they be done or not, because they will change the mantle of the cement and also the quality and the strength of the cement and bone interface. Technology is widely debated, but we have just seen that some of the technology is probably mandatory in some of these cases. So we'll start with severe varus. We have already discussed about this. We have severe bone loss sometime on the medial side, and also a bone remodeling on the proximal tibia, adding to the proximal tibia varus that can cause problem. Contractures of the soft tissues on the medial side and subluxation, as you can see on the X-ray here. So the steps involved include extensive medial release. A standard tibial bone cut will add to a large bone gap. So you may not have enough poly to fill in. So you have to be really careful before making these bone cuts. So in all large deformities, remember that we have to have a very conservative cut, which was already discussed in the previous discussions. So the standard has been the deep MCL release and also the posterior medial release, which is required in around 71% of cases in that study, which has been mentioned down. Pike crusting very in small number and very rarely, and we discourage doing the distal MCL release. However, they have seen after like 3 years of follow-up, even after the distal MCL release and pike crusting, there was no instability in majority of the cases. So I think the medial release works well even in large deformed cases. This is one of the main important technique we have to be careful, which is we have to learn is about the reduction osteotomy. Reduction osteotomy is not removing the osteophyte, it is removing the excess bone after downsizing the tibia. For example, if it is compatible, you downsize from size 6 to 5 as you see in this example, and then take the medial bone resection so that the tenting on the MCL is relieved. Very important, if you over release you may need a constrained component. If you see this lady with quite a lot of varus, the varus thrust has been managed with the stem and the medial augment only. Similarly, another severe varus knee. This is about 48 to 50 degree of varus, lot of varus on the medial side, and you can see the long X-ray showing a HK of 133 and 127. So this was done robotically. As you have discussed already, under anesthesia when you do a correction, it come up to 23 degree on this screen. And after removing the osteophytes, you can see only by removing the osteophytes, we could get up to the 15 degree down, and the minimal bone resection was done. You can see in the planning page on the first picture, there is a bone defect about 15-20 centimeter, and that is why an augment preparation was also done. You can see the medial part is cut like an augment preparation. We have done that using the robotic for this case. And then a reduction osteotomy was done. Now you can see, after reduction osteotomy you can see the varus is come down to 9.5 from 15, and still you have 9.5 degrees of varus deformity which has to be corrected. That is when we progress to a medial epicondylar osteotomy after the trial component is inside, and that is how the medial epicondyle should displace. It displaces posteriorly, and you can see it displaces distally, making both flexion and extension space equal. Now you can see in the robotic the balance has come down to 1.5 degree of varus and almost equal gap on both sides. That is when we accepted that position and fixed that osteotomy using a couple of screws and a stitch. That is on the left side. You can see a long X-ray, the mechanical axis is restored, and the other, after 2-3 days she came back and got the other knee done as well. That is her post-op X-ray showing almost like 179 degree of HKA in about 2 months time. Similar, another severe varus, huge defect, a minimal bone resection was done. You can see here that instead of normal 8 mm cut, we have taken only -2 and then 12 mm on the medial side, making a gap of 10 millimeter on the medial side for the augment. See, normally we do the augment preparation using the intramedullary jigs. However, you see in this case, we have modified our technique and published this recently, how you can use the robotic technology even to prepare the augment using the slight modification in the protocol. There is a preparation of the augment, and you can see the final preparation for the components, and there is a final X-ray. So similar thing we have already discussed about the valgus knee. We have discussed all of that earlier. So couple of cases we can see. The lateral contracture you can see, we have managed that with a simple primary component only. This was again, you can see how the gap was balanced using the robotic technology. So another case which somebody has asked earlier in the discussion, in case if we can't get the stem in the middle of the diaphysis, what do you do? Especially in these kind of proximal tibia deformities or extra-articular deformities or high tibial osteotomy, etc., you may have to use one of these offset bolts so that you can transfer the tibial tray and get the tibial, the stem into the diaphysis in the center. Another difficult case is you can have these kind of old high tibial osteotomy done with a lateral closing wedge osteotomy. Implant removal and the extensive release needed. You have to be prepared for all this. It can be translated. You may have to prepare for the augment. This one you see the overcorrected reverse sloped high tibial osteotomy on the left side. Difficult knee. Again, using the same technique, we have used the offset bolt, you can see, and an augment preparation technique using the Mako, and then we have used the offset to get the stem in the middle of the diaphysis, as you can see on the left side X-ray. This is another similar situation. We have a previous unicondylar knee which is failed within a few days after the surgery. There is a proximal tibia fracture, you can see, done somewhere else, and then patient came to us. This was revised using again robotically, using the same technique. You can modify the technology little bit to get into the robotic registration and cut. Genu recurvatum, usually a neuromuscular issue should be ruled out. You may have to use a constrained hip. We have already discussed about the extra-articular deformity just now, and in extra-articular deformity we have to calculate whether we can do an intra-articular correction or we may have to do an extra-articular correction. So this was done using computer navigation many years ago, and this similar one case was already discussed. We have multiple exostosis, previous deformity correction, and a huge extra-articular as well as intra-articular deformity using a navigation technique which was done earlier, and that is the kind of correction we have got in this gentleman. So similar another extra-articular deformity, we have discussed this already. And another method, if you have these kind of implants, you can also use a PSI. Nowadays, because of the robotics, this technology is usually not required. These are interesting ones and difficult, they are rare. If you have an osteoarthritis with a previous neglected patellar dislocation, they are difficult. You may have to combine the alignment of the patella along with the resurfacing. Difficult case, previous patelectomy with a scarred patella with a lot of stiff knee, huge stiff knee with a flexion deformity of about 15 degree, further flexion is only 30 degree possible. We had to resort to you can see the tibial tubercle osteotomy to get into the knee, and we didn't use a stem because it wasn't required, and that is at about 2 months follow-up.
Full bend.
He has a cordyceps lag about 15 degrees, but he has developed a flexion up to 90
straight.
So neuropathic arthritis also a similar situation. Loose knee, you will have to use a hinge, and these are all difficult periarticular fractures. Hinge if needed, otherwise a constraint can help to get to the stability because of the lack of ligamentous support. Very rarely you end up with these kind of periarticular fractures, and this is one of the severe flexion deformity which we rheumatoid over 40 degree flexion deformity. We corrected preoperatively with a hamstring release, and then up to about 30% remaining deformity was corrected using the plaster post-op, and you can see that the deformity is fully corrected. This is in about 6 months time. That's how she was after surgery.
Okay.
Fully corrected deformity and doing well. To conclude, these are complex knees. We have to have plan and different technique plus the implants for this to suit the situation. Literature wise, we have a poor result, so we have to be very careful with these kind of clinical situations. Appropriate planning, inventory, skill and technique are important. Thank you very much. Thank you.
Thank you, sir, for such wonderful talk. We move on to our next very anticipated and interesting session, the art and science of the symposium 2, that is direct anterior approach symposium. To lead us through, I would like to invite Dr. Narayan Hulse sir. And I would like to call upon the podium our panelists, Dr. Vikas Jain, Dr. Kyle McGiven, Dr. Surpreet Bajwa sir, Dr. Ramneek Mahajan sir. Meanwhile, any question for the last session?
Meanwhile, the panelists are going on podium. Anyone want to ask any question regarding the last talk, Dr. Hulse sir? Any question from the delegation? Okay. So now we move on to the most awaited DA session, and I hand over mic to Dr. Narayan Hulse sir.
You said you have a question?
I was asking for...
Okay. Right, so the most important topic of the day, or the most latest topic of the day. So we have a DAA symposium, and I welcome all our important. So even though it is the latest approach to take off, I think this is one of the oldest approach as well. You can see that it started in 1881, and there is a description by the Hutter, and the interval is still called as a Hutter interval. So, however, it wasn't used much. Smith-Peterson is the one who used it for a total hip replacement in 1917, and later popularized by the Light and Kegi group, and they published also extensively using the direct anterior approach. But for many years it was remained dormant, except a couple of surgeons, the Jude brothers were using, and only I think the very few people were using it for a long time. And then this man, who is well known to all of us, Dr. Mehta, he is also a very renowned acetabular surgeon and also editor of the Latonal Jude textbook of acetabular fixation. He popularized this single incision anterior approach for a total hip arthroplasty in United States. And so the history, one thing is there are a lot of new methods, instruments came, and some of them simplified it. Michael Nogler, he started and published using the direct anterior approach even on a standard or a normal table. So with that, we will ask our expert panel, so why do you need a direct anterior approach today, with a lot of training, a lot of, residencies have been taught all of us with multiple approaches which we have been successfully using for so many years. Dr. Kyle.
Okay, yeah, that's great. So why? I think that there's lots of reasons. I think that the quick post-op recovery gets discussed the most. For me, I always fall back on patient position. So my main reason is supine position.
Early recovery, something which can get them to their office. Something, because each day lost is what they start counting. So that is where, yes, the DA helps. Take them back into office faster.
Okay, we got that point. It's because of the peer pressure and not patient pressure. Actually, I started that probably because of the patient pressure. Because you see, these patients are on Google, and they have gone all over the places, and some people come and ask for a direct anterior approach. Maybe that's the reason. And for you, when did you start DA?
I started in 2018.
2018.
And one of the things I would want to add is the supine position. And you can focus more on limb length discrepancy and other things rather than just quick recovery is obviously an option, but then posterior we tend to compensate. Many times when you're not getting a stable hip, you'll try to lengthen it, increase the size of the head, maybe go a +4 or something. But with DA, you'll get the component position will be perfect because the patient is supine.
Sure. So do you think the DA is getting more popular all over the world? We know that.
No, of course.
Do you think it's really because of the clinical benefit, or is it because of the pure marketing?
So both actually. I feel like patients' expectations have increased. It is an already successful procedure. We've been giving great outcomes, and I've been trained under people who've been giving great outcomes, but the initial functional recovery, like everybody mentioned, also with the demons of the posterior approach, you've got two problems with the posterior approach which were not addressed. It was one, the risk of dislocation, especially in young surgeons' hands, and the fact that LLD was also a cause of concern, especially in the West. It was the highest cause of litigations. So the West moved to DAA because of that. And we came in again because it was a marketing tool, but also because we have a young populace which demands initial functional recovery. We've got patients with AVN who want to sit on the floor, who want to do their day-to-day activities quickly, and it really helps.
Yes, before concluding this, for the first part, why the DA is becoming popular, if you see this slide, see there are a lot of similar small incisions came and a lot of new technology, MIS, double incision, so many things came in 2000s. And none of them have either become so popular, most of them they perished except the direct anterior approach, which tells us that there must be something in a direct anterior approach which stood the time over last 3 decades now, and only the direct anterior approach which remained, and it's becoming more popular and it's gaining ground all over the world, except all other, for example, if you think double incision, small posterior incision, so many things came and gone. And I think it is fair to say that a lot of pressure both from the marketing side and everything. Also, the direct anterior approach gives us a very good access for the fluoroscopy if you have to do an X-ray, and also great access if you want to measure the leg length, which is not possible with any other approach. The soft tissue sparing, debatable, but the scar size what we give after direct anterior approach probably is the best compared to any other approach which we normally practice. So, in 2018, this is one of the survey which opened my eye at that time. If there was a survey which conducted in American Association of Hip and Knee Surgeons, members were polled, 56% people were already using direct anterior approach, whereas the lot of the members, non-members who were attending the meeting were about 40% were already using. If you see the graph, that is the way the direct anterior approach has taken in that country. So in my journey, it's a little bit of a disaster. Started 10 years ago, too complicated, and my boss used to say that, never complicate simple things. So it was looking every time you start doing DA, and I think, you are complicating because you haven't learned properly. Probably the training was not enough. So the first couple of cases went well, but the training and mentoring was not good. That was the case in 2015. Bilateral, left side was bad. Normal table, you can see that the struggle, the bleeding. And that is how I finished my acetabulum. You can see that it was difficult. And there's so many screws in a simple case, oversized, it wasn't good. And the post-op X-ray, you can see that the trochanteric fly, it's broken, and which wasn't seen on the first X-ray, but you could see that later. So I, went back to my nice, well-trained posterior approach and got the other side done. This is 9 years now. Patient is doing well, but that is what I thought. It should not be like progress is man's ability to complicate simplicity. So it was simple, it was easy, and it was going well. So I have seen that, done that, and dusted that approach probably for many years until all this started again. The more literature came, the more surgeons, more evidence. And most important thing for the direct anterior approach, we all agree here is the issue with the training. See, you all say that the posterior approach, the direct lateral approach, they're all great approaches, probably because we have seen them, we have been trained with them for decades. And you start something new, it's always going to be difficult. For example, if someone is approaching a distal radius for the first time, probably they feel the same, oh God, where I'm going. And I think its most important part is that training opportunity, whether we do or not. Along with that, we started this robotic, the new era, and in 2022, that's after about 7 years, I did again a direct anterior, but this time we had a robotic. That was the first patient using robotic. Apparently, this is the first robotic direct anterior also in the country. So, but I started with another issue. You have a direct anterior approach to learn and also the robotic. So you have two learning curve to go through, and it wasn't easy. So again, start from the other end. If you are going to do a direct anterior approach and if you are convinced, how do you choose your first few patients?
Yeah, I think that's easy.
Yeah.
Skinny, female, with decent bone. So on the younger end, females and thin.
Ramanik, you want to add anything?
Agree with what he said, but at the same time, I would look at the greater trochanter. If it is outside the flare of ilium, that probably is my first patient that I would like to take in.
Valgus X-rays are much easier to do compared to virus.
More offset, more space.
Yeah. So the direct anterior approach, if you ask someone who is doing a lot, they would like to push you for everything. Remember that the people have done revisions, people have done all kind of complicated cases and revisions as well. But I think, if you are going to start someone, it has to be a very skin, lean in, less muscular and easier, less complicated. Something like, these avians we get nowadays, those kind of patients are easier. However, there is one common question asked in these kind of meetings is, will you do, if you get these hemiarthroplasties, so you get these bipolars every other day, shall we practice, direct anterior approach on a bipolar or a hemi thing? He's nodding his head, yeah.
Yeah. So my first case will never be a hemi. That's also because one, you've got weak bones, you've got osteoporosis, but also the fact that you're trying to push in a bigger head. So it's a definite challenge. Dual mobilities are challenging initial couple of cases as well. So stay away from NOFs for your first couple of cases. You don't want to fracture the femur and you don't want to struggle with pushing the head in. So, yeah.
So one of the commonest problem with a direct anterior approach is having a proximal femur fracture. And by definition, you have osteoporotic, these fracture neck femur in elderly. So we don't like to take that issue with the high chance of having a trochanteric fracture, etc. Another issue with the bipolar, in these kind of cases, if you try to do, is that sometimes they can be emergency, you will not have support, you may not have a friend to help you with. They don't come like an elective cases. So in the beginning cases, they may not be good one. However, the elderly patient also have less muscular tone. So it may be a little easier to retract, etc. So some people have done them, the fracture neck femur as well with the DA. It is not that difficult, but I think for a beginner, I think we will keep them away. So average weight, thin, average muscle mass, female, older patient, adequate bone quality, and idiopathic osteoarthritis are the best one. So the learning curve. So we'll start again from the other end. So there is a debate about the learning curve. The direct anterior approach, the main thing is going to be, the how do you deal with this learning curve, how fast we will learn, and how do you mitigate the problems with learning curve, and what do you think about the learning curve, how many cases, and in your own experience, how did you learn?
I'm probably the worst person to ask this question because when I started residency, I had 2 high-volume surgeons that I trained with that both adopted it. So their learning curve was my learning curve. So it was excellent. So I had a great experience.
So Ramanik, how many cases you think you need before you are very good with a learning curve?
So if you ask the people who've been doing it, they always say first 100.
Yeah.
Now gradually they're coming down. Somebody says 50, depending on how close you are, how you are getting trained. So average, what it was said was, you first go for a visitation or a fellowship, see, read, come back, operate 10 cases, then probably again try to go back and revisit.
Yeah.
Then the next time that you operate, you try to get that person in your OR or get somebody who's doing it to observe what you are doing, so to shorten that learning curve.
So the main thing to understand here is, you see, we have a less, the hip pathology primary OA in this country, and we don't get that many cases. But remember that hundreds of cases are needed before you are very good with direct anterior approach. It's between 60 to 70 cases in most of the literature that you need before you are very good direct anterior approach.
Can I add something? Can I just add something? Yeah. Here, for this learning curve, actually there's a very beautiful write-up by Neil Seth.
Yeah.
if actually somebody is interested in starting it, Neil has written step-by-step way for a learning curve. And it is point-wise, very elaborative, including how to train and then how to execute.
So what do you think, what in your practice you did, if you are doing other approach before, to become good with a direct enter approach so that they can learn?
So few of the things which are important is you need
Personally what you did, yeah.
Like I had a fellowship in Portugal, and that's how I started DA. Then I did a few surgeries, then we had some course with Stryker few years later. That's where we learned further and further. Apart from that, you need a dedicated team. All your team members should be the same, and they should be equally enthusiastic. Don't compare with the posterior approach. Even if you are able to finish a posterior approach in 30 to 45 minutes, a direct anterior will take at least 1.5 to 2.5 hours. You have to be patient. Keep it as a last case or a day where you have just 1 or 2 surgeries so that you are patient with the surgery and you are able to do it properly.
So what are the problems?
So my learning curve was quite brief as well because I was fellowship trained in the anterior approach in Australia. And what really helped was a cumulative of one, knowing how to do the approach, but also having the right instrumentation. So the learning curve reduced because we have access to the instrumentation. So in 2015, I'm sure you didn't have the appropriate instrumentation, and that changed for us. So that reduced our learning curve. So the initial challenges that I had was with the femoral exposure. I am a non-selective 100% anterior surgeon from the first day of my practice. So I've done high BMIs, and you struggle in those kind of patients. You struggle with the skin incision, you struggle with the LCFN injury. But those you can mitigate with, with a little bit of experience as well.
Yeah, so I think it's all very structured process and mentoring, which is going to be very, very important for the learning purpose. Otherwise, we are going to have problem because, we tend to say that I'm also doing direct enter approach, we have advertised, and, you get into the operation theater. I got a couple of horrible examples. See, the one guy was trying to do hemiarthroplasty using a direct enter approach. And young surgeon, obviously very enthusiastic, would like to learn and practice. So he started doing that with an anterior approach as a practice in an elderly lady. He couldn't reach the femur, obviously has not learned, he's only read some YouTube videos or something. And he has to turn the patient lateral and do the posterior approach to finish the surgery. He couldn't tell the patient that, I have done 2 approach, I had to cut 2 times. Look at that, how difficult it is. It is difficult. So he said, I put a subcuticular stitch on the anterior approach and put the staplers on the posterior approach so that the x-rays don't show that, there are 2 approaches. Look at that, the kind of thing is learned.
Lucky he knew the posterior approach as well.
So at least. So it's a structured learning process, and we all have to learn properly before getting into that, the difficult approach. So with that, we'll move on to the surgical technique. So from this end, there are 2 standard, the way of doing it. You do a table, or you do a on table, or a specialized table.
I have a specialized table. So I've been trained on a special table. I use the special table, and I've always been using the table. So
you just mentioned to us, what are the advantages of the specialized table rather than a standard table, which the other people will explain.
All right. So it's not a trade-off. It's just I have access to the table. One, the fact that what that table does, it reduces the number of assistants. It reduces the variables in terms of pulling and tugging of the leg. So there is a continuous force. The table is hydraulic in nature, so it helps in extension, external rotation in a more predictable manner. And basically has a few numbers which go around and tell you how much rotation you're doing, what extensions you're doing, what abduction or adduction maneuvers you're doing. So it's all in all a little more predictable than somebody else holding the leg, and if you don't have access to the right instruments, then struggling on 2 fronts.
You do specialized table or normal?
So I started with off table, now I shifted to on table. You need 3 things for the femur. You need hyperextension, second is external rotation, third is adduction. And table, it makes it much more easier. And you are able to do obese cases, neutral cases, so everything you are able to do. So that's why I prefer on table now.
Ramani?
So I don't have a table, so I used it off table on a standard
normal
approach.
table, yeah.
Normal table, we are happy with it.
I use a table, 2 different types. Yesterday, I was lucky enough to operate off table, which was a great experience, learning experience. I like the reproducibility of the table, standardization. and just we don't necessarily have the manpower in the operating room, so it takes out several people.
So there are specific things about the on table and the off table. If you are using a specialized table, the most important things to consider, it's very, very costly. You know, they are very, very costly, and you know, it's going to be like you purchasing another half robot. So they are costly machines. Second thing is that you need a specialized person to handle the table. So that is another issue, that you know, the guy who is holding the the foot end of the traction and adjusting the things has to be a technician who knows how to handle the table, because the surgeon is scrubbed. And the most important thing is, if you are using a specialized table, the leg is tied to the boots, and you will not have access to measure the leg length, etc., unless you remove the boot, or you have to use either you have the patella, superior above patella, etc. So you don't have an easy accessibility for the leg length measurement. Sometimes they can be cumbersome. That's what the people who use a normal table will say. However, with a normal table, it's very easy to measure all those things, including the hip stability, because the leg is free, but the positioning is difficult. You need an extra assistant for most of the situation. And the next one, the latest, is about the lateral position DAA. I think we don't discuss much about this. Some people have published on lateral position, but they go in the direct anterior approach on the lateral position. But this actually fails one of the most important issue or a benefit of direct anterior approach, because the fluoroscopy again becomes difficult because it's on the lateral position. However, delivering the femur, I think, becomes easier in the lateral position. That's why the people have started using lateral position. Another claimed advantage of lateral position DAA is, you see, we all have done the posterior approach or a hardened approach in the past, and we are very familiar with the orientation, the anteversion, the inclination, etc. So you can continue with the same orientation, so that you don't have to learn through this learning process of the learning curve of the direct anterior approach. So maybe that may make it a little easier if you do that. So these are the specialized tables, different brands available.
Just if I can add one more word, we have designed a table in the Indian context, which is much more cheaper, and you can use it for all the patients. So that's what I'll try to show in my presentation.
Sure. So there are a lot of such tables are available. This is another one of the few techniques which a lot of people have tried in the past. The elevating the femur out of the wound is a difficult thing. There are different kind of jacking the femur out with different kind of retractors, traction, etc. This is the one traction system we used to use in the past. But I think as you gain experience, most of them will not be necessary. The traction system, the lifting system, etc. will not be necessary. So this is our standard way of doing it now. The normal table, supine, both legs draped like a total knee, and table should allow the break at the anterior superior iliac level, and you should be able to hyperextend and abduct and externally adduct and externally rotate. This we have already discussed. There is nothing, substitute for a proper instrumentation. I think, for all beginners, or especially, who are going through the learning curve, and in fact, for anybody, even if you are experienced, these specialized instruments really make your job much easier. So this is I don't think we'll discuss much about it. There are two types. One is a normal longitudinal incision, and another one is the bikini incision. The first one is a longitudinal incision, and the second one you can see is like a bikini incision. Bikini incision is shown to be a little more cosmetic, especially in those people who would like to wear those kind of clothes. However, the interval after making these two incisions are same. There is not much different. I have done both of them, and if you are familiar with one, doing the other one is not difficult, and both of them are exactly same, except we'll discuss about the lateral cutaneous nerve later in the series. So this is the technique. You mark the anterosuperior spine, mark your incision. Incision is directed towards the slightly laterally, especially if the robotic arm has to enter that in. This is important. You don't get that nice picture every day on table. This I get, once in 100 cases. So the, superficial, the ascending branch of the lateral circumflex, you can see so nicely visible in this picture, but it comes so nicely only in the videos and pictures, not real. So the releases very important. So I'll again start from the far end. So the release on the proximal femur is quite important. If you want to give a couple of tips, how exactly you do, what structures you release, and what you don't release to the, the audience here.
Yeah, I think that's a great picture to illustrate. I like to go from obturator, kind of in the barrier of the trochanter, release the capsule off, right to underneath the piriformis to leave both those structures. It's about a 90-degree window, maybe a little, 80 to 90-degree window that elevates the femur up quite nicely.
Ramnik?
No, I probably agree. The first thing that I release is the capsule, and then the conjoint tendon. I try to save the conjoint and the piriformis, and in between the interval, it's that fat. The moment you see the fat pad, and you suddenly, it's that somebody is lifting it from the front, from the hook, and the moment you release the capsule and the pressure, you see that fat pad. You know your release is complete. The femur is actually off.
I think the superior capsule part is the most important. Once you release that, you get the femur off very easily, most of the cases. Otherwise, proceed more medially.
Yeah, so what's also important is not to release in this image, and that is the medial structure. So that's your external rotator. That is what gives the advantage to the anterior approach over the posterior approach. You don't release the external rotators. So don't release the obturator externus. It is just the tendon medially. Lateral to that, you can release the superior capsule up to the piriformis. But also the medial release at the level of the lesser trochanter is something I do as well. So it gives femur a little bit of buoyancy. And once you put a bone hook and your femur is buoyant enough and you see the fat come through, that's enough, and you'll be able to do your femur quite comfortably.
Perfect, perfect. So you have a hook on the medial side of the neck and try to lift it up. Don't try to force your Homan or these kind of retractors behind the trochanter and try to lift it up and break something. It's very important. So release starts from the pubofemoral ligament on the medial side on the lesser trochanter area. Do that, then that's the only way you can lateralize the femur. Getting the femur lateralized is very important. Then the superior capsule, the faculty has already just mentioned that this is the most important structure. Just behind that you have the abductors, you have to be careful. So some of them describe that as just a longitudinal incision. Don't cut that transversely. Longitudinal incision on the capsule so that you can retract the femur anteriorly. Very important not to release the obturator externus, which has a medial force and it prevents against the dislocation. You can see in that picture how nicely those retained tendons can be seen if you take a little time and do those releases very carefully. And then about the acetabulum, which is straightforward in this approach, you can see such a small incision is almost like twice the size of those retractors, but you can see the 360 degree. How many retractors you use for the acetabulum? Again from that side. Acetabular side, how many retractors, and where are those retractors?
I use one on the anterior rim and then one basically posterior lateral.
Posterolateral. Great. So see, we have got just the 2 retractors as well. Sometimes 3 retractors we put. One on the anterior column, very important retractor on the front, and it should be superior so that you will not cause, the neurovascular injury, which is inside the iliopsoas bundle. So you use some kind of periosteal elevator, like which goes on the anterior column, and your retractor should just slip into the anterior column, so it is safe. If you don't do it, it can perforate the anterior wall of the acetabulum, especially in the osteoporotic. Posterior, you can see that one. And on the medial side, if you would like a posterior approach, you can insert another Homan retractor as a reference on the medial side, which goes into the obturator foramen, like your guide to the teardrop on the medial side. You can do that as well on the medial side. So 3 or 2 retractors. So that was the interval which we were talking earlier. There's the neck and capsule which is exposed. You can see the nice glistening capsule incised. And a lot of us do this, a lot of things on this. We may not have so much of time, but the capsule can be either excised or in different way. We may have to suture it and retain them if you want to. You can close it at the end of the surgery. Some people do this napkin ring osteotomy to remove, dislocate the head, but not everybody will do that. Some of them also dislocate the hip even before doing the neck osteotomy. But reasonably, it's fair to say that you do the osteotomy in situ, take the napkin ring, decompress, then extracting the head becomes easier. This robotic thing, I don't think we'll have to discuss that now. And at the end of the surgery, if you have maintained the capsular stitch, you can close the capsule and come back. The skin closure is easy. So releases we have already discussed. So these are the capsular flaps which we have retained anteriorly and posteriorly with those stitches. Capsular stitches also help you to retract when you are doing the acetabulum or reducing the femoral head. The assistant can hold the capsule posteriorly, anteriorly, which creates a track for the reduction of the head. So it's it helps in that way as well. Now this is the issue, and this is the issue for the busy surgeons and all aspiring surgeons as well, the busy surgeons as well. So how is your surgical time currently? After how many cases?
So 45 minutes standard surgical time. It started with 2.5 hours, to be very honest. And it was about 20-25 cases. You get used to the instrumentation and the assistant, the leg positioning man. So, yeah.
Whatever. We are able to finish in 25 to 30 minutes, mostly bilaterals. We have done more than 1,000 cases now. So
2 to 2.5 hours the first case with a trochanter fracture and a wiring. So all those things were the first case. Now close to 1.25, 1.5 hours still. That is my challenge in a busy practice.
What about?
Probably around 40-45 minutes, depending on patient. 5 minutes shorter for someone small, 5-10 minutes longer for someone large.
So I can ask Ramnik,
deformity.
because he has done a lot of the hard hinge as well, and you're so good with that approach, you finish quickly. Do you think, in terms of the operation theater utility, will you ever reach that level with a direct enter approach?
Never. See, the time that I take and the number of cases that we do, the word that he used was the OT theater utility. Supreet sitting here is still talking of an hour, 1 hour, 10 minutes, and 45 minutes, 1 hour, 10 minutes. And a Harding I finish in 25 minutes.
And I think the posterior and Harding approach, about 35 to 45 minutes is reasonable, and 1 hour to 1 hour 15 minutes for a DA is reasonable.
And the thing is, we still mobilize them same day.
Ramnik, if somebody who's been doing a DA, for example, all the time, they do your hard hinge, they take 2 hours as well.
That's true.
Which is
That's
okay.
the point. And
Now,
the point is consistency. Sorry, sir.
It's okay. The time is not that important. That we have to do the job properly. We all agree. And we have to learn properly, and some of us are a little quicker, some of us are not that quick. So this is my own audit.
Just one question to add. Do your patients have less pain the next day with anterior?
Yes.
That is the advantage, that's what.
Less
Even
pain.
if you're
It's the
taking
same.
one.
It's the same. I'm telling you, even the Harding, the anterolateral that we do, same. And right now, as I speak, I have 5 hips in the ward, of which 2 are DA, 3 are Harding. My boys cannot tell the difference. I do not tell my physiotherapist what is what.
It's very true. That's what the literature says also. There is no answer yet, which is better, which is not better. The pain depends on several factors, how they are, both physical, psychological, their wound, and what medicines you have given, how are they, so many things. So it's difficult, and there is no answer in the literature also yet, so we can't really argue and win anything on this. So we don't do
the functional outcome really depends at what stage you're in your learning curve. I mean, if you're still in your learning curve, then, and if you compare one approach to the other, fair. I mean, you're going to get equal outcomes.
No,
but,
and also
but if you are ahead of your learning curve, and I think we've crossed that barrier, we do get superior outcomes, and there is no doubt about it. And the literature actually supports early functional recovery, which is,
So
which
you
is what
compare with.
You also have to have
compare with. Because you don't do Harding, you don't do posterior, then what do you compare with?
That's the point. So when somebody who's in their learning curve compares it
gentlemen,
with posterior.
I got more slides. So we'll wait a couple of minutes. So
Talk for the evening.
This is my own audit kind of report. Started with 3.5 hours, and everybody in the OT, everybody hated me that day. Until then, they were all like, "Oh, this guy will come quickly and finish off and go." 3.5 hours, anesthetist hated, etc. Now we do most of them within 1.3. However, you see, the most of on average, it has become almost an hour, which is reasonable and not bad. So this is another issue. radiation and fluoroscopy, we use probably little more than what is needed because it's easy to do fluoroscopy in this approach. So you guys have to be careful with the radiation hazard. These orthopedic surgeons, we know that we're all little, careless or sometimes can be nearly arrogant that we don't use this radiation protection so much in the OR, and we keep getting these instances of radiation injury and the oncological issues in so many orthopedic surgeons in the country currently. So I think we have to be really careful with that. So I used to do like 15 image, to start with, and some of the time even without the lead gown, etc. So we have all stopped all of that. Now the imaging has come to 0, especially because we use robo. That is one of the reasons it has come to 0. But I can do a nice DA without robo, only with the 2 images on average. Trialing also we have stopped because we have robo. We don't have to do trial and waste time. Acetabulum we rim only once. No trialing for acetabulum in 90% of cases. So all these things have really helped us, to reduce that. Percentage of cases used to be 90% posterolateral and very small hard hinge earlier. Hard hinge I used to do for the fractured neck femur because it didn't want to reach the posterior scar near the gluteal area for infection. Now we are doing almost 90% DAA in all cases. This is one controversial thing. Again, which stem you use with the DA and why do you use them? Is there any specialized stem you have to use for the DA?
I don't use a specialized stem. I use a proximally porous-coated dual taper wedge. That's my stem of preference for any approach in primary hips.
And another question is a collar stem needed or has it got any advantage for this purpose, for the direct anterior approach?
In my opinion, it has 0 usage.
Next.
I would probably say any stem can be used, dual taper, triple taper, and that is what I would say. Versus collar. The problem is collar came in and is got fashioned because the DAA people were getting 2-point fixations. They were not getting the 3-point fixations, and so to prevent that, they started relying on the collar.
So
but
the problem basically
is the collar needs to be taken out of the equation in a collared stem as well. Correct. A stem has to be press fit with 3-point fixation, then your collar is just sitting there.
So there have been certain studies which mention that triple tapered stem with collar are comparatively better when you're doing the direct anterior approach in comparison to the flat tapered. So that is one of the points where I am shifting more towards collar.
Basically 2 things we have to consider here. The longer the stem, it's difficult to insert. So if you have a shorter stem, probably it's easier in a direct anterior approach, but at the same time, the stem stability is important. It is not that easy that we will put a smaller stem in. Second important consideration is we know that direct anterior approach traditionally had a higher proximal femur fracture intraoperatively. So one of the few studies have shown that if you have a collar, probably the periprosthetic fractures are little less compared to an uncollared stem. Robotics and fluoroscopy, we have almost touched upon that topic, so we don't discuss. Complex cases, as you gain experience, you can do. This is one of my cases with a flexion deformity of so much. With a fused hip, you can see that, which we did again using robotic and direct anterior, not a bad scar. Bilateral we started doing now. And this is one of my patient with a posterolateral scar on the other side done by somebody else and a DA on this side. And that used to be my standard scar. The scar sizes have become really, the good for most of these patients who keeps comparing from patient to patient. Even in a heavy patients, 90 kg with a kind of deformed head, we were able to manage a normal THR. The elderly patient, we started moving on and started using direct. See, this is a radiologist, a doctor himself, with a bilateral severe OA following an AVN many years ago. Did the bilateral, you can imagine that like a mirror image on both sides, we got it done. And that is the 11th day after surgery. You can see the wound is not fully healed. And this is doctor from another state. You see, is walking so well. And that is the last time I saw him. You all know that the doctors are not that good patients, so he never came back for the follow-up. But we assume that he's doing good because he's not come back. Anybody with problem will come back. So these are all, I call them as my DA warriors, all young patients with some kind of AVN, etc. And a lot of them have bilateral hips, and you see they walk like a normal person. So out of my first 100, no dislocation, no deep infection, common peroneal, the cutaneous nerve, we're done with it. And there is one, you can see that one complication, the wound complication we had, we thought it must be an infection looking at that wound. However, I excised the scar and then it healed up nicely. So this is one of those complications which I had, was a tip of the trochanter. Because of the inadequate release in first cases, it's healed up nicely. So the last line, if the faculty would like to add anything before we close.
Yes.
From that side, yeah.
I
Final
think
message.
The initial point about hemiarthroplasty is very, very true. But if you're trying to get through that learning curve and you're someone who fixes a lot of femoral neck fractures, I advocate for total hip arthroplasty in those patients. After you get through your first few patients, even osteoporotic people, performing a total hip anterior helps you get through your learning curve and increase case numbers.
Ramanik, last line.
So I would probably say, busy practice, keep it the first case, and don't post, if you can, don't post anything, or post it on a day when you don't operate.
With DA, the learning curve might be difficult, but once you cross that curve, it's really good, is what I think.
Do what you do best.
So I have got a last something to tell is that, you see there are nice posterior, lateral, all kind of approaches have been developed, and the patients do well with any approach. So there is a patient on another side, even though you have your fancy new approach, the marketing and everything, and I think you should do the hip with the best approach rather than experimenting on them. If you are trying to do a direct enter approach, go through the steps which we have discussed, that the learning curve is large, the mentoring, the learning, the training, the most important part. Thank you very much. Thank you.
Can I ask you one question?
What? Later or now?
No, right now.
Okay, come on.
In your first few cases, or in your OPD now as well, okay, do you counsel your patients for complications?
Complications? So we do.
No, so when you sit in their OPD and you start telling them that the complication rate with DAA probably can be this, vis-a-vis posterior, which you have been doing for so long, what would your patient choose? So you don't tell them?
Honestly, you see, I have a group of patients, who come to my OPD sitting in the Bangalore. They all tell me the complications, even if I don't understand some of them. They have read so much and they have come to me. We have a standard protocol. It's all written. It's all typed with the percentage of all complications written up in a page, and we'll give it to them and ask them to sign. Because you see, later on they may say you are not told this or that. So we have a full page with all complications written up with percentage and signed by them. Thank you.
Thank you. Thank you, Narayan sir, for this wonderful session. And I would extend my thanks to all the panelists. For the next talk, I would like to invite Dr. Vikas Jain, who will be presenting learning curve of DAA, how to shorten it intraoperatively, challenges in DA, exposure, retractors, and tips avoiding common pitfalls. Dr. Vikas Jain.
So excellent talk and excellent symposium. This is what I would want to start with, the why, what and how of DA, continuing our previous talks. So this is the part of my conversation. Why do I do DA? What can be done with DA? How to proceed? I'll give you 7 tips and tricks to avoid the common complication, and then the conclusion. So this is the part of why DA. Bilateral hip, 15 days after surgery, walking comfortably. Sitting cross-legged, sitting on floor, a lot of Indian patients do require it, especially from the periphery. The third thing, I think Dr. Rangneek might agree, posterior patients might not do it. So this is a case of bilateral total hip replacement done. He has a high hip flexion, all range of motion, much better with compared to a posterior approach. I am not feared of the amount of flexion or anything my patient is doing, because I'm sure what I'm doing during the surgery is more important than after the surgery. The same patient after 1 year, that's how he's walking now. So why do I prefer DA is one of the important things is leg length equality. The patients do have early recovery within the first 6 weeks. Patients are able to leave walker within 4 to 6 days. They do have less post-operative pain and zero restrictions. You can do bilateral hips. For ankylosing spondylitis and even for cases like Parkinsonism, DA is much better. Data can be constructed like 0.7% anterior dislocation versus 1.3 in posterior. But remember this, in posterior, you're also giving a lot of precautions. And in direct anterior, you're not giving precautions to the patient. So we have done around 1600 DA cases overall from 2018. We had 2 dislocations so far. I started with 2.5 hours, 2 hours, 45 minutes. Now we are doing in 25 minutes. Most of the cases I'm doing are bilaterals and 99% are DA. So what can be done? Over the course of time, you can do all the cases. There is no limitation. There is no restriction about the cases. This is what we did this week. First case was ankylosing spondylitis. The right hip was in internal rotation, yet it went ahead with DA. Patient has a bilateral hip fuse and bilateral knee fuse. The second case we did was, this was 15-year-old operated DA case. Right hip was operated. He had a 22 head. He dislocated multiple times. We went ahead, we did a revision, acetabular revision for the right side. It's a multi-hole cup. And at the same time, we did the opposite hip with a primary. And this is a patient just next day after the surgery. So with DA, even revision, the recovery is much faster, is what I believe. I have just recently started with revisions over the past 3-4 months. This is what the case we did the other day. The patient had a head injury, C566, 1.5 years. He had limited restriction. He was on physiotherapy. And there was a complete fusion. As you can see, we did the left side. And the anterior calcification was at the iliopsoas and the anterior area. This is a huge chunk of bone, like a bar of soap. It was that huge. This is the amount of movement he had initially. There was no movement at all. And this is just after the surgery, just around 80-90 degrees. Around 80-90 degrees, and we have to do the opposite hip even now. Patient. So yes, you can do all the cases over the course of time. This is what my sequence would be if I'm starting with DA. Start from primary, valgus in thin patients, female patients are better. Then normal to overweight patients. Varus cases you should choose later, start with valgus cases. Then you can start performing bilaterals in a single sitting. Then move over from complex primaries, ankylosing spondylitis, heterotropic ossification, and you can consider revisions as well. But this is a sequence which I would like to follow. So how to make the DA curve easier? The 7 tips and tricks, because we hear about a lot about the complications. So it can be performed on all the tables. What you need is femoral hyperextension, adduction, and external rotation. This is what my first case was, a hemiarthroplasty, right leg amputee. So I thought there is no risk, I might as well do it. We tried with the purist for some time, and now we have designed our own table. We just need the hyperextension and adduction. This is the position you exactly need. We normally cover it with a steroid layer. This is just for the image. So how to choose the right patients? Indian patients are actually good patients for DA because we have thin lower limbs, we have less muscular patients, and we need floor activities. Young muscular male patients would be the ideal, would be the most difficult cases. Elderly patients and osteoporosis have high risk of fractures. So incision, coming to the incision, vertical incision and bikini incision, both are good. Vertical incision has a much easier learning curve compared to the bikini, so that's what I would start with. This is how the vertical incision looks, and that's how the bikini incision looks. Flex the hip, palpate the ASAS, just go 3-finger press. You see the red muscle, that's the tensor facial artery, incise it in the middle. You retract the fascia towards the medial side, then the lateral side is the muscle, then you come across the femoral vessels, ligate it, and you can do the capsulotomy. Most important thing is the instrument which we have already discussed. These are the 4 things I would definitely want: a double offset broach handle, long prong Mueller retractors, and DA specific retractors. So this is what I would want during my surgery. The number 3 is the most important for me, and number 1 and number 2, the offset handles. Acetabular preparation you might do, it might be easy, but taking out the femoral head in Indian patients with a thick LT is a bit difficult. So this is what I do normally now. Do a capsulotomy, put your retractors, take a curve osteotome, go between the femoral head and the acetabulum, reduce that vacuum. Once you are done with that, you can easily extract out the head. So this is what I'm showing over here. Just put in a retractor and put a osteotome, reduce the void, and just take out the head after taking the cut. For the femoral preparation, what you need is hyperextension, external rotation, and adduction. You can go from posterior lateral to midline. Double prong mular retractor is the most important. The second takeaway is to avoid GT fractures, you should take multiple box cuts. Try to take multiple box cut. If your first rasp goes in easily, you won't risk having a fracture. So these are the releases which have already been talked about. Lateral to midline is what I preferred, not at the obturator external muscle, superior capsular release, and then the medial side, the calcar side. You can use the double offset broach handles as well. The last thing what I do is I check everything on table. I'll do hip flexion, extension, abduction, adduction, internal rotation. So if my hip is stable in external rotation of 90 degrees and hyperextension, I'm sure it will not dislocate. So this is what I would be doing in the end. Once I'm done with the surgery, just 1 second. So this is just the last slide. Yeah, I've done the reduction. You can check the flexion, extension, abduction, adduction, alki-palki position on table itself, squatting on Indian toilets, and namaz position, because this is what the patients need. I have checked on the C-arm, the leg length, and other things, which is what I would do normally. And this is how you can do the leg length if you're doing off table. So to conclude, DA does have a steep learning curve, but the benefits DA do benefit the patient much more compared to the outphasing, the challenges you're facing as a surgeon, be it leg length discrepancy, recovery, or stability. Thin and lean patients would be the ideal to begin with. Double offset broach handle and retractors are helpful. Special table you don't need as such, but it can help initially. You need a proper patience, proper setup, persistence, and teamwork is important. With experience and time, primary as well as revision scenarios, you can definitely do with DA. Thank you.
Thank you, sir, for such nice demonstration. For our next talk, I would like to invite Dr. Surpreet Bajwa for the direct anterior versus posterior approach, who wins in 2025.
All right, so my name is Surpreet Bajwa. I'm a hip and knee replacement specialist at Wokhart Hospital in Mumbai. Everything's been spoken about anterior approach, so we are going to be data-driven. Everything that I talk of in these 15 slides is going to be data, meta-analysis from 2023 to 2025. These are my disclosures. I'm a consultant for Merrill. I'm a consultant for IoT. I have my own practice, but my biggest disclosure is that I have a bias for DAA, so don't blame me. I got trained under my bosses in Australia, and my journey was from posterior to a hard hinge, and then to something called a superpath, and then moving directly to the anterior approach. So that's what I was through. What matters to us and our patients is very important, and we've seen look at 8 practical parameters which are not. So I'm going to go after them one after the other, and hopefully we'll come up with a statement to confuse you a little more. So, instability. My biggest reason for shifting to the anterior approach in search of my training was the fact that the anterior approach has next to 0% dislocation rate. So in my practice, I've had 1 or 2 dislocations post-traumatically in those patients, but nothing with just patients walking out of their rooms. So I'm very, very happy with my dislocation rates in the anterior approach. But the meta-analysis also says that the dislocations are far lower in the anterior approach when you compare it to the posterior approach. And now this does not include which surgeon and what level of training. This just is an overall parameter. Infection, similar, but slightly lower risk of infections in the anterior approach when compared to the posterior approach, but more or less even Stevens on this scale. The risk of periprosthetic fractures is a lot more in the anterior approach when you compare it to the posterior approach, predominantly because we tend to struggle with our femoral exposure, and because of that, we tend to undersize our stems. This is where collars come into the picture, but that's a talk for a different day. But that's where DAs have definitely more risk of femoral fractures when compared to the posterior approach. We have our fair share of LFC and LCFN injuries. These are usually neuropraxias and they're reversible. I have seen my fair share of sciatic nerve injuries as well. I do acknowledge that LCFN injury are more common. They're reversible though. And also seen that sciatic nerve injuries are a devastating complication, although we give the lead to the posterior approach by now. PROMs. All major registry data, including the Australian and the Swedish registry, have started talking about PROMs right now. And early PROMs are quite remarkable with the anterior approach. This one patient has undergone a bilateral total hip replacement, and this is day 1 in the hospital. Yes, it is better with the anterior approach when compared to the posterior approach. However, I must acknowledge that the long-term outcomes are the same. Anterior and posterior have the same long-term outcomes. But early PROMs, definitely in the meta-analysis and in my own private practice as well, it's better. As a result of better PROMs, as a result of preserving a lot of muscle, you tend to have a lower length of stays because the pain scores are better. And if you follow the ERAS protocols, your pain trainings and not otherwise. Another debate which is important to all of us, the operating time. Yes, DA takes much longer in our initial journey, but what's important is that extra 15 minutes, is it worth it for your patient? And I count myself on that parameter, and I say that that's important to my patient and that's important to me. So I'd rather spend that extra 15 minutes in my theater, give them a better initial functional recovery, and let them be happier in the longer run, just like any other posterior surgeon would. After 100 cases, you're on par with whatever your next door surgeon is doing. So that's even position is a little more difficult as well. It has been eased out because of the availability of equipment and instrumentation, but you have to understand that you've learned the posterior approach through your fellowship, through your residency. If that's your workhorse, that's the best you can do, and you should stick to it. DA has been improved a lot because of the utilization of fluoroscopy. I've used fluoroscopy in all my cases, and I've done about a couple of them in the recent couple of years. The outcomes are very good. The cup positioning is very good. The stems are not in varus anymore, and that's because you are able to see the outcomes on table, which you couldn't as easily in a posterior approach. You can take an X-ray even in the posterior approach, but it's a little more cumbersome in the posterior approach. Rate of transfusions, pain scores, and opioid consumption in the anterior approach much lower in the earlier window, again as a result of not cutting or dissecting much tissue. But the parity is, even Stevens at 12 months. However, the cost of initial equipment, the table that I use or the retractors that some of us. So who wins? You decide. You decide your surgical approach, you decide what is best for you and for your patients. If it's worth it spending that extra, couple of minutes in your OR, it is worth it. Now, is the training cycle worth it? That is something that you have to decide. If you're at a center which supports the anterior approach and your journey of transiting, which has the right instrumentation and is willing to support your fellowship journey, go for the anterior approach and start off with simpler cases. Otherwise, stick to the workhorse, stick to the good approach that you've been using, and it will give your patients the outcomes that they deserve. These are my references, and thank you very much for your attention.
Thank you, Dr. Supreet, for excellent presentation. Our next session is Relive Surgery, Direct Anterior Approach. I'll invite our moderator for the session, Dr. Narayan Hulse sir and Dr. Supreet Bajwa sir.
Okay, so to start, patient position, supine. I come in initially for a fluoroscopy shot. I think this is one of the most important parts of the case. This is a patient, he's got a shorter varus neck, had a hip on the other side, but this is establishing leg length, offset. I tend to call leg length hip length. I think that, leg length discrepancy that arises in the distal femur, the proximal tibia, the ankle, doesn't need to be corrected with hip arthroplasty. If there's shortening at the hip itself, I think that's correctable in surgery and will match to the other side. Or in acute collapse, to pre-collapse leg length, but don't like to change more than that. So this is what I keep on the fluoroscope as a reference toward the end of the case. Initial surgery, I do basically 2 finger breaths, lateral and distal to the ASIS, and come down through subcutaneous tissue until tensor fascia is identified.
Do you change the position of that incision, proximalize and distalize it with varus and valgus necks?
I don't change it. I like to angle in line with tensor fascia. And later, I use straight instruments for reaming and cup impaction. So that basically just matches where my inserter handle is going to go. Incise tensor fascia in line with the fibers. I just like to bluntly finger dissect out, and then I'll find the superior neck. As soon as I find, palpate that space on the superior neck, I insert a curved cobra there, multiple retractors. You can use a standard Homan, so there's nothing really out of the box there that's different. I like to pull back the tensor and pull back the upper part of the rectus with Hibbs retractors or Meyerding retractors. There's a layer of deep investing fascia that's just above the circumflex vessels. So I will cut that first and then pull the rectus back. And I think that lets you see that circumflex. I don't know how well this will come through, hopefully well. That's that first deep investing layer. You can see the rectus poking through there. As soon as you pull that back medial, then you're able to expose those circumflex vessels and always identify those. That's an important pearl when you start is blood loss. I think it's initially, as people are learning a bloody surgery, you see there, I was a little bit careless. You can start to see it bleed, but quickly identifiable and cauterized. As soon as those are finished, I basically cut through the vessels, and then I'm looking to the inferior aspect of the neck. Oh, that was horrible. There we go. Looking toward the inferior aspect of the neck. I take another cobra and just kind of wipe that pericapsular fat. And then I'm on the inferior aspect, have good visualization. I actually like to grab the right angle and feather reflected head and iliocapsularis up toward the upper portion of the acetabulum. I know some people like to take a cob to elevate that. I find if you're fairly meticulous with elevating that anterior retractor can be placed a lot safer. You see there I've placed that. I like to use more of a blunt tip thin retractor just to avoid neurovascular injury and place it in a safe spot. You're looking down on the capsule, good visualization. I do an H-shape capsulotomy first. I do protect the superior leaf, but to be resected later, and then I'll resect the inferior leaf. So I do a 180-degree capsulectomy. I've gone through stages where I've repaired for a while. I've settled on this. I think it's nice with reduction. It stays out of your way. And I've had periprosthetic fractures that I've gone back and revised. And there's a good scar layer there that's almost not completely reformed, but a version of an anterior capsule. Enough of solid tissue that I think it provides added stability anteriorly. Identify the neck cut. I make that in situ. I do not do a napkin ring. I think a little pearl is that superior portion of the neck cut to not go too deep because there's a bleeder back there that is frustrating as you're trying to get the head out and then to find it and cauterize it, especially early on, that can decrease visualization. I use a corkscrew. He was a little bit of a shorter neck. Normally the head will spin if you have the power, if you have it on ream instead of drill, and the head comes out fairly easily. He was a little bit more difficult. but obviously still not too much of a struggle. This is where I'll insert the hibs back and take out that superior leaf of capsule. I just find that with the capsulectomy, it's easier to do it now, and then when I go to do my release, there's more of that out of the way, and it's just a little bit more efficient. Once that is out, I will make a little notch where I want to insert my next retractor right on the kind of posterior lateral edge next to the labrum of the acetabulum, and then put a cobra retractor in to follow. Then I take a large bent Homan just for visualization here to take out my labrum, and then take out pulvinar. You can ream through all that. That sets my medial wall and kind of gives me an idea of depth. Following that, as I'm putting that medial retractor in, I'm looking for osteophytes that I like to take out before I ream. I think there's there's pulvinar coming out. And then that's inferior labrum. That's just a still shot of taking out the medial osteophytes. And then I like to use a straight reamer handle. I do ream with more introversion and inclination than what my cup goes in. I think one of the reasons I don't like offset is because I think you keep a good hemisphere and you don't make an eccentric ream. And if you have a good hemispherical ream, a hemispherical cup will be impacted even if you're changing your inclination inversion. So there's a straight handle for the cup. I do a bit of a twirl to get the soft tissue out so you're not having to hit it too hard. I loosely impact my cup until it starts to grab, and then I'll come in and just do a quick fluoroscopy shot. I like to make sure the pelvis is level, shoot the middle, push in. I tend to be 20-40 on probably the low end of 20. Once the cup's in, I replace that anterior retractor. I think another pearl is when I'm bringing in fluoroscopy for my cup, I take out all the retractors so I'm not pulling the pelvis and rotating. And then for liner placement, you have good visualization. Make sure all the soft tissue is out of the way. I also failed to mention that the initial fluoroscopy shot, I will match the angle of the fluoroscope to my standing radiograph that I have from clinic. And I think that takes out a lot of the hip spine problems that I feel like it's very important, but it gets a little bit overanalyzed. If you just match it to a standing position and position your cup relative to that. So now we're starting the release. So the leg has been extended, adducted, and externally rotated. I'll take a suction tip and not pull up too much initially just to do my standard release. Once that's completed, I take a bone hook. I put it inside the canal and hook on the thickest portion of the calcar. Even in softer bone, I found that to not cause any issues with stress riser, chips and bone. You kind of see there going more vertical, like we were talking about earlier. To not continue it across, you can start to violate abductors if you're not careful there. So then bone hook goes inside the canal, and I think you'll see here, I'll pull on that. It's not quite coming up. I hope that comes across. There's just a little bit more, and then that femur should just pop right, there you go. And that's the fat that they're talking about. The femur pops right up, and then you're through. So once that's been completed, leg drops, goes over, 2 retractors in, 1 over the trochanter. I use a similar, both that double prong. I use a longer double prong over the trochanter and a shorter double prong on the medial side. Normally when I do my capsulectomy, I get that medial release. If not, this is a portion where I'd release that a little bit to place that retractor. I do like to use a canal finder initially. I think with version, especially as you're starting the approach, that gives your brain an idea of that canal orientation. I don't use a box cutter. I use an initial long kind of canal finding, lateralizing broach, and then a shorter lateralizing broach, with thinking the back corner of that stem to be posterior lateral. Sometimes if there's harder bone, I'll take a rongeur and I'll bite that posterior lateral bone out, and that helps you lateralize with the broaches. Also like to start the broaches a little high initially, and that just helps eat away the bone. And you see there, I just use an anterior offset broach handle. I think speaking to periprosthetic fractures, one of the largest reasons for anterior hips, not only is there the learning curve, you know, when people are learning, they're gonna have more periprosthetics, but we're introducing this double offset broach, and you're losing force with every offset. It's changing your vectors. So you're hitting a broach a lot harder than what you're used to, you know, if you're a posterior lateral surgeon. So I think that using that single offset is helpful. You see reduction with the trials. Going back to that, you know, the image that was on the right side of the screen, you can match up. You like your leg length, you like your offset. Bone hook on the neck to dislocate. I always put my thumb in and hook the rectus. That helps that head from getting caught. It's kind of a little pearl is that head can get caught underneath the rectus if you're not careful, and it can track superior, and you're gonna be calling your friend who's a general surgeon with your tail tucked. So don't do that. I've not called a general surgeon, but I've been sweating bullets before. So that your trial implant's out, as long as you like your fluoroscopic image, retractors back in. At this point, obviously, if you need to change anything, try to avoid too many reduction and dislocation as far as time, but I would say in the beginning, that's okay. This is the point, I'm gonna pause it for just a second. To the biggest benefit of anterior surgery, you know, you see your trial broach right there on fluoroscopy, and when you're starting, you're gonna have a stem that's undersized, maybe a little bit of varus, but you can correct it. And you're correcting it with the trial on a very reproducible fluoroscopic image, and you can change that. So that's my argument against collared stems is, in my opinion, there's no reason there because you know that you're gonna fill the canal, you have an image, and you can change it before final implants are in. So broach out, final implants in, you know, you're staring down, make sure that your implant seated good. I like to slightly lateralize the first impaction to make sure it's clearing everything before I impact directly in line. And then head on and reduction. Go back to see the same things here. It's you know, clearing your retractors and then making sure that the rectus is clear of the head. So whether it's someone pulling on the leg off table or raising the leg with the table, it's similar motions. Not much changes there. Make sure you visualize once the head in that there's no soft tissue. If you're someone who keeps the capsule, I think this is a point where I've seen x-rays where people had the inferior leaf of the capsule and the head sitting eccentric on that last fluoroscopic film. So, I mean, we all know how x-rays, you know, you can only see what you know that you're looking for, and that's something to pay attention to on that final shot, is to make sure that the head's sitting concentrically. So you kind of see that, you know, as it comes over the top and pops back in, like the image is, and then you're able to shoot, you know, make sure everything fills the canal. You see that's a stem with a reduced distal diameter, so good proximal fill, and overall good result.
Amazing. So the preserving that capsule on the front probably will help you in that the trial reduction. Capsule, if you can preserve on the anterior aspect and use the stay sutures on that. Some people use a ethibond, some people use some fiber wire or something of that kind. So you can have a traction on the anterior capsule, and when you're gliding the head inside for a trial reduction, it just goes into the acetabulum without escaping into the anterior aspect. So some people say the preserving not just for the capsular preservation, but also it will help you for the retraction on the front, if you would like.
It's you know, the natural version of a hip skid.
And the second aspect is the reduction, trial reduction of a direct anterior is slightly different from a posterior approach. Ideally, you should not be using those, you know, the head pushers, and you should not be using too much of force to reduce the trial reduction. Because if you do that, the hip is too tight, and dislocating the trial becomes impossible. So it has to be either it goes with a thumb, or you know, you don't reduce the neck size or a head size a little more, and then go back in. Because we have seen the situations where the head is stuck in, the trial head is stuck in, and people are not able to get it. Because the anterior hips are slightly different than, you know, when you do the posterior hip and use a big head pusher or something to push that in. So it's important, unless you know this point, you will try to reduce a large offset or a larger head and put that acetabular trial inside, and you will struggle really to remove the, redislocate the trial, and it becomes a real difficulty. And the one point you just mentioned is that the trial head can escape either on the iliac side or intra-abdominal sometime, and you have to be extremely careful. So you have to remove that head before the leg goes back to the position again, the external rotation and adduction. When it is straight, when the neck is still seen outside the wound, you remove that before that head escapes into the soft tissues.
I think that's a very good point, and a coordinated effort between who's ever running the table or is providing traction and rotation to the leg, that you have to be on the same page.
How many assistants you normally need? A scrub nurse and 2 assistants, or 1 assistant?
I have 1 assistant across my table holding retractors,
Yeah.
An assistant just above me, and then someone not scrubbed who's running the table.
A scrub nurse separately or no?
Yes.
No, 3 of them.
Somebody on the back table.
Yeah, and while preparing the femur, you stand, or your assistant on the same side at the surgery, is he caudal or cranial to you? On the right side or on the left side when you're operating left?
The assistant's cranial to me.
Yeah.
I'm below the hip.
So you're hammering that way?
I've done both. In fellowship, we were always above the hip,
Yeah.
hammering down, which is much better on your rotator cuff.
Yeah.
In private practice, just my setup and the way to get in, get out, I stand below, and I'll probably have a torn cuff in the next 5 years.
What about these self-retaining type of retractors for the hip?
Yeah, so that's an addition.
Self-retaining type of retractors, when you are doing DA, you may be able to reduce the number of the assistants and also the cumbersome, mobility.
Even a regular Chanley's, actually, if you preserve the capsule.
Sir, please summarize, sir.
Yeah.
And you would just be able to pull the capsule away and put your Chanley's and just pull it, and it just exposes everything. And you don't need any more retractors for the cup or for the stem. I mean, except the ones that you put in on the medial side and the superior side. So I do that. I have a Chanley's that I've designed. It's carbon fiber, small Chanley. And it just pulls the capsule. You put it inside the capsule medially, put it inside the capsule laterally, and yank it open. It just opens the whole picture. You don't need any more assistants. So I have just 1 assistant, 1 scrub assistant, and 1 leg man for the table. That's it.
Yeah, self-retaining's good. I've operated with people who've used Wiltzies to do that. I think that a Charnley with a wider footprint is better, because I've seen those eat through the tensor, and you end up with 2 halves of tensor after the case. Yeah, absolutely.
So thank you very much. Amazing. Thank you.
Thank you, sir. For the next talk, I would like to invite Dr. Rajesh Malhotra, sir, for the topic Practical Application of Spinopelvic Principles in Difficult Primary THRs, Case-Based Discussion.
Good afternoon. It's a pleasure to be here. And I'll be talking about some of the concepts. Some of them I'm sure you are conversant with. The others may appear a little new, but I think it's important that you understand. Have you started? No, second, not the first. First is the case discussion. Yeah, that one. So this is a chapter Larry Doe wrote in my book, and he said the causes of failure have remained the same or the different in the 20 years. And the most important, or what we used to call unclear etiology for instability, probably is spinopelvic. And we know the instability is the much of a problem. They have a lesser risk of dislocation. But then if you are stiff, that is the problem. Also, you must remember, because I said it's about the spine and the hip, the pelvifemoral parameters also change. I mean, that's quite intuitive that your angle was called a pelvifemoral angle. The angle between the pelvis and the femur also changes when you are standing or you are sitting. So 4 pearls I want to tell you. One is everybody has his own pelvic incidence, right? And that determines the lumbar lordosis and how much of change will be there. The second is that the spine, pelvis and hip movements are synchronized to allow hip to move freely through range of motion and prevent impingement. And third, like I said, hip movements are closely related to instability after THA. That's the concept of CSI. Let me give you an example. If you have an ankylosing spondylitis, it's got a bony ankylosis, which is in external rotation. This patient is never ever in his life going to dislocate posteriorly because he's fixed in external rotation. And he'll never have enough internal rotation to dislocate posteriorly. In fact, David Beverland said that when he is got a patient on the table by posterior approach, he measures the internal rotation, and if the patient has excessive internal rotation, he'll give extra anteversion, because after all, it's the movement of the femur which will drive the femur out of the acetabulum. So don't just keep on thinking about acetabulum, think about the femur movements as well. And then the most important is the functional safe zone, which will put to rest all these controversies. So you have a pelvic incidence which looks like this. From left to right, there's an exaggerated lumbar lordosis. So the person on the right will possibly might come to you with a spondylolysis or spondylolisthesis, and the one on the extreme left is actually a hip user. So this is a hip user or a spine user, inadequate movement of the spine, and because of that, this anterior impingement, and they get osteoarthritis and posterior instability. The spine users get all these spondylolysis, spondylolisthesis, and lumbar spondylosis. The next is, so that brings to us the concept of combined sagittal index. So this is what happens, then as you age and the spine becomes stiff, you start getting late dislocations. But this is the concept which I want you to understand. It's called combined sagittal index. And that's a figure which you arrive at by adding the pelvifemoral angle. That is the angle between the middle of the S1 to the center of the femur, center of the hip, and then the axis of the femur, and that's in the blue, and the anti-inclination, which is a combination of anteversion and inclination, which is in the green. You add these two, and if you are in a certain limit, which is the 203 to 233 in standing and 162 to 198, you will be stable regardless of whatever component position you have got. It is actually been validated. So how can you recognize that a person has a mobile hip and a stiff lumbar spine? I just told you that a stiff spine guy will move his hip more and more, and these people are called hip users. So how to identify a hip user? A hip user has a hip user index, which is in sitting and standing, what is the change in the pelvifemoral angle, and divide that change by adding the change in the lumbar lordosis to the pelvifemoral angle. So it is as a percentage of the pelvifemoral angle and the change in lumbar lordosis. And if it is more than 80%, this person has a stiff spine and he has been using his hip. So this is an example of a hip user. He change in the pelvifemoral angle between sitting and standing is 41 degrees, and the change in the lumbar lordosis is 8 degrees. So 41 divided by 49, it's 83. So this is a person who has a stiff spine and he's a hip user. So one broad screening test is actually to look at the balance of the spine or the alignment, and which means that normally I told you the pelvic incidence approaches the lumbar lordosis. If the difference is up to 9 degrees, it's acceptable. If it is more than 9, the spine is not balanced. So if the spine is not balanced, then the range for the combined sagittal index becomes narrower. Instead of 203 to 245, it becomes 215 to 233. And this is a paper we published, actually quoted very often, one of the popular papers. And this talks about the concept. So let's go back quickly to the fact that when you stand, your sacral slope should be more than 30. When you sit, it should be less than 30, period. That if it's not that, there's something wrong with the spine. We have talked about the degree of mobility, but I'll define the pathological stiffness as less than 5 degree change and dangerous if there is 5 to 10 degree change between sitting and standing. And that happens, like I said, not only after spinal fusion, but also after lumbar spondylosis. And second is, look at the difference between the pelvic incidence and lumbar lordosis. It should be less than 9 degrees. Why alignment is important? Because when you have loss of lumbar lordosis, it actually leads to thoracic kyphosis, pelvic retroversion. The hip looks flexed, but actually is extended, and the knee is flexed. So that is the kind of disturbance in the posture which occurs. And because the pelvic incidence is more of a spine surgeon's definition, we use functional pelvic plane, which is a line joining the two ASIS, the midpoint, to the pubic symphysis. And we see its angle with the vertical, and that could be actually the anterior pelvic plane, like it's seen here. That's the anterior pelvic tilt, or it could be posterior pelvic tilt. So that is the other thing which you need to understand. So what happens if you have normal mobility and normal alignment? You can just put them in normal position. If you have abnormal alignment, you have to see whether the pelvic is tilted anteriorly or posteriorly. If it's tilted anteriorly, usually it's because of hip flexion, which becomes all right. If it is tilted posteriorly, wait till shows that it is more than 13 degrees. 13 degrees is the magic figure, and in that case, you reduce the version. Dangerous stiffness can be with the normal alignment or with the altered alignment. So again, if you are stuck sitting, which means the lumbar lordosis is obliterated, you decrease version. If the lumbar lordosis is exaggerated, you increase version. And this is the algorithm. It also talks about the hypermobility and the kyphosis. I'll just talk about that in a short while. So talking about hypermobility, that is known to resolve spontaneously. You must remember that. And also remember kyphosis. The patient may have a big kyphosis, and that can dislocate anteriorly. So you need to reduce anteversion in a patient with kyphosis, and usually these patients have a high BMI and they have less flexion less than 50, or also sometimes the neuromuscular imbalance. So that is, again, you have a risk of putting them in high inclination or putting them vertically. So you should put dual mobility in a kyphosis. And pathological stiffness, of course, needs dual mobility. So this is very simple. This is fan classification. Just remember one thing. If the spine is flexible, put it in normal position. Do not worry about 2A, because that 2A is anterior pelvic tilt because of flexion deformity, which will disappear after you have corrected it. So if the spine is flexible, put it in normal position. If the spine is not flexible and the lumbar lordosis is exaggerated, it is stuck standing, so increase anteversion. If the lumbar lordosis is obliterated, it is stuck sitting, reduce anteversion. So that is a simple thing. Now let me show you some cases, as Dr. Pachore asked me to. AV and left hip, 45-year-old female, normal mobility, normal alignment. Just put it in normal position. This is the EOS, which actually gives a great opportunity to measure all these pelvic femoral angle and indices. It can calculate everything accurately and reproducibly. And see the CSI, it is 228, well within limit, stable hip. Another example of 40-year-old hip arthritis. Now this patient has anterior pelvic tilt, but the normal mobility is there. So it's like 2A. Don't worry about it. Just put it in normal position and the patient is happy. 45-year-old male with ankylosing spondylitis has dangerous stiffness and is stuck sitting. You can still come out with a normal cup without using dual mobility if you see your pelvic femoral angle and alter your anti-inclination by making sure that the CSI remains below 235. This is another patient with ankylosing spondylitis, has pathological stiffness, less than 5-degree movement, and this was treated by dual mobility because that's the kind of patient I would not take any chance. 35-year-old patient with hip arthritis, hypermobile, reduce anteversion like I told you, and the patient remains stable. 22-year-old hip arthritis, again, hypermobile variant. Hip was stiff, spine is hypermobile. We know it will resolve, but you have to keep the version low because this is what happened. Dislocated anteriorly. I had to go back in and reduce the version and it became stable. But hypermobility does resolve in most of the cases and the only predictor was the presence of contralateral hip osteoarthritis. Then the hypermobility will not resolve. Another patient, 45-year-old ankylosing spondylitis, and he has kyphotic deformity, and as we decided, there's a high risk of dislocation. You can use dual mobility or normal one. Remember that that Victor showed that even by using the dual mobility, he had 6.8% dislocation. And I think if I were to go and visit his cases again, I would probably find that it was outside the CSI acceptable range, which actually even the dual mobility didn't prevent the dislocation. So this is what I did. I put it a normal porous cup, keeping the cup in retroversion, and ensured a safe zone of cup replacement because CSI standing was 2.0, and then was in this kind of fixed pelvic obliquity, you have to equalize the limb length by equalizing the apparent length. So you try to shorten the left side and try to lengthen the right side to get some apparent length equal because there's no adjustment, and this is how it was done. The last and most important thing is functional safe position, which is actually the personalized component position. So this is a lady, 65-year-old, who had a T-lift surgery, and we did a direct anterior approach robotic. And when you do the VROM, the virtual range of motion, it shows you at what movements there is impingement. And in this case, there was impingement with 28 head, with 32 head, and 36 head. And then in the planning, I changed it to dual mobility, and it showed no impingement. So this live surgery was presented in Orthodome earlier this year. And this was the example of dealing by technology with the spinopelvic issues, where you use a direct anterior approach, use a robots, use the dual mobility to get the desired result, as has been said by Victor.
Sir, kindly summarize.
Yeah, this is the last slide. So this is the direct anterior approach, the robotic, and make sure that you have a dual mobility. So remember the hip movements, remember the knee movements, take into consideration what the changes are, and you will actually end up with a successful outcome, and CSA is a very useful tool for that. Thank you very much for your attention.
Thank you, sir, for such a wonderful presentation. Now we have reached our scheduled lunch time. So post-lunch, we will start at 2:10 p.m. So kindly finish your lunch and join as early as possible. Thank you.
Stability and weight bearing is the best stimulus for bone formation. Instability is the worst thing to form fibrous tissue and non-union. And you can see 11 years, though patient was elderly, because of the walking stability, there's absolutely biology is the most important key factor, and for that you must provide good stability and mobility alignment. Again, tibia fracture, same thing, good stability. Sometimes this is a 76-year-old patient, traumatic fracture, 7 years post-op, and best option to make the patient walk is a distal femur replacement and stability and good soft tissue balance. Spin-off, which was very common with mobile bearing with some laxity, which is not tolerated by mobile bearing. And this patient came to us with a locked knee, and you can see it was there for quite some time. It was impinging on the patella lower part, and there's a notch because of the repeated impingement, and post was also broken, and LCCK was good enough because MCL was intact and doing excellently. Now you can see this patient, there's a progressive medial bone collapse with a long stem, and progressively the tip of the tibial stem is cutting out the cortex. So very important is a medial column support, and the best option is all the augments are there. Bone graft can collapse, augments they stay. That is the biggest advantage of the using a augment which can form bone and better stability. And you can use the trial, and you can take intra-op X-ray with the trial of the trabecular metal and confirm the stability alignment. And you can see a long rod and trabecular metal augment. Sometimes the post gets broken because of the probably poly part, and there's an instability and demonstrated. Post-op enjoying 9 years. Late PCL rupture in CR knees. So many times there's a tendency of releasing PCL, and it can, one of the cause, it can give rise to, but the CR knee is, I think, lot of PS people are shifting to CR, and there's a more trend towards CR, but try to be careful about extra release of the PCL, which can give rise to rupture, and there's a reverse rollback. The femur goes anteriorly and causes instability. So, instability, flexion space instability, again the surgical error, soft tissue balancing not done, or, and you can see patient had a repeated subluxating, but patient came to us with a locked knee. The post went behind the bar, metal bar, and got locked and revised it. Excellent mobility, 7-year post-op, LCCK. Hyperextension, we have to be very careful, and mild hyperextension can be treated with a bigger post. And metallosis, some patient keeps walking on the plastic is completely worn out, and you can see a metal granuloma behind. You cannot remove that entire granuloma, but whatever metal it was there, because it is very adherent, but it's a 4-year follow-up, everything is stable. Faulty implant design, small post previous the thing, and that can give instability, late instability. So conclusion, pre-op planning is absolutely important. You should be confident during intra-op surgery. MCL lax but intact, LCCK can be used. Reconstruction of bony pillars, most important, because many times the bone is osteoporotic and there's a possibility of collapse, which I showed the column, and you can get a late cutting out of the stem like that. Trabecular metal is excellent, and there are many augments available. Use of shortest stem is important. Don't use too long stem. Offset stem improves the optimal lateralization and better patellar function. And see that patellar tracking is central. Thank you very much.
Thank you, sir. Any question from delegates and faculty? Okay. Thank you. Moving on, our next topic is symposium on the revision TKR. I would like to invite Dr. Hemant Waukankar sir on the podium. I would also like to invite our panelist for the session, Dr. Harbinder Chadha, Dr. Rishikesh Saraf, Dr. Gurdarshan Singh Nat, Dr. Sharan Patil sir, Dr. Kiran S. Chauka.
Right, thank you very much. I would like to thank the organizers, especially Dr. Pachore, Dr. Vikram Shah and his team for the invite. And I think next 40 minutes or so, we are going to cover many aspects of revision total knee arthroplasty. And we have an excellent panel here in Dr. Harbinder Chadha, Dr. Rishikesh Saraf, Dr. Gursharan, Dr. Sharan Patil, Dr. Kiran, and Dheeraj Dubey. I think we have only 5 here, so somebody is missing. Dr. Dubey is missing, fine. Right. So we all appreciate that total knee arthroplasty is a completely different ballgame as to the primary. And we have a variety. I think Pradeep showed some excellent cases earlier on. So I think in next 40 minutes, we need to extract all the information from our panelists or the experts here and get all the tips and pearls about the surgery. So these are the points on which we are going to discuss in the next 40 minutes. So let's discuss the approaches that these are the standard approaches that we all know. And but when it comes to revision surgery, the range of motion can be a huge issue. It's especially the knees that are stiff, say ankylosed, or very limited range of motion is a problem. So let me start on the left-hand side. What is the standard approach for your revision knee, and do you change that depending on the situation?
Hello.
Yes,
My standard approach is medial parapatellar arthrotomy only with quadriceps snip.
So quadriceps snip is standard irrespective even if it is fully mobile?
No. Not in that case.
Yeah.
In difficult cases.
Yeah. So I think we'll not pass on each question to everybody because it's understood that any knee that is, super mobile, hypermobile, you don't need a complete quadriceps snip every time. But majority of the times you do need quadriceps snip because that becomes a standard workhorse for these patients. And any other options for a completely stiff ankylosed knees? Do you do a turn down, or do you do a tibial tubercle osteotomy, Sharan?
I have done tibial tubercle osteotomies. It's really stiff knee and there's patella is very low down. Sometimes I've done the tibial tubercle.
So would you do a tubercle osteotomy along with the snip, or you decide that beforehand?
Beforehand.
Beforehand.
Yes.
Any differing views? Yes, please.
With gradual releases, if it is possible, we'll do it with that thing. Otherwise, obviously, when it is really stiff, with the quadriceps snip, and if it is not still able to bend or flex it, then I'll go with the tibial tubercle osteotomy.
Yeah, please.
I tend to also favor the osteotomy well before, and I will not use a quadriceps.
Yeah, but the biggest problem with osteotomy is that your mobilization protocol can change because you're always worried about the osteotomy giving way and the extension mechanism sliding proximally. So any worries on that front?
Yeah, but I think now it is very well described how we do it. There's a way of doing it and fixing it back.
Yeah.
By and large, it is a fairly stable fixation to mobilize them early.
Yeah, so quick pearls on the osteotomy. How long should the osteotomy be? Importance of soft tissue continuity on the lateral side to keep the vascularity intact.
Absolutely. So you have, it should be longish and narrow, and then flip it onto the lateral side so that the soft tissue sleeve is still intact. And you can pre-drill the hole so that you can fix it back.
Yeah, so your method of fixation is going to be screws or wires or both?
Screws is ideal as long as you're not using a stem down. Screws will work very well.
Yeah, lovely. Right, Rishikesh, what are your standard implant removal techniques? I'm just going to show you some videos here. Let them run on the side, side by side. So what techniques do you use? Do you use all of these or?
No, sir. Previously, I used to use the giggly saw, but nowadays I use double osteotomy technique.
Can you step down the audio there?
Multiple osteotomy. And the thinnest, from thinnest osteotome to the three-curve one we use, and slowly we punch it from both the side, medial and lateral side.
Yeah, so the aim is to preserve bone as much as possible, work in the interval between the implant and the cement, and keep most of the cement intact with the bones. So anything to add on those techniques?
I have been using very small, thin blade with the saw. It's working wonders.
Yeah, that reciprocating saw can be used, and
yes,
otherwise
the
old,
jigglies.
ACL tibial tubercle osteotomy saw blade, which is a very fine blade, which is just 5 millimeters wide,
Yes,
and that
yes.
works beautifully.
That makes wonderful, and it makes the things faster.
Yeah, absolutely. So on the femoral side and on the tibial side, any differing techniques? I'm just going to move on. So that's a double osteotome technique, just to show you how it gets done. And when it comes out, you need to be sure that very little bone comes out with the prosthesis. You don't want to see too much bone on that prosthesis. So on the tibial side, let's move on. Yeah, go back. Yeah, so on the tibial side, anything different?
I think the stacked osteotome is the best way to do it. And one needs to be, one thing we should never do it is lever it out.
Yeah, try to avoid levering because you will crush into the native bone, and that's a thing never to do. Right, so after the implants are out.
What I use is, so many times I use K-wise to enter.
Yeah, just to break that interface between the implant and the cement. Yeah. So we all appreciate that major challenge here in the revision TKR is the bone loss, and is the soft tissue incompetency with the bone loss. These are two major challenges that we do. I think the main concern is how we transfer load to the native bone, because you can't rely on bone at the level of the joint. You have to transfer load either through the metaphysis or the diaphysis or both. And what are your options for considering the bone loss alone? You know, given the choice, yeah, you can start on the left side.
So if the bone loss is less, so my preference is only metal augments.
Okay.
If the bone loss is more in the metaphysis, there's a lot of cavity defects. Then we
Okay.
have to use cones and sleeves. And
We will discuss that a bit later on. Sleeves and cones, we're going to have a lot of discussion on. So these are standard. Do you have any possibility of using allografts? Do you have available?
no, allografts are not available.
Okay. Not. How many people in the audience have allografts available to them? Okay, so less than 20%, I would think. Yeah. So not many in this country have allografts available. So you have to rely on either the freeze-dried bone that may be commercially available, or use the metallic options. So these are all the options that we are talking about: using augments, using cones, or using really big augments, as you can see. The maximum thickness of the augments that are commercially available today in some systems is at 15 millimeters. It used to be 20 millimeters in past, but no, 20 millimeters is no more available. So that is a limiting factor as far as the augment size is concerned. And these are the options that we are looking at. Let's consider the stems now. Stems are an important way by which you transfer load to the native bone. So I'm just going to give you options, and let's discuss what situations you use what. It could be smooth polished or grit blasted, which you would use for, say, arthrodesis, like a cam nail. That is never used in the TKR per se, but that's mainly used for arthrodesis. You can have a short stubby stem with 20 to 40 millimeters length, or a medium length with up to 100, and maybe long up to 200. And these are options. You can have fully cemented or only metaphyseal cementing. You can have straight or offset stems. So let's ask our panelists here, what are their options or standard options? You have, say, minimal loss of bone at the level of the joint. Your metaphysis is decent, like the picture I showed earlier. What would your options be in that situation?
I have been using only fully cemented metaphyseal cementing.
Fully cemented metaphyseal, so a short stubby kind of a cement. But again, are you worried that you can't really control varus valgus very well in that situation? Because your short stubby stem is not going to give you any guidance as to controlling that varus valgus. You're not too concerned in that situation.
Sometimes I use that if it is not stable or if it is not giving that stability. I just definitely go with the smooth polished long stems.
A well-fitting, smooth polished. So you need a good diaphyseal fit in that situation.
Diaphyseal fit.
Yeah, please.
I have a similar technique. I like to cement and then usually go down medium.
Say 100 millimeters?
Yeah, 100.
100 millimeters.
Yeah, 100. And I rarely, if ever, use 150. That'll be usually osteoporotic bone with cone support.
Yeah, Sharon.
Exactly the same. I go along with both.
Yeah. Any situations where you would want to go beyond 150 millimeters length?
I think if you have removed any implants, plates or screw holes, you want to bypass them.
Okay.
Very osteoporotic bone, then yes, but I won't cement it.
Yeah.
Because the long cemented.
It's a nightmare to take out if you have to. God forbid your patient comes back to you again. It's really you're cursing yourselves why you did it in the first place. Yeah, only situation I have found that you really need to even consider 200 is a tall men. Tall men with really large diaphysis, where even the thickest stem available, for example, Zimmer has 16 millimeters. 1600 even doesn't give you the diaphyseal fit. So you really have to go for one size bigger, and in that system, it's only 200. There are some systems available in the market that give you 150 option as well. So 150 option is useful, but otherwise you have to straight from 100, you have to jump to 200, and that gives you reasonable stability in the diaphysis.
One other situation is if you're revising it for periprosthetic fracture, you want to bypass that area, then that's another situation.
But periprosthetic fracture, you would again be fully cementing it, because there is absolutely no hold even in the metaphysis. So that would be, we'll come to that in a few minutes. So this is the zonal fixation that was described by Faris Haddad and his team. Reading Morgan Jones wrote this paper some time back, and another paper by Gil Scuderi. So these are the three zones of fixation that they talk about. In revision situation, right, let's talk about the level of constraints. Now implant choices are using a simple posterior stabilized or a CCK type or a hinge. Now, do you keep hinges as an option available for all your revisions, or you would choose that based on case-to-case basis? Let's start on the left side, yeah.
Always hinge should be kept as an...
so hinge is always as a backup option available.
Absolutely.
That I think gives you a good sleep at night before
Yes.
surgery, yes?
Yeah.
Next.
Same. I always have a hinge.
Yeah.
I don't, to be practical. If I'm sure the ligaments are intact, I don't keep a hinge because I use different companies and it's not logical for me to do that. But if I'm in doubt, certainly I'll have
But Sharan, with your kind of workload, I would expect that you would have a hinge as a backup option so that every surgeon in your setup sleeps well at night.
I mean, there's no question if you can have, it's ideal, but I haven't found it so difficult to...
Yeah, understand.
Yeah.
It's not required every time. Yeah, Rishikesh.
Depending upon the situation, usually I decide the posterior stabilized constant insert is available with Smith and Nephew. So if there is
so in-between option is available with Smith and Nephew.
So in most of the cases, we can manage with that. But if there is a more bone loss, ligament injury, definitely the hinge option is always at the backup, and we need it.
I try to use the minimum possible constraint which I can use.
Yeah, that's absolutely true. Minimum possible constraint, but would you keep a hinge available, as a backup option, fallback option? As plan B or maybe plan C?
Yes.
As the case may be.
I will keep.
Right, lovely. So let's talk about hinges for a while. I mean, there are two types of hinges on the market. Principally, they could be condylar bearing as 3 different designs you can see here, or an axial load bearing. That is like a link situation. Now, the completely different philosophies, and you would imagine that because axial load bearing happens in the link, it doesn't survive as well. But it has excellent track record and excellent, studies, papers available. So link survives as well as any other hinge available in the market. Any thoughts on the types of the hinges or any personal preferences?
There is a situation, I use a lot of axial loading hinges, but there is a situation like whenever there's a tendency for hyperextension, and that's not the place where hinges tolerate it well.
Yeah.
Hinge fails quite badly whenever there is a tendency for hyperextension. So if you're using an hypermobile or neuropathic joint of any kind where there's a possibility of hyperextension, I use condylar.
So in fact, some of the hinges that are available actually have a hyperextension bumper stop. For example, RHK has a hyperextension bumper stop there. But as you would imagine, this also will get worn out over a period of time if it is going to be knocked on every time you hyperextend. Yeah. Any talks on any opinions on the hinges? So what is your favorite hinge? Let's start on the left-hand side. If you have to keep a hinge available, what's your choice?
I usually keep a link hinge, axial load-bearing hinge, preferably.
So axial load-bearing hinge, like a link type, is actually the simplest surgery on, I think, in the revision arthroplasty scenario. It's absolutely simple because you have fully cemented the stem, and you don't have to bother about much. Only thing you need to be careful about is the rotation of the femoral component. And once you take care of that, because that is going to have bearing on the patellar tracking, but once you take care of that, is the simplest, no-brainer kind of a surgery. Yes, Rishikesh.
Depending upon the cost and affordability of the patient.
Of course.
So condylar bearing prosthesis is available in many Indian companies also, and cost is much less. So if patient is affordable or insured, then definitely axial loading. Otherwise, I use condylar.
Sharan?
Other than the link, I use Knowles.
Knowles.
Yeah.
Okay.
I use mostly the condylar bearing.
Condylar bearing. Okay. Only link. Only link? Wow. We got really people like simple surgery here on the panel. That's good. Right. Let's talk about the Knowles hinge here. Now this is supposed to be used with the sleeves, and I think important to discuss the differences between the sleeves and the cones. People tend to confuse the sleeves and the cones and interchangeability of it. It's completely different concept. I think it's important to point out that the sleeves that you have here, there are 3 rings that are supposed to have a good host bone contact. This is for uncemented fixation into the metaphysis. And these 3 rings I pointed out in yellow arrow and a red arrow. And unless you have good host bone contact in these 3 rings areas, you're going to have a problem there. unless you really fully cement this hinge, again, that is not meant for fully cemented use. So you need a good host bone contact of these 3 rings for the sleeve concept to work, because otherwise there's a higher incidence of sleeves being reported in the literature now, because it's a poor host bone contact and the sleeve gradually fails. Any opinions on the panel?
I agree. The smallest of the sleeve, 39, is completely cemented.
Yes.
Otherwise, the rest of all are uncemented. And you need a good grip, good hold for that to integrate. I mean, I know there is certain situations cones will be much better, especially in the areas where you can mix and match. Here you're a slave of the implant and you don't have offsets and stuff like that. But even the cones, if they're directly in contact with soft tissue, they can produce disaster situations.
Yeah, because
so you may have to cover it up.
you're supposed to cover it with the cement.
Yes,
we'll see some examples of that as you go ahead. Yeah.
So otherwise, for me, the workhorse has been sleeve, to be honest.
So sleeves and cones are not the concepts to be mixed together. They're completely different concepts altogether. Sleeve is a part of the implant. Cones is not part of the implant. Cone is part of bone substitution strategy. We'll show you some examples as we go along here. Let's look at some clinical situations now. Here is a patient who has had a bilateral unis that has failed miserably, and obviously fracture and collapse. And we're talking about the right side that is being done here. Yes, let's start on the extreme left.
We can just go for simple normal revision with arguments on the tibial side.
But I mean, if you look at the depth of that defect, how big an augment you're going to use?
15 mm and no?
Too small.
Yeah, then.
Yes, Rishikesh.
Yeah, converting the uni into TKR is always a primary TKR. And you can use the lateral side bone to reconstruct the medial side defect. And then definitely a primary knee, maximum you can add a rod on the tibial side, and that's all. This will be a primary total knee replacement, not required any revision process.
This is a 35 millimeter defect on the medial side.
Yeah.
Okay? As I'm showing you here, with the trial cut being done, it is a 35 millimeter. I think it's not shown there.
For me, this is a straightforward sleeve. Because whenever, I mean, the stability the sleeve gives is unbelievable. And I am very
You would
peaceful
have
with that.
maybe 75% coverage of that porous area.
That's good enough.
That would work very well. This, in fact, was done quite some time back. I think, Anyway, sleeve is certainly an option here. So what I have shown here is this is the biggest augment available here. So this is biggest augment, and underneath that augment, biggest augment that is available, I have bone grafted because it is, obviously primary bone is available here. So I can, multiple, bone grafts being stacked underneath and obviously have a long fitting stem here. So that is the way it was done. And this is a posterior stabilized knee. You don't, medial sleeve is completely intact, MCL is intact. So this is a posterior stabilized knee, and that is how it has been done. So any comments?
If cost is not a constraint, then the sleeve is an easy choice for me. It will do all of this quite comfortably without any problem.
Yeah, but Sharan, you wouldn't expect a constraint to be an issue here. I mean, this is like a primary knee, severe varus knee.
I'm saying cost is not
Cost is not an issue. Okay, fair enough.
So I'm also a little hesitant to use bone graft in a revision situation. The bone, the cement, the whole ecosystem for a good bone graft integration is slightly challenging. Depending on the quality of the bone, I prefer to use metal.
This patient is actually just 55-year-old, and obviously we had to reconstruct whatever it was possible. Right, let's look at some more. This is a patient who's coming up for a second stage revision, and this is the kind of bone graft you have medially. Now, as you can see, there is almost 30-40% circumferential defect on the anteromedial side. And so what are the options? Again, sleeve would be a realistic option, Sharan?
So this is one place where a cone would be a very good option because
I gave my hand away.
No, in any case, if you're talking, you're always talking about cones. Zimmerman.
No, I think it can be a personal choice for
Yeah,
many surgeons. So.
you know, I agree, but there is so much of exposed, and you don't have an integration capacity. It will go below the 3 rings.
Yeah, so
what
this
we
is,
talk about.
yeah, in fact, those 3 rings having good host bone contact is a limiting factor for the use of sleeves. And that I think has to be appreciated, because if you don't have that, you can have problems even with sleeves. So this is what I've used here. This is a trial cone in place, and this is the final cone in place, and this is what Sharan was talking about. The outer surface of the cone that is going to be exposed to the other soft tissues, you need to cover that with cement on the outer side. That is because it is extremely irritant to the soft tissues on the medial side. Especially with the exposed cone is a bad news for the soft tissues. So you need to really take care of that. And that is a postoperative X-ray of the same patient. Again, similar kind of situation with a lot of metallosis, as you can see. And at the end of the surgery, again, huge anteromedial defect and a similar cone being used here. You can never get rid of that black color of metallosis, and you just have to accept it at one point of time and move on. There is a hinge was used here because the soft tissues were not so good. Right, let's talk about cones for a little while. It has to be considered bone substitution rather than implant component. So that I think has to be understood very well. This lady, this is a patient of mine who I had done a CR knee, and 3 years later she fell down and came with a dislocated knee. Let's talk on the left hand side. So what are the options? The lady presents like this to your accident and emergency department, and your resident calls you with this X-ray, and what's your thinking now?
First, we have to temporarily reduce it and apply immobilizer.
Yeah, so reduction in A&E itself, yeah? It's simple enough. You just give a little pull and it slips back in place.
Yes.
Next, what do you do?
Then we have to assess for the stability, whether it is totally unstable or...
What do you expect?
I expect instability.
Yep.
So, after 3 weeks of brace, we may assess, and then we may go to higher level of constraint if required in this case.
Yeah, so 3 weeks of brace allow the soft tissues to kind of stabilize, because there's going to be a lot of edema with dislocation as well. Allow the swelling to settle down, and obviously you can assess it clinically, but you give a brace, and so long as there is no neurovascular compromise because of the dislocation, you just can observe the patient for 3-4 weeks and then go in. What is your option? What are you going to do there? If you're talking about revision, of course.
Yes.
Yeah, let me just show you what this is. This is patient started going into almost 30-40 degrees of hyperextension. And that is the kind of X-ray that you get.
So I think
what has happened here with the soft tissues?
Yeah, so soft tissues are totally gone. So there is multi-directional instability seems there. So
yeah, so posterior capsule is completely stripped off.
Yes.
Both medial and lateral side is probably incompetent
Yes.
as well.
Yes.
So what are you going to do? What revision?
My option will be hinge.
Yeah. Okay. Any other opinions of the panel? So I think these are the situations where absolutely there is no choice but to go ahead and revise this knee with a hinge. And most of the times, as we heard earlier, with hyperextension, being a problem here, you need to use a hinge that gives you a hyperextension bumper stop. And my choice in that situation is RHK. I'm sure link must be working as well as that, but I've not used link in such situations. My choice is RHK.
In fact, link doesn't work well in this situation.
Okay.
And the literature shows this is one situation the failure rates are very high.
All right. So according to Sharan, you should not, or literature, you should not be using link kind of a hinge in this situation.
Axial loading one is not okay.
Yeah, so axial loading. So that is what was done for this patient. In fact, this is one of the simplest of revisions that you can come across. All you need to do is take out the implants without compromising host bone. And because the soft tissues are all lax and it's not much to be done, you don't need any augments. It's a straightforward, simple implantation, taking care of the rotation, of course, of the femoral component. And a hinge is the simplest option, and patient can be mobilized really rapidly and really fast. Right, this patient of mine was involved in a road traffic accident, and this is the X-ray that she came to us with in A&E. And yeah, let's start on the left-hand side now. Yeah, what's your take on that X-ray?
We need to see about the osteoporosis, obviously.
She's
What's the age?
come involved in an RTA, comes with a bruised and swollen leg, presents to A&E.
What's the age, sir?
She is, I think, 65.
65, okay.
I've
Probably
done this knee just 3 years prior.
So what we can do is just try to reduce it and give 3 weeks of rest for that till the soft tissues settle down. Then
You mean you want to reduce the fracture?
I don't think it's possible because implants already there will be loosening of the implant.
Yeah.
It has to be explanted.
Yeah.
And long stem, you can retain the femoral component. Go with the long stem. Only tibial component can be replaced with constrained poly.
You know what the implant this is? This is attune. This does not have an option of constraint.
Okay.
Yeah?
Then we have to revise.
Yeah. What revision? What are your choices? This is a bicondylar tibial fracture. Both condyles are fractured. Along with that, you can see the fibular neck fracture as well.
Like
Yeah?
in megaprosthesis kind of thing.
No, I'm not worried about. I'm just pointing out the injuries there.
Yes, because
So bicondylar tibial fracture with lateral side also incompetent, medial side incompetent because of the nature of the tibial fracture. So what are your implant options? What is your thinking?
Definitely, since her age is 65, with such kind of fracture, we don't have almost proximal, somewhere 8 centimeter, 6 centimeter bone is not there. So would like to go for megaprosthesis kind thing.
Okay, let's have more opinions there. Yeah, megaprosthesis is one consideration.
I think the other consideration is to try to fix this and then allow it to heal, and then
Okay.
address it and see where.
How will you fix this? Because there is hardly any bone underneath the prosthesis for having any meaningful cancellous fixation.
Yes.
Even if you talk about double plating, even if you talk about double plating,
Since
you're not
I'm
going to have
going to-
any meaningful screw purchase in the proximal fragment.
Right. For me, I would just wait until this thing healed and
Okay.
treat it in a cast.
So wait for
Yeah,
6
until it
weeks,
heal-
3
and then-
months, longer?
I would wait 3 to 6 months.
3 to 6 months?
Yeah.
Okay. Sharon?
I think it's really a tough situation.
Yeah.
The way I would look at it is, I will definitely need the help of a good trauma surgeon to reconstruct the proximal tibia after explanting. And using whatever reconstruction is done, then the appropriate implants to get a stable fixation.
But are you talking about fixing the fracture or you're doing something else?
Well-
Or talking about revising?
Revising with fixing.
Okay.
Revising with fixing. I need to have some kind of a bone sleeve all around to do a distal fixation, but how long is going to be my metaphyseal sleeve? Will it bypass that fracture? There are all the considerations one needs. But no easy answers. Whatever you do, except like what Kiran said, a megaprosthesis is going to be a touch and go.
Escalation, yeah.
Escalation.
Yeah. Any more opinions? Yeah.
Sir, I will consider it as a bicondylar fracture of the tibia.
Okay.
And we'll put an external fixator, we'll put it into the traction, and that will reduce the fracture. Then we'll wait for another, say, 6 to 8 weeks. We'll let it consolidate slowly.
This
and then we'll
fracture
revise.
below the level of the tip of the tibial
Yeah.
component, how
Yeah.
long do you think this will take to heal?
So it will take more than 3 to 4 months to heal. Definitely it will take.
Okay.
Yeah.
So you think waiting for that long is a realistic option?
That will, with that we can just remove the tibia and we can go ahead with primary fixation, tibia with rod.
All right.
Which is available with Attune.
So fixation and what kind of implant? Nobody's talked about what implant you want to use when you do, say, revising the knee. PH knee, CCK type knee or a hinge?
I don't think we need to use more constraint because there is
See,
no
medial side could be competent with
Because
this long
the
tibia.
MCL
Lateral
needs
side
to-
is definitely competent because fibular head is gone.
Absolutely. There's no need for a larger constraint. That's not the, depends on how the.
No, but what I'm saying is medial side is incompetent, lateral side is incompetent, so why do you not need an increased constraint?
I think it's incompetent. It's still anchored to
Yeah,
the bone.
it is fractured, yes.
It's fractured, it's anchored to,
Okay.
as long as you can unitize it,
Sure.
there's no need to,
All
and
right.
depending on the
All
age
right,
of the
fair
patient
enough.
also.
Fair enough, yeah. Any further opinions? Or I'll go on to see what, tell you what was done. Right, basically the leg was grossly swollen, there were small blisters appearing, so no question of any intervention as of now. I waited for about 4 weeks, allowed for the swelling to completely settle down. My thinking here is that the proximal metaphyseal area of the tibia I cannot rely on for any implant stability or load transfer. So whatever load transfer has to take place is from a lower metaphysis to diaphysis on the tibial side. And with that in mind, whatever, I'm worried about the tibial tuberosity as well, because I suspected that, the tibial tuberosity could also be fractured and, in piece. So I'm just going to show you some pictures now. So this is how, was seen on exposure. So there is, you can see a lot of fractures here. And that is the way I'm trying to build up the bone on the tibias to see whether I can use a diaphyseal cone to build that tibia up. But even diaphyseal cone would not work here because that, it's, first of all, it was the very small diaphysis was remaining, and even the smallest of cones would not give me a diaphyseal fixation.
You got your famous stacked cone technique.
No, but even the smallest wouldn't go into the native bone.
Achha.
So even the smallest bone would not go there. So even I'm trying to put it reverse to see how it will go, but it doesn't go in there. So what I actually done is I have decided to go with a longer stem on the tibial side, and I'm going to fully cement that stem, entirely cementing the stem. Very few occasions where I entirely cement the stem. And this is with my trial component on. You can see how much, and even the tibial tuberosity fragment is loose. You can see that. I'm just holding it down with artery forceps. And that is the way it was seen with the trial component in place. This is after my implantation, and these fragments have just been put back into original place. And obviously a lot of fiber wire to get that tibial tuberosity sutured to the native host bone. And that is the post-operative X-ray of this patient, fully cementing the stem. And this is the hinge that was used. And that is the post-op follow-up X-ray at 3 months. The proximal area, it's kind of bypassing that fractured area completely, allowing the patient to fully weight bear because the load transfer is happening through the metaphysis and into the diaphysis of the tibial side. Any comments?
I think a great job done. No two situations will be similar. And I think under the circumstances with the given situation, a stable, mobile knee, the best you could do, I suppose. I think it looks excellent.
What would it would have not healed up? The tibial tuberosity, if it would have failed to heal, what would have been
the thing is, one thing I forgot to mention is I had kept the patient in extension for 3 months. I refused to allow this patient to flex the knee for 3 months for the tibial tuberosity. I have seen, as a surgeon, we are, eager to mobilize the patient rapidly, and in 6 weeks, you're trying to start bending the knee. I have seen these, tibial tuberosities giving way and failing, and the quadriceps mechanism just starts migrating proximally. So 3 months, there is no shortcut to 3 months time frame in that situation. Yes.
Sir, anyway you waited for 3 months.
Yes.
Then don't you consider that if you have waited before surgery 3
patient
months,
is weight bearing fully without flexing the knee from day 1 or day 2.
Yeah, that is okay, but non-weight bearing keeping a patient is also fair enough. If you
but you wanted not to operate for 3 months.
You put a
No, how would that be better than the situation she is at 3 months now?
Sir, you can come out with primary knee. You can maintain the femoral condyle as it is, and instead of tibia, you can attach a tibial rod to that. The bone is consolidated.
It's all crushed and mushy. Even at 3 months, you can see there is not really consolidation there.
I think at 65, keeping them non-weight bearing is a
She's kind of obese lady,
Sir, I just want to ask.
I mean, there's no perfect answer, I suppose, but success cannot be questioned, so it's been done very well.
Telling the megaprocesses was to mobilize her faster, 65 age, comorbidities will be more.
See, megaprocesses,
and range of motion will be from day 1. So
yeah, but
that
I mean,
was my intention of
a
saying
65-year-old lady megaprocess. See, I think my aim was to conserve native bone if possible, and retain that bone. I mean, if this proximal bone still might consolidate, and have some host bone remaining there. But yeah. When you talk about megaprocesses, you have to excise this proximal tibia completely.
That's only for proximal 6 centimeter, 5 centimeter. With at least we could have started with good range of motion, mobilized.
And even then you have to reattach the tibial tuberosity and all of that. So you are going to have take time to consolidate that as well. So it's possible, it's acceptable to do that, but it's an extreme step to do it. But having said that, just recollecting from my own cases, there have been fractures in this area, but not as comminuted as this, not as displaced as this, and I've gone exactly the same route and said, let's not do anything, let it heal up. And there have been instances when they've healed up and the prosthesis has been retained. I didn't have to do anything at all. But they're very mild compared to what we saw
this
here.
is right. So just one more example. Again, tibia fractured the way it is, and here I could use a cone and get away with a cone. That is how a cone was used. Just showing you the examples of that, and that is how that is the X-ray here. So I think I'll move away from this. We have just 3 minutes here. Just one more case. Yeah, so this kind of situation again, a periprosthetic fracture, a very low, elderly, low demand patient. You again fully cemented the hinge here, and that is really the option. I think, move to one last case here. Yeah, this lady, I think Dr. Pachore knows this lady very well. Her knee was done in Mumbai some 15 years prior. Revision was done 15 years prior, and she kept on postponing her knee until she couldn't even stand. And that is the way she is presented to me. This is almost 15 years after her revision TKR that was done. And as you would imagine, there is hardly any bone in the distal femur, and the bone quality overall is quite poor. Any comments on what? She's an elderly lady. She is, I think, 77, 78.
I mean, when the problem becomes too complex, the answer is more simple, I think. So, medial condyle, everything seems to be quite gone. And
yeah, I mean, this is the way it is. And two ice cream cones, not even an ice cream cone on the femoral side.
Absolutely.
So this is, I would treat this like a periprosthetic fracture, as I showed earlier, and would go for fully cementing the, stem on the femoral side. And because such patients who are actually low demand and want a quick solution to get back on their feet, and that is how it was done. Right, last 2 minutes, last 1.5 minutes. Any
I want to ask you the question, sir.
Yeah.
I want some experiences of well-fixed, uncemented stems to be removed. Steps.
Sent to your enemy. So those are extremely tough to.
Many cases where it took long time.
It takes a long time. You sometimes have to do a corticotomy as well, longitudinal corticotomy and this. So any questions from the floor? Let's have invite some questions from the floor. Just last couple of minutes. They are either stunned or.
No, one of the things which we don't pay enough attention into revision is to get the joint line in the correct place.
Yeah.
I think we tend to ignore that and see what's the best we can do. It's so important to have the joint line down, especially on the femoral side when you have loss of bone. Today we don't have an excuse.
Here, if you see this X-ray, it feels as if that patella is lying very low. But let me show you the pre-op X-ray where that patella is.
No, I agree.
So that is I am not guilty of that patella being,
I was not
the
pointing
joint
at
line
you.
being. So just to make a point.
I know what you're saying. When the distal femur is lost, we tend today with all the stuff we have, we should be able to distalize the femur effectively.
Sure.
Because it does have an important role. That's what is one of the
I think in revision TKR, I think distalizing the femur is extremely important, and there are ways of understanding where the original joint line must have been, and distalizing the femur is very useful and important. No question about that.
There are a lot of landmarks intraoperatively to know where it should be, and we should follow that. Yeah.
Lovely. So I think on the dot we are finishing this session. Thank you very much. Thanks for all panelists for their wonderful interactions. Thank you.
Thank you so much, sir. For the next talk, I would like to invite Dr. Sanjay Agrawal, sir, the Dr. Pachore Oration Lecture. Dr. Sanjay Agrawal, sir. Thank you.
Right, ladies and gentlemen, great honor and privilege to be speaking in my dear friend Dr. Jawahar Pachure's oration. I am from Mumbai, as most of you know, and
What drives you?
a lot of inspiration with even, there's no fun if you don't hear what he says.
What drives you?
A lot of inspiration with even more perspiration. Now, that's been my life. That's been my journey. I studied in KEM Hospital in Bombay, which is a very renowned. Those days, if you had the marks in your qualifying exams, I got a couple of gold medals on the way. I was taught by great people who were iconic in Mumbai and in India, and some of you who are senior know of them. And these are some of the giants that influenced all of us. I worked with Dr. Dholakia for 18 years. Dr. Ranawat and his type influenced us, but there was a point in time he stopped talking to me, and I'll come to that a little later. I went abroad on an International Graduate Fellowship Award. I could not have afforded to go abroad otherwise. I did get the Norman Roberts Medal at the MCH Orth. And I worked at Oswestry under Professor Brian O'Connor. Leslie Kleneman, who later on became the Liverpool professor, I worked with when he was at Northwick Park in Harrow in London. I worked at the Royal Liverpool, Stoke-on-Trent, and at Johns Hopkins in Baltimore. I came back to Hinduja Hospital, where I have been there for the last 40 years. I am also attached to Breach Candy. Some of you have heard of it. It's another well-known hospital in Mumbai. But if I have seen further than others, it has been by standing on the shoulders of giants. And I am a clinician and a scientist. And why do I say so? So generally, the treatment has to be evidence-based, things that have been done. But clearly, from time to time, you will be doing things which are hatke. And when you do things which are hatke, you need to gather the evidence, you need to put it together, collate it, and make it into something that can be published. And if it can be published, others too will learn from it. And this is what you're doing here. You're learning from others. I have 98 publications in peer-reviewed journals. I have an H-index, which is very, very good. It is a metric which is used if you want to check what yours or your teacher's H-index is. Nowadays, just go to ChatGPT, put the full name, write down whether you are in Delhi, he is in Delhi, you're in Delhi or wherever, and ask for the H-index. And
Aishwarya, let me ask you a question. Are you happy with the treatment you got here?
What does it look like?
my H-index is 21 and I-index of 38, which is internationally accepted as very good. So Dr. Pachure, whose oration I am doing, he and I have been associated for 40 years. I mean, that's when we were younger and both had black hair, you'll notice. And this is what we look like now when we have white hair. We've published a paper together, and this was using the bi-contact prosthesis. Dr. Jawahar Pachure, Dr. Jhunjhunwala and I, we published it in the Indian Journal of Orthopedics. This was our experience with this particular very difficult situations. Some of them, like you just saw of the knees, for the hips, and we had a solution. I was the ISHQ president, thanks to my colleagues here in this period of time, and I think we've taken ISHQ to another level now.
So every time I meet you, something good happens. Either my film becomes a hit or I get a nice film, so I'm hoping something else happens.
Oh, very nice of her to say nice things. I did hand surgery when I was in England. I worked with Frank Burke. It was in the Guy Pulvertaft unit. And I have publications in the British Journal of Plastic Surgery, the IRC of Medical Science, and way back in 84 and 1985. I also did spine, which I don't do now. I worked with John Dove at Hartshill, and I came back, and all the Hartshills that you see now have been copied from what I brought back in 1986. And I was awarded the Talwarkar Award at Wyrock for my Harrington rod fixation earlier. some of you might remember, I introduced to the orthopedic surgeons and spine surgeons microlumbar discectomy. In fact, I published it way back in 1987, introduced the holmium laser technique in Bombay, where we could put the laser. I don't do it anymore. I don't know if anyone is doing it, but it used to work. We published that as well. And in trauma, which I trained in,
so we can fix the damage done now.
That's we do in trauma. We fix the damage done. In 2012, I had been doing fixations of the distal end of the radius, and I was getting a certain degree of flack from my colleagues that I was being very aggressive. Nowadays, I think most of you will agree that if you have a difficult fracture, you can get the patient rehabilitated if you fix the distal end of the radius with these locking plates. K-wires backing out a fracture patella. Fracture patella constitutes 1% of all fractures that come to a busy practice. And if you use the old techniques of putting a K-wire and then doing it, well, I improved on it. And I do the Pryford and the Schauwacker. All fractures heal. They mobilize within days. Tendo Achilles repair, well, wound complications you know about with high reoperations day. Where I would do is I would take percutaneous in the distal part and open in the proximal. Atypical fractures, all of you have seen them. Is there a solution? Well, there is. There is a solution when you do vigorous endo-osteal reaming across the fracture. The bone dust that you can see on the third X-ray is what acts then as in the D. The C and the D, that acts like a bone graft and it facilitates healing. Issue, non-conforming plates. Now when all these plates were introduced, they used to be straight plates. I started bending them and twisting them to conform to the distal fibula. This itself worked very well. We published this, and AO, I'm not saying they copied me, but they were also seized with the matter, and they also have brought in a twisted plate for the distal fibula. The surgical management of arthritis, I played around with osteotomies. I have 3 publications on that. I did fixations, and patients would mobilize quite well. And of course, if it's done properly, they do well. Now I would do an open biplanar osteotomy using one of these fixation devices, which we have again published anyway. And there has been a common belief that Indians don't get DVT. In fact, they do. We published it and we figured out a way how to prevent it. There are a lot of genetic factors. DVT exists in Indian patients. Please do not go away with the idea it does not, and it can be prevented with prophylaxis. Issue that is not recognized well enough is that MRSA does affect Indian patients, and we have worked on the prevalence of MRSA colonization and showed that if you do screening, which costs 550 rupees prior to surgery, and if they have MRSA in their nose, you use mupirocin in the nose and use chlorhexidine wash 2 days, and the MRSA is no longer a problem. And then you have suturing. You all have seen cases where you do staples. I have this particular method of doing sutures where the patient does not need suture removal. We have repurposed denosumab and shown that this can be used for bone healing. If you want to see how it's done, you have to read BMJ. Go on to Google and you will find it, and you will know what doses I use for this. We have used this also for protrusio, same kind of doses. And we have repurposed bisphosphonates, and this is my contribution to literature, 15 such papers covering so many of these kind of conditions where bisphosphonates is a game changer.
Give us your magic pills all the time.
That's Helen talking about it. There's a paradigm shift in osteonecrosis treatment. I have a paper in JBJS, a 20-year study. The fact that post-COVID, all of us have seen more avians, published in JBJS 2022. And these are all the papers that I have in just AVN. This is my treatment protocol. Please don't go away with the idea that you can give any dose or you can treat it like you would osteoporosis. This is the treatment protocol required for the management of AVN. In our study, amazingly, in stage 1, we have 98% success. And like I said, in JBJS, we have the 20-year study report. So this is just to show you. I have a full lecture tomorrow on how I do it. So you might be interested in that. But this works. I think the chapter on management of AVN has been rewritten. And in fact, here is a child who had ALL. And now, with his AVN, he's able to do so well at 21 years without any surgical intervention. In replacement of hips and knees, I believe in the magic of normal joint function after replacement. And the armamentarium for increased mobility in TKR is known.
Actually, giving me a second life when he did my knees last time.
And the Journal of Arthroplasty, I did describe the patella-Clunk syndrome. I don't know if this is working, not working, but that's when Ranavat stopped talking to me because they had to withdraw this entire prosthesis from the market. And this is what I believe we should be doing for all our patients. They should be getting full range of movements because we are Indian. And not only for knees, it's not going through, there we are. Is this possible with hips, or is this just a fluke? If Africa and Asia, that's 78% of the world's population. These are the requirements for our patients. And after hip and knee surgery, we say you cannot do this. I think it is unfair. You go to Guy's and St. Thomas, they say these are all the movements to be avoided. And well, all my hips, and a lot of you have seen me do this, all my patients are able to do this after surgery. And is the armamentarium only large heads? Well, I've published this as well. Is it dual mobility? I've published this as well. But is it possible with standard hips? This is what I want to take you through. This is what position to do after hip replacement. And this gentleman is there on ZTV. He's
My God, this is
And how do I do it? Go in and some of you may have seen me demonstrate this. After my hip surgery, I have this degree of stability using an anterolateral approach, not an anterior approach. And this is how I make my hips hop. Modified anterolateral approach, cup in line with the native acetabulum, etc., etc. Standard things is not a fluke. No, it is not. If you get the stability with the methodology that I use, and you can do a forced drop test, your patients can do everything. And I think we as Indians need to be able to offer this. How did I raise the bar? The research and publications that I talked about. The thing that I did, Hatke, which I talked about, I published in all these kind of journals, 98 papers. My work on AVN has also been published. And my patients play squash after hip replacement. You can't guess who is my patient and who is not. And patients after hip replacement. And that is how I raised the bar and made my hips hop. And thank you so much for listening.
Thank you, sir, for such a wonderful session. For next talk, I would like to invite Dr. Vivek Mahajan, sir, for unstable to THA strategies of restoring hip stability.
Good afternoon, everyone. Thank you, Team Shalby, Dr. Pachore, for the opportunity. Well, it's a long topic, so I've been given 7 minutes. I'll try to justify. Well, we all want to avoid a scenario like this. Unstable total hip arthroplasty incidence is reported in various studies. Beverland reported almost 0.6% incidence in his paper. using the contemporary posterior approach and the TAL as a reference. Various registries are showing that dislocation is one of the most common causes for reoperation other than aseptic loosening. This is a Swedish registry, this is Canadian registry. Well, risk factor can be classified into surgeon, implant, or the patient related factors. Let's try to address them one by one. Regarding the surgeon related factor, 50% of the dislocations are associated with the inaccurate cup positioning, and main cause of higher cup inclination is the error during patient positioning, because you might end up putting the patient in internal and adduction. So always try to position the patient yourself. Close attention should be paid to the orientation of the pelvis. We aim for a target zone, Levnick safe zone, somewhere around 40-degree abduction and anteversion. However, the literature from New York Hospital for Special Surgery showed that almost 5 in 7 hips which dislocated, they were actually in the safe zone. So actually, we need to rethink that if the safe zone is really safe. In a high-risk group, it is always better to aim for prevention and to aim for higher jump distance, which depends on the anteversion, inclination, cup-neck ratio, diameter of the head, and adding a anti-luxation rim to the cup. Jump distance can be lowered by the cup inclination, it can be increased by the cup anteversion, and it is also affected by increasing the head diameter. A figure that depicts that how well the jump distance is increasing by increasing the head size. Normally, we try to increase the jump distance. Mobility cup provides the highest jump distance, which is the result of a large head diameter. One of the cases in which we switch to a large head to increase the jump distance, it's a revision scenario. Another case in which the dual mobility was used. Regarding the approach, Beaverland used the posterior approach using TAL as a reference, 0.6% dislocation. But the point here to note is that special attention should be paid to a capsular or the arthrotomy closure. Most of us are paying a lot of attention to the rotators, but actually it's the capsular or the closure of the arthrotomy that matters. Dawes said all approaches usually performs the same. The key is the restoration of the hip mechanics and muscle tension. All approaches are good, just we need to do them well. Regarding implant factors, there might be an impingement related to liner, cement, osteophyte, or heterotopic ossification. Head size, skirted heads should be avoided as much as possible. We need to pay attention to the liner profile and the femoral component offset. Patient-related factors, elderly, after the neck fracture, neuromuscular disorder, stiff spine or a lumbosacral spine, Professor Malhotra has already spoken about this, non-compliant patients, obese, females, and of course the surgical errors. Regarding the patient factors, obesity, one should pay a lot of attention to the obese patients, because if the patient is having a high BMI, it can make the hip unstable, especially due to high fat around the thigh, especially the inner part of the thigh, because that is giving a laterally directed force in the lying and the standing position. And if there is a huge belly fat, that can also add to the instability of the hip. Usually in my practice, I prefer to do a dual mobility in a very obese or very high BMI patient. Stiff spine, already been spoken about. Just few slides. Stiff spine with a retroverted pelvis, there is an increased risk of anterior dislocation, and a stiff spine with the anteverted pelvis, there is an increased risk of posterior dislocation. This patient had a stiff spine, X-ray has got blood. Patient hip was stable, but once the spine fixation was done, after 4 months of spine fixation, the hip became unstable. So spinopelvic mobility should be paid attention. Dislocation risk in normal population is almost 1.5%. This risk doubles if the spine is 1-level fixation, and if, 2-level fixation, and if it is a 3-level fusion, the risk also becomes almost 3 times. Management depends on the early, late, single, 2 or more, if we know the cause or it's a multifactorial. Non-operative, it's worth a try if it is a single dislocation, well-positioned cup or well-positioned components, if it is stable after the close reduction or not, if there is any wear loosening. and if patient can follow up the hip precautions. Operative treatment should be considered in a recurrent instability, chronic cases, irreducible malposition components, inadequate soft tissue tension or trochanteric escape. Surgery, one should know the cause, component orientation, soft tissue tension, offset of the femoral and the acetabular component, impingement, head size, and you should have salvage procedure as backup. Beautiful classification described by Paparowski, which divides into 6 types depending upon the cause. Revision algorithm, if you know the cause is due to acetabular component, revise it and go for a larger head. If it is a femoral component is the culprit, again stem revision and larger head. So always aim for one size bigger head in case of a revision scenario. Abductor deficiency, maybe you need to do a dual mobility or a constrained cup. Impingement, find the cause of impingement, remove it and put a larger head. Late wear, again you have to do a replacement and larger head. If you don't know the cause, maybe a dual mobility or a constrained cup. Another algorithm which you can refer to, published. Constrained cups have a role. I usually reserve them for patients with Alzheimer's and surgery with damaged abductors, and if the dislocation with improper positioning of implants, muscle tone is lower related to neurological or immobility, prolonged immobility. A patient which had alcohol abuse, non-compliant patient, constrained liner was used. Constrained liner, however, they are not a panacea. Problems like acetabular component loosening, dislocation of liner shell interface, excessive polywear, and dislocation of liner can happen. And it is contraindicated to use the constrained liner with skirted heads. You can see this patient in which the liner dislocated because skirted head was used. Just the skirted head was changed to a normal head, hip became stable. Dual mobility cup, the population in need is stiff spine, revision scenario, high demand, ligament laxity, and femoral neck fractures. One case in which it was used for a revision, another patient stiff spine, the dual mobility was used. I have done my audit before this talk of my patients who dislocated, and what I found, most of my hips which dislocated, they were looking okay, all except one, which was a DDH case and the hip center was too high. I also evaluated and found that initial soft tissue was not tight enough my initial days of my practice. Now I am paying a lot of attention to my soft tissue closure. Usually if you have a non-compliant patients, that spike up the dislocations, and most of the patients who had dislocation initially they were appearing to be a straight forward hips. Beware of female patients with the lax soft tissues, which we usually call as easy hips or a small socket size, and beware of men with alcohol issues. Thank you so much.
Thank you, sir. Due to packed schedule and delay in the time, we will be skipping a tea break. Anybody who wants to have their tea, they can go. But for the next session, we will continue. The next session is Symposium 4th on the Revision THR. I would like to invite Dr. Rajesh Malhotra, sir, on the podium. And I would also like to invite our panel, Dr. Kyle McGiven, Dr. Harbinder Chadda, Dr. Sunil Rajan, sir, Dr. Pradeep Bhosle, sir.
So gentlemen, we have a lot of ground to cover and only 40 minutes. We'll make it very quick and so that we can cover maximum number of cases. So the first case is a 77-year-old female, Parkinson's disease on medication. She has a coronary artery disease. She's on blood thinners. She fell on 7th December, and this was a fracture. Because it deals with revision, I'll not talk about it. All this is a question whether this really needs an arthroplasty because it's an intertrochanteric fracture with a lesser trochanteric fragment. However, the surgeon did a bipolar hemiarthroplasty on 9th of December, and on 12th, the patient had a dislocation. The closed reduction failed, the open reduction was done, and there was post-operatively a new onset sciatic nerve palsy. On 20th of December, the patient again had a spontaneous dislocation. So see, this is what has happened in a period of 12 days. 2 open reductions and repeated dislocations. So this is the X-ray. Now we'll start from one end, I mean, let's be consistent. So I'll start with Pradeep. What will you do?
It's very important to identify why it has decided. I know there are a lot of risk factors, patient positioning. Do CT, identify what was the alignment problem. And second thing is very high risk. So I will advise constraint.
Let's keep it very, very short because there are lots coming up. There are under 200 slides.
Dual mobility, dual constraint.
So what's wrong here? Anybody wants to say what's wrong? Let's make it
trochanter
very
is gone.
It's mainly the abductor deficiency, I think.
There's abductor, they say greater trochanteric fracture, yes. And it's dislocated, obviously. Anything else, Kyle?
No, not.
So I think obviously the patient has been lengthened. You look at the tip of the trochanter and look at the head. So it's some way, obviously, the stem is proud for whatever reason. And the vertical offset is increased. There must be high pressure. This is osteoporotic bone. So next question, sir, what will you do? Dr. Chada?
So I agree. It has a high center, and you could possibly revise the femoral stem, but it looks like it may. Is that how many weeks is that?
This is 2 weeks, 12 days.
12 days.
3 open.
Yeah, so I'd revise both the femoral and acetabular side, put in a total hip arthroplasty, and constrain
So
it.
what kind of acetabular component will you put?
For the femur?
No, for the acetabulum.
Acetabulum.
So I understood you will revise the femur, you will restore the length,
Yes.
you will put you said you will put an acetabular component. So what kind of acetabular component?
I'd constrain it because possibly has a neurological injury and definitely has that abductor insufficiency right
So
now.
the constrained cups do not come below a certain diameter. This is a very small acetabulum. And second thing is, in an osteoporotic bone, you put a cementless cup and put a constrained liner, the whole thing might just pull out.
Yes.
Any ideas? Any thoughts? We'll go on to the next slide otherwise. Kyle?
I tend to start with dual mobility, convert to total hip, start with dual mobility. Even if I get good fixation of the cup, I'm going to add screws knowing that the potential for constrained at some point is there and want that cup to ingrow.
So the dual mobility, again, if you're using a cementless dual mobility, I think the quality of bone is quite poor here. But well, let's see what was done. So she has multiple dislocations, she has Parkinsonism, Adler-Lido demand, and we know that there are issues with neurodegenerative disorders. We talk about dual mobility. We also know that even hemiarthroplasty is known to have problems in patients with Parkinsonism. So it's not that you should feel very safe and secure that you have put in a hemi replacement. It's known to dislocate like this. And even the total hip has got a lot of challenges. So this is what was done. I just took a constrained liner and I roughened it, the backside, and I cemented it. And I think with a cemented liner, I'm not worried about it coming loose or having problem with the purchase in the bone, because anything else, if you put any kind of cementless cup and put the constrained liner, the stresses will be transferred. Here, however, here the stability of the cup in the acetabular bone is immediate, stability is immediate, and that possibly has got the least risk of coming loose. So she was given a brace and she stood up and she walked, and she lived for about a year when she died because of unrelated reasons. Now this is a 59-year-old female, morbidly obese, non-diabetic, severely osteoporotic, had an right THR for idiopathic avian, and post-operatively developed sciatic nerve palsy again. She had an acetabular shell which was 50 millimeter, neutral liner, 32 millimeter head, 12-14 taper, triple tapered. I'm sorry for the poor quality, but I think this is how the X-ray looked. And it doesn't look very bad though here, but she was morbidly obese and this was a small femur. So just remember what Vivek said a short while ago. He is worried about the females who are obese, who have got a small acetabulum, and this is what happened. Now, Pradeep, what will you do? This is like third day after surgery. She was made to walk, and here she is in your clinic. I got a desperate phone call from my mentor saying that one of his colleagues had done this, if I'll be happy to take it over.
Two things. One is we have to think about sciatic nerve palsy. So evaluation of that first. You can do EMG nerve conduction studies.
I think in this case you are going to go in anyway, so just explore it. You are not going to leave it like this. So I don't think there's any role for waiting. The question is what will, so it's a done. I agree with your point. Sciatic nerve palsy is there. It has to be.
And keep all the options trabecular metal ready and give the good
so you want to put a trabecular metal cementless shell?
Yes, everything, reconstruction possibilities, stability, intra-op stability, reconstruct the acetabulum. Stem you may not have to revise unless it is badly positioned. You will confirm that before.
I would prefer to go for the highly porous cup, TM cup, but along with that, I would need the kickstand screw also in this GM.
Kickstand screw with the porous cup to make, to take care of the fact that possibly the quality of the bone was too poor for this kind of cup, but she is very obese. And remember that the initial X-ray looked okay and she was bearing weight when it just all came off. So whatever cementless thing we are using, we have to remember. What do you think about the superior acetabulum? Do you think there's going to be a defect here?
It has got high up. Yeah, there is a superior defect is there, and that is I think more than 3 centimeters. So it is almost something.
Kyle,
bone loss is there.
What will you do?
Yeah, so I mean, initially, depending on what the bone looks like, but I'm going to, increase cup size, go medial, plus or minus a wedge up top, which is probably going to be needed in her.
Can be a little dangerous in small women because the anterior posterior diameter is very limited. So again, you have to be very careful. The problem with very osteoporotic acetabulum is, one is that you can ream off the walls very easily if you oversize it. If suppose the system recommends line-to-line reaming, if you under-ream, you can split the acetabulum. You ream as recommended, you may become loose. So, I mean, you have to be very, very careful. I don't know how frequently you see these kinds of very osteoporotic bones and very heavy. We call them obese malnourished. So these obese malnourished are really bad bones. But one suggestion is you say that you'll go the higher size of cup.
Yeah, that the bone allows, plus or minus a wedge up top.
Yeah.
Yeah, I mean,
and about the defect?
If you ever visit Oklahoma, there's lots of obesity, so.
Yeah, and what about the defect on top, augment?
Yeah, a wedge up top.
When will you make her be a weight?
Depending on the bone quality, but if I feel like it's solid and get good fixation of that, I'm probably 50%.
She has a BMI of 42.
50% with a walker day one.
Dr. Chadha?
I do the same thing. Definitely it came up superiorly.
So
it
I'm
needs a
sorry,
wedge
I
for
think I
support.
still didn't have much confidence in cementless cups. So this is what it was. Of course, we did a NCCT. I'll just skip them for the interest of time. We have the CTs, axial and sagittal cuts. So this is what I did. Took out the cup, and then there was a posterior superior bone defect. And so I trialed a 46 size cemented cup, and then I put an augment on top and I fixed it in place and I cemented the cup. I have a series of about a dozen such cases. The longest follow-up is 12 years. And this is poor quality bone. This needs cemented cup. The defect is uncontained. There is a segmental defect on top. Put in an augment, convert it into a sort of contained defect and cement a liner in that. And then because it's a cemented thing, you don't have to worry about putting weight on this. And she's happy now. She's 8 months now and she's happy. The next one is really a shocker. I mean, I would like everybody to pay close attention This is a 51-year-old male who had hip replacement in 2007 and avascular necrosis. He had to have hip replacement because it didn't meet Sanjay. But then he also had idiopathic thrombocytopenic purpura and history of steroid use. So he said that, you know, in 2024, almost after 17 years, he was having pain in the left hip for 2 months. And these are the x-rays on your side. He had seen somebody who said there is lysis in the acetabulum and the pain is because of that and it should be revised. How many of you think it's lysis?
We have to document with CT scan.
Indore, so he's about, say, 1,000 kilometers from Delhi, and he says, now I have very severe pain. I have to take analgesics every day, naproxen, tramadol, gabapen, night pain, cannot turn, cannot walk more than 15 to 20 meters. He's crying, but there's no fever, no systemic focus, nothing. ITP, last episode was 23, before he had this pain and he was given steroids. Examined again, BMI 24, tenderness persists on piriformis fossa, greater trochanter, tenderness of lumbosacral spine, no groin pain, no thigh pain, movements are painfully restricted. Flexion 0 to 60, abduction and adduction painful, internal rotation painful and restricted, external rotation 0 to 30, he is lengthened by 1.5 centimeter and he is crying with pain. We do the x-rays again, x-rays look much the same, no change, what now? You have tried to give injection once, it has failed. We'll start from Dr. Chedda this time. He's a patient in your clinic, you have given injection once. Now he has come back with recurrence which is much worse, a lot of analgesic intake and the x-rays look just the same.
The pain is in the flexion of the joint?
No, he complains of pain in the lateral aspect and the gluteal region and in the groin, but there's no tenderness.
It might be impingement of the iliopsoas.
Impingement of iliopsoas, that is right, but the question is why should it appear 17 years after surgery? And then his provocative tests for the iliopsoas are negative. He doesn't show any provocative signs. We do try to look for that. And if you look at we have that false profile view there, and you see that the edge of the acetabulum is not proud of this end, and this is not hard on hard bearing. And he has done well for 17 years. Any suggestions what to do? Again, his friend says get it operated. It is showing lysis here, but his old x-rays have shown this stress shielding for many, many years.
And so what, his iliopsoas is tight or not?
Sorry?
The iliopsoas is tight, the soft tissue? Can he?
No. No.
None of that?
No.
No, you need to evaluate for more visualization, CT or MRI.
Okay, so Pradeep says CT, MRI, I can't refuse him. I did metal-ions because this has been in for a long time, and we, although we have seen a lot with AML, we have a large series where this, and I'll show you something like that if the time permits. So metal-ions were normal, ESR CRP was normal. The Mars of the hip showed no collection, no lysis, no lytic areas, no bone loss, right? MRI is like that. And then we did MRI of the lumbosacral spine, which showed early degenerative changes, no problem. So now what? Oh, actually, before you ask for it, we also did a PET scan. So we did a PET CT, and the PET CT shows that post-left THR status, implant in situ, streak artifacts obscuring the locoregional anatomic, slight uptake, limited significance. Now we have done CT, MRI, PET scan. He is crying with pain. What next? Dr. Bhosle now, what next?
The observation.
Under observation.
Yep.
He refuses to go from my clinic.
Put the patient.
So I went for a pilgrimage to Ujjain. He came to know I'm there. He traveled 100 kilometers and sat in front of me and said, you treat me. I got a bone scan, I got a PET CT, I got, and we know that we never operate unless we know the cause for pain.
Aspiration.
We never revise.
Infection for aspiration.
So we, how do you read my mind? So we aspirated. We did aspirate and we looked at it. The cultures are negative, gene expert is negative. all this while, we are very, very confused whether this pain is coming from the hip at all. I have been told that the stress shielding doesn't give rise to pain. A very senior surgeon in America told him, get it revised because it is stress shielding. And stress shielding, I looked at literature, stress shielding has not been reported to give rise to pain. It doesn't give rise to pain. So he is here, only thing I see is stress shielding. This is negative for tuberculosis, negative for infection, negative for everything. So Dr. Bhosle, what now? So I ring up Prasad Gaurineni and I say, I have this patient, I want you to do arthroscopy. Sir, alendronate? No. So you think it is the lysis or the osteolysis which is causing pain?
Double dose denosumab, 120 milligrams every 2 weeks, a period of 6 weeks. If it works, it will work within 2 to 3 weeks.
We did give zoldronic, nothing happened. But I think maybe you are right. We didn't try denosumab, so we can't go back the road that road again. So I asked my friend to do scopy. I said, I can't make out. I'm not prepared to revise. He's crying with pain. So he did this scopy and he sent me these pictures. And he says, Rajesh, it was moderate synovitis, dense arthrofibrosis around neck, no evidence of loosening. On histopathology, again, no polymorphonucleate cells, no metallosis, and the cultures are negative. Now what will you do, Dr. Bhosle?
Explore.
Okay, explore. Have I ever said no to you? So I said, fine, he is in so much of pain. I throw all caution to wind and I say, okay, I'll open you because you are, no, but there was one difference. And the difference was that I injected xylocaine in the joint and he said my pain is relieved. So I by this time knew that the pain is coming from the hip joint. There's no question about it. But what is causing that pain in the hip joint is not clear. So we did this before we explored. So I gave xylocaine injection. I didn't give steroid because I was mortally scared that whether it is, because in this country it could be tuberculosis, it could be, whenever you can't understand anything, you always think it could be low-grade infection. So that thing kept on stopping me. So finally I said, I'll explore. So I went ahead. I saw only a very little tattooing around the area where the stem was. This was the cup. Everything was taken out. And now, after I took it out, I just saw some changes around trunnion, but the better lines were normal. And I sent histopathology. We saw something inside the bore of the head. Again, not enough to explain. So now, I was really scared to put in a definitive hip. So what should I do? Leave as a gallstone? Now this is halfway through I'm calling you from the theater. I've taken down the implant. Now tell me what I should do.
Put cement spacer with antibiotic.
I don't know. When will I learn to say no to you? So this is what happened. So I put in a destination spacer because I thought I'm not sure what the cause is. I didn't want to leave him without a hip. So what I did was I loosely cemented the acetabular component. I loosely cemented the femur. The femur cement is only towards the top, somewhere only around here, so that when I have to go and revise, I can do that. I sent histopathology, I sent culture, I sent biofire. Everything came as negative. There was only finding was low-grade inflammation. Low-grade inflammation.
Did you do a frozen section interop?
Yes, we did, and it didn't show many polymorphonuclear cells. And there was no pus, there was nothing. But the fact is that even after taking out everything, I don't know the diagnosis. So I put in a destination spacer, loosely cemented cup, cemented stem, came out, and this was he looks to be limping very badly, but he's so thrilled because for last year and a half, he has had so much of pain that he was not able to walk. Now what, gentlemen, is the diagnosis? If each one of you will give one diagnosis in this case, I don't know the diagnosis I'm telling you, but I can tell you what I think. If you have any thoughts about what it was or could have been, you are welcome to tell. Or anybody from the audience for that matter.
A subacute infection.
Infection.
Okay, but an infection which ESR was always normal, CRP was always normal, Bio5 was normal, culture was normal, histopathology was normal. But anyway, we have put in a spacer, so I hope it's good. But there is an entity called this thing. There is a this thing, scarring which you see after TKR. After TKR, you have been shown to have the extensive scarring in the joint capsule. His painful restriction of movement before surgery with fibrosis during the arthroscopy suggests that it could be a fibrous reaction, fibrous scar, but why it happened after 17 years is anybody's guess. We still don't know whether it was infection, but the fact is that we ultimately did take out the implant. Who had problem bearing weight on the right hip, which was operated about 20 years back, diabetic, hypertensive. She had pain, hip aspiration was negative. So, Dr. Chadha will start from your end.
So you see shortening of the leg and asymmetric wear of the acetabulum, polyethylene wear, the proximal portion.
So I think it's a no-brainer. There are lysis on the acetabular side, there's lysis on the femoral side, the trochanter seems to be breaking off, and this is our dear friendly AML stem, which we have shown that over a period of time loses material from the trunnion. We have a series of about 12 patients. We tried to publish it everywhere, but because it is now withdrawn from the market, nobody is interested in publishing. And we have actually classified the trunniinosis which we see with these stems, and I'll show you some very interesting findings. But how will you reconstruct it is the question. Kyle?
How will you reconstruct the femur?
Yeah.
Is that your question?
Yeah.
I mean, for me, it's removal, see what you have, and distal fit stem. You know, the trochanter obviously worried about, I hate claw plates, so I try to get a cable through there around a proximal modular body.
Sure. So this is what it is. The patient was very clever. She had this model made by Jajal, and it shows the extent of bone loss. Does it help, Kyle? This 3D model, bone defect?
Yeah, 3D models is always helpful.
So this looks almost as if there is no, it is still intact, there is no discontinuity. This is how the thing looked, took out the stem, and see that this is what happens to AML stems. They, particularly if there is a collared head, they just thin out at the trunnion and they just telescope. So the patient is walking and telescoping on that head all the time and keeps on losing material. But again, this patient also had normal material. You can see the eccentric wear of poly on your extreme right, and this was the discontinuity. So this was actually, I don't think I damaged the cup so much by the time, acetabulum so much, but by the time I removed, there was a pelvic discontinuity. So options from one end, Dr. Shabra?
I think the...
Dr. Chadha, sorry. Dr. Chadha, options
yes.
from 1 to 3, 4.
So I think because of the pelvic discontinuity, you're going to need to use some sort of a cage construct and then cement into it a polyethylene.
Cup cage. Kyle?
I like impaction bone grafting and distraction technique with large cup and or cage, but I've had good success with bone graft and large cup.
I did one day before yesterday, impaction and distraction. She has got sciatic nerve palsy. I'll show you that one also. Sometimes these things can get very dangerous. And Dr. Sunil?
Cup cage.
Sir, I think cup cage construct
requires
cup cage.
Cup cage. So everybody seems to agree this is a discontinuity, but you know there are many ways to skin the cat. So I just wanted to bring to the house this technique which is called the dome technique. And what you do is, if there is superior and anterior defect in the acetabulum, you can join the two augments together, and then you can actually put in a cup. And so this is what I did. I put the two augments in a dome manner and did a cementless, a trabecular metal cup actually, which was unitized with impaction grafting in the floor, and this is how she looks, and she is quite happy. She was nearly bedridden, was not able to walk, and she is able to do that. This was for the dome technique. Another 61-year-old female, failed right total hip, reverse hybrid. She had a history of revision 1 year after the primary, right? And this is how it looked. No, there was a big mass medially seen on angiography. Actually, this has been put before. When we saw that X-ray, oh, he didn't put that X-ray. So this was the X-ray she came with. So now the cat is already out of the bag. She is here. So how many of you will do an angiography in this? Kyle? Okay, so whenever there's an intrapelvic component, and we have submitted this paper to the International Hip Society meeting for a presentation this year, unless you have a clear-cut sequence of radiographs where a cemented cup was put in the normal position and gradually it migrated inside, you should always do angiography. If a cemented cup was in place and later on migrated medially, it would always have a membrane and it will not be stuck. If, however, there was a medial deficiency and somebody put the wet cement inside, and that I have seen get stuck to the iliac vein or the femoral vein, and you try to remove it from the acetabular side, it can create problem. In fact, we have published about the putting a Fogarty catheter in the vessel preoperatively when the angiography shows it to be very close, and keep it ready in the theater in case she bleeds, or keep the surgeon on call, because sometimes these intrapelvically migrated things can be dangerous. Particularly this one had a metal shell, metal mesh. So the metal mesh can get rough and can get stuck to things. And when we did angiography, they showed this collection, which they thought was a hematoma, which was stuck to the vessel and the component. So I got very worried. So I thought this has possibly invaded the vessel wall and is collecting as a hematoma. Obviously, the report was wrong, but then we thought that it would be better to call the general surgeon. So the general surgeon came, he secured the vessels, and then we took out this all. They see how rough with metal threads coming out from this mesh, and then we could see the floor from here, from inside, and then this was a defect, and this was a defect, and there was pelvic discontinuity here. Again, this had broken through. I think discontinuity was obvious on this also. And then this time I did what I was told to do in the previous case. I did a cup cage with the impaction grafting blow. But the key message here is that if you have intrapelvic migration of an acetabular component, you should be wary. And if you have slightest suspicion, the first and most key thing is to get all the sequential X-rays from the time of surgeries. But that's not always possible, like it was not possible in this patient. She came from Iraq, and this is what it is. Now she has no previous X-rays, and when what are the challenges you expect here, Dr. Chadha? Again, another case of severe intrapelvic migration of the component. Do you think there's discontinuity here?
There may not be discontinuity, but the worry is that it's so far medial, and all that cement sitting there, it's going to be difficult removing that.
Right. So the message I want to give here is there are quite a few challenges here. Of course, the first thing was to do a CT scan and do an angiography and establish that the vessels were far away. I put the surgeon on call, but I didn't call him. I didn't ask him to open the abdomen like I did in the previous case, where the radiologist said that the swelling was abutting the vessel. But the key thing is that if it is not infection, I don't try to pull it out. Particularly, again, like I said, if the cement has been put in wet stage, it would be stuck to the soft tissues, and you try to rip it apart. There was a case I saw. I think I'm old enough that I've seen everything which can go wrong. So one of my juniors was trying to take out the spacer put in, and this was a cement spacer, and the previous surgeon had put it while it was wet. So he pulled it out and he stripped the vein which was stuck to that. So I think it's very important, because if it was not put in a wet position, there'll always be a membrane. So you try to tease it. If it comes out easily, it's okay. If it doesn't and it is infection, open the abdomen and ask the surgeon to separate it. If it is not infection, cut it off and leave it there. That's the important thing. But there is no space between the trochanter and the ileum. And the sciatic nerve was breathing right at the margin of the acetabulum. And this is externally rotated. So I knew that the nerve is in danger. I gradually teased from the neck. I can swear that I didn't damage the nerve. I left it inside. I reconstructed it with impaction she has so this is how it started. Look at the extreme left. This was after about 10 minutes of effort that I could get a plane between this, because there's no movement and the nerve is somewhere here, and I'm working here on the bone, little more space, then little more space, and finally I could actually get in and see the component. And when I was trying to take it out, it won't come out. It occurs after revision.
You have to wait and watch first. Let's see whatever natural recovery, everything, and do EMG studies. And then when it is absolutely...
So EMG NCV will be of no use before 2 weeks, at least for 3 weeks. Anybody else who would like to, you explore immediately, unless you think that the nerve is cut. But Kyle, how would you proceed?
Yeah, I think obviously from in surgery, if you have any concern that there was damage to the nerve, that's one thing. But if not, I mean, you're taking traction off the nerve. If there's pain along with it, you're going to treat with gabapentin, Lyrica. I also put them on high-dose vitamin C and B12.
So we put her on the edge of the bed, flexed the knee, relaxed it, gave her erythropoietin. We have a regime, and it's known that erythropoietin, and some people believe corticosteroids do help in that. But the thing you should try is do imaging, and if the imaging shows that there is no interruption, if it is normal, you wait. If it shows hematoma or something, then you explore immediately. If you can't make up, wait for 6 weeks, do all nerve conduction studies and everything, and see whether you need to go in. But it's a very, very disconcerting condition. The last case which I'm going to show is, because we have all been on the acetabular side, I'll quickly do this. So this is a long story. So the patient had fractured neck femur, usual story, screw fixation, AVN, total hip, went on for a few years, then failed, then had a revision, then another revision where somebody tried to put this long stem, and now he came with this kind of picture where the bones are turned into a ghost. If you see on the picture on your right, and it's just a ghost of the bone, and it's almost tending to come out through the anterior cortex. ESR and CRP is normal, skin is normal, 7 centimeters shortening. Last case, the gentleman will quickly, Dr. Chadha.
Yeah,
Plan.
So I think the whole proximal portion of the femur is just not useful here, so probably proximal femoral replacement, and then because the abductor mechanism is probably incompetent, probably a constrained liner.
So there is a greater trochanter intact which somebody has tried to tie with wires. I'm sorry if it's not showing its poor quality. Kyle, proximal femoral replacement or something else?
I think depending on bone quality when I get in there, one of two options, to try to get a distal fit, but be careful with the bone, get past all that. The other thing is long cemented stem past that, pull that, put a plug. I don't love doing that, but might be an option here, and keep what's there proximally. While not really useful, you don't also have to remove it and maybe save some abductors in the process.
Dr. Sunil?
I'll go with the impaction bone grafting, sir. It's outdated, but I think it can be done.
No, it's
in
not
such
outdated.
cases.
I think it's an excellent idea, only that
Femur,
I didn't
yeah.
think of it. But then that's a good idea. The problem with distal fixation or distal cemented stem, it always remains is that you do get fractures if they are not a big diameter. Like we've seen so many solution stems fracture which are unsupported proximally and osseointegrated distally. Dr. Bhosle, anything different?
Same, impaction bone grafting and denosumab.
So this
Opening.
is what I did. Actually, I put in reef stem, which is hydroxyapatite coated modular stem, interlocking stem, and I protected it with the locking plate spanning it because I don't want a fracture at the tip of the stem. And then I use the same plate to actually capture the greater trochanter on top so that the abductor mechanism does not escape. And he is now 1.5 years out and is actually quite happy. Last case, this is a patient, bilateral hip. She went to the doctor, wanted to get the right hip done. The doctor did the left. So this left the right one alone. So now she came because she was diagnosed with a tumor. She was having pain and somebody did the x-rays and said you have a tumor and it's spread into the pelvis. There is a tumor in the pubic ramus and superiorly. And this time she went to the doctor and said, do my left. So he said, I can do your right. So, so now infection workup was negative. We did the serum metal ion levels, they were normal. We did the MARS and that showed that there was a large tumor. Large 11 into 7 to 6 centimeter multiloculated cystic lesion, an abscess and proteinaceous contents, query metallosis, query hem infection, blah, blah, blah. So this is how it looked. So she was open and this was the tumor which was evident. It was bulging like a big tumor here and this tumor here, just see, this is all tumor here, tumor there. And although there was not much of metallosis, but there was a huge pseudotumor. And when we removed the implant, there was this black ring kind of debris which was around the, this is around, and this is, and the trunnion was badly damaged. So I still believe this was a case of trunnionitis over a period of time. And then of course the femoral preparation was fairly standard, but the cup was a dual mobility cup with multi holes. And she's fine now, she's waiting for the right side. Thank you very much, gentlemen, for your
exclusive cases. Fantastic. Thank you.
You didn't let me cover even 1/3.
Real quick, any concern with going back with dual mobility in cases of metallosis?
So I do understand that, but I think the problem there was the trunnion. And second thing is that in the case with these pseudotumors, although it looked intact, but it is not at all uncommon to have severe soft tissue damage. Uncommon to have severe soft tissue damage in these cases, and this is definitely not away with the normal head. But it's just that I think looking at the amount of damage there, I wanted to put new up, and it did have. So for me, more important was the G7 cup with multiple holes. And when it came to choosing a liner, I chose dual mobility, but I think
for the past 15 years, following my master is not easy. Professor Malhotra, I'm proud to be a student. I did post-graduation under Dr. Malhotra. And he steals the show whenever he is and wherever he is. So following him is a matter of honor, but cannot match him. There's no doubt about it. Now let's see. I was more skeptical about robot. I was a CR surgeon to start with, and I was quite happy with my technique. But then I felt that there are some cases where we calculate the CPAC type and all that for our purposes. This is the system gives us, this is the pre-planning which we get the previous day. So it actually tells us exactly what we are going to do, the size of the implant. It actually calculates for the mechanical alignment. So the patient has had a varus, but they're correcting it to neutral. And this is going to be the resection on the medial side, 10 mm, lateral side about 7.5 mm, posteromedially 10.4, posterolaterally 8.4, all this seems acceptable. And the size of the femoral component is going to be 2, and the robotic arm. So the robotic arm is very versatile in movement, but sometimes the pins can come in the way, the array can come in the way, and prepare the keel yourself. That's the one thing. So this has helped us to avoid any sort of stress riser on the tibia as well, and it keeps everything within the zone and also not creating any stress riser on the diaphysis. So once the pins are in, then the arrays go up, and these are all the glass beads, and these are all caught. So the sensors, they get detected by the robotic arm and the OTS, and once that is done, we go for registration. It's all pretty straightforward and easy. It might look daunting. The first 2 cases were very difficult, but once after the first 10 cases, everything becomes so easy and straightforward, and you start enjoying this operation. So the RMSE, what is shown on the video, it's basically the root mean square. It has to be within 1. So your accuracy, intra-op, how you are matching and registering the tibia and the femur, it has to match to the pre-op plan. So pre-operatively, the computer has already positioned everything, and it knows where exactly the femur is and the tibia is, and there is every step there is a check and a feedback which goes, and there is nothing can go wrong here. That's the most important thing about this. So gives you a very confident feeling with this. Actually, once the registration points, there are multiple registration points, 40 points on the femur and the tibia. Once all the points are mapped, and once the robo is convinced that your femur and tibia are in the right place, then you start what we call as the gap check. So here in gap check, what we do is we extend the leg, and then at 0 degree we check for varus and valgus. We give varus and valgus stress and see how much is the maximum opening in varus and valgus. And once that is determined, then you can play around, and you can change the amount of bone cuts you want to do depending on the medial tightness or the lateral opening, and you have all the freedom here to exactly put your implant where you want, and that really excites us as a surgeon, because now that we know about CPAC, about functional alignment, and having the degree of freedom and being able to do it very accurately really makes you happy here. So, so that is the sort of screen you see. If you see the screen here, you can see the screen gives you inflection, what are the cuts you take. So, so basically here you can see that the medial side, the gap is 9, and lateral side it is 12, which is all right. About 2 mm of lateral opening is fine. So that the cut we are going to take on the distal medial is 10.4 and distal lateral is 8.4, again within range. Varus is 0, slope is 5, and the extenotation is 3. So femur size 2, tibia size 1. This is the captured value, maximum value. So here you can see the maximum value is 14 and 9.5, so a little more here. So what we are going to do with it, we can actually work and play with whatever we want. So so we finally actually decided on actually varising a little bit. Here we varised the tibia 2 degree here, a little varus on the femur, externally rotated 4 degrees, and distalized the tibia a little bit, but we found that was not needed, so we again proximalized it. All this can be done before doing the cuts. Virtually you can see everything, what's happening. Yeah, are you happy with the lateral gap? Are you happy with the medial gap, both in extension and flexion? I mean, this is absolutely fantastic to see everything be made virtually. And once the decision is made, then you lock it in, and then you just use the C-clamp to fix the femur. We check the gap check time can reduce with time, and the cuts is going to take 13 minutes, exposure and then closure. So all in all, the surgery can be finished in 1 hour 10 minutes, 1 hour 20 minutes max. There are people who they claim they do it in 45 minutes. So it's not impossible to finish this surgery quickly. Now what we've seen in these patients is definitely the post-operative pain is less, probably because not opened the medullary canal, the bleeding is less, and patients walk quite well, and that could be probably because of less soft tissue stripping. If you see the knee, we've hardly removed any soft tissue from the medial side, and the bone cut is also not much. So it is hard to believe how this happens, because we've been doing this manually for a long time, and we know, either you have to take bone or release soft tissue, but that accuracy gives you a lot of advantage in actually reducing soft tissue stripping, and also reducing the amount of bone cuts, and still you can accurately align the knee. So once the robo is in place, you lock the base of the robot. Once that is done, you can see these three arrays, the array of the robotic arm, the femoral and the tibial array, all have to be seen on the monitor. You just lock the both the C clamps to the robot, so that avoids all those small micro movement. Actually the robot stops, the arm stops cutting, so that you have to be careful about. So once all that is done, then again rechecking the position of the femur and the tibia, and once that is done, then the burring starts, and you can see it so the cut for the flanges and the lug holes, everything is done. The perfection is really astonishing. So I am a relative novice compared to a lot of seniors here and veterans here. So I am still awestruck by the things which we can do, the things which are possible here with the robo. So once the cuts are complete, the tibia is cut as well. So one thing you have to be careful with this is, I see that sometimes the medial skin can come in the way. So we use a retractor, and you can actually push the medial skin off, and it is definitely safe. It is not, it leaves a little rim of bone posteriorly. Absolutely there is no danger of the vessel or anything coming in the way. The medial skin, I found, if you are not careful, it can get injured. So bone movements you have to avoid. So once you put the trial in, so once the trial is in, once all the bone cuts are done, then you put the trial, you can see how perfectly it fits, and again you can recheck. Once that is done, again in extension and flexion, you can check what is the gap medially and laterally. So you can see now it is about 10 and 12, which is fine, and the residual limb varus is about 4. That's what it's showing. So we've externally rotated a little bit, so little varus on the femur, little varus on the tibia. This is what I always like to do, even in the conventional surgery, but now I can accurately see what's happening. And again in flexion, you can see what are the flexion, the extension gaps, the medial and the lateral gaps in flexion. So it throws away a lot of bone dust because it's burr, so you just have to clean those glass beads. Sometimes they might not get detected, and that's the flexion range. Again you can see it's a perfectly balanced gap, and the implant goes in. We infiltrate, we give an adductor block. I always use a CR knee, it's a vitamin E poly, and that's the final implantation and closure. So that's the pre gap check, and then the final gap check. What we achieved was this. We've a little varus on the tibia, and that, as I said, and the final limb varus is 3, and that's the post-op X-ray. I'm really happy with this. The perfect fit of the femur and the tibia, the slope, the sizing, and what do you need? What else do you need? Thank you very much. Any questions?
Fantastic presentation and video demonstration. I had one question.
Yeah.
How much laxity do you accept when you balance the gaps in
So-
millimeters? And
so-
second,
Yeah.
in extension, many a times you feel the leg is in recurvatum when the system shows you that it's a 0-degree angle. You know, in extension, the flexion extension angle, it shows 0, but you feel it something like a recurvatum.
Yes.
So what do you do with that?
So I've spoken, I had the same concern as what you raised about the recurvatum thing. Sometimes we feel that it is in FFD, but it shows that it is 0, or if it is in, we feel that it is in recurvatum, but it is, so that sort of alignment there, it can be done real time with our hand. That is more, the mediolateral is perfect, but this recurvatum FFD thing, the system has some issues. I don't know, the company people also told not to bother too much about it, just go with the feel of it. If you feel if it is a little loose, then you can put a thicker poly, but that is one thing. And then this lateral laxity, trying to balance that lateral laxity, 2 mm of lateral laxity I just accept. So 10 and 12 I usually don't bother too much. If it is more than 2 mm, then I try to play around and try and correct it.
Yeah, I have a
Yes,
comment. If I in the center of the hip, center of the knee, and the center of the ankle, and it is not taking into account the anterolateral bowing of the femur. And what you clinically perceive as hyperextension is actually taking into account the distal femur and the rest of the leg. And clinically, you do feel that these legs are in hyperextension if it shows you 0 on the screen. So for me, I don't use this robo, but I use Mako. And for me, 5 degrees is neutral.
Okay.
So I actually aim for a 5 degrees FFD on screen, whereby it actually is neutral. Because clinically, you feel it is hyperextension.
Is that your experience as well, Bhupen? And what do you feel about?
Yeah, so I use Corey Smith and Nephew system. So for that, they also tell the same thing, that up to 10 degree, if you feel clinically it's 0, means it is 0.
Can accept it.
Yeah.
Okay.
Any more questions from the audience? When do you convert your CR to PS? I mean,
well, with the robotic, I've never had to.
You never have to.
I never had to. My experience is limited. I've been using it for the past 6 months only. Usually, my 99% of my knees are CR. So with the robotic, the one place where I was worried when I'm doing conventional is my saw accidentally cutting the PCL, or the PCL becoming injured during this preparation. But the robot, what it does is, just at the level of the PCL, it leaves a very nice island of bone. So the PCL is so perfect. So it's never been a problem for me, and the balance is quite okay. So when I have a severe medial tightness in flexion, I have done what we call, I've actually surgically avulsed the PCL. I've done that. I actually I use an osteotome and actually do a bony avulsion of the PCL anteriorly. So the PCL will be only attached to the capsule at the back. That loosens the flexion gap medially a little bit. But I still use a CR insert.
Thank you, sir.
Thank you.
Thank you for such a wonderful demonstration. Moving forward.
He's asking about patellar alignment. Just a comment. So my experience is, because we are able to balance the flexion equally with the robotic, which is a measured one, most of the cases, the patella aligns perfectly, and the incidence of LR has significantly reduced after we have started using robotics.
There is one paper on this actually, somewhere abroad. They mark special points on patella and on femur, and on trial they checked how it is tracking.
For the next discussion, we have, I would like to invite Dr. Hemant Mandorwa, sir, for expanding horizons, UKR adoption in India.
So thank you. Very soon, probably we'll have robotic presentations also, because technology has its own limitations. So I'll be speaking about expanding horizons of uni adoption in India. So thank you, Shalby, because the motto is restoring mobility and improving lives. So the knee replacement market is ever growing in India since last 25 to 30 years. And for patients, this translates to more advanced treatment options, better implant longevity, faster recovery times, in all a very good future. So what are the key growth factors of the Indian market at this moment? So Indian population is aging, so we are not very young, we are moving towards an aging population. There are lifestyle factors which lead to premature joint wear and tear, and more patients will require arthroplasty. Increased affordability and insurance, especially after the advent of PMJAY. Medical tourism. Many people from all across the globe come to India to get the arthroplasty done. And the last but not the least, growing awareness. Patients are more informed, proactive about the definitive solutions for knee pain. Now every patient asks about robotics, about unis, about other options, about dual mobilities, about the newer advances. So in terms of revenue, India accounts for only 2.5% of the global joint market. That is in 2022. But since last 3 years, the growth is very encouraging. It's almost 6.3. Anything which is more than 4 CAGR is considered very good. So why uni? Even unicondylar knee arthroplasty is growing day by day, as we see. This was told by my mentor that every modern arthroplasty surgeon has to learn or at least have the knowledge about AMOA and unis if he is not doing or not. And in the experience of arthroplasty surgeons who have started doing uni, almost 1/3 of their total unis have been knees have been converted into unis. So conservation has always attracted attention. Even in my case, so we started with PS design in my earlier career. Then I shifted to CR, and I started retaining the posterior cruciates in almost all my primary knees. During my first few years of arthroplasty, I used to see my tibial cuts, and they caught me thinking whether I am doing justice to my patients. Is this knee a right candidate for a total knee like this? Then 2014 onwards, dissatisfaction rates came in vogue regarding total knee replacements, and they were to the tune of 20 to 25% in TKRs. So not everyone is satisfied with TKRs. Probably earlier we were neither accurate nor very precise. In today's era, probably with robotics, we are becoming accurate, but are we precise? We have to ask the question to ourselves. Ultimately, what we want is the bullseye, that we want to be accurate as well as precise. So an important study that came was the patient satisfaction was linked to preserving the ACL in many patients, and 83% of those TKRs done, a study was there, had intact ACL. So a new thinking started coming to think about preserving the anterior cruciate ligament as well. So now it's a paradigm shift from the traditional OA knee, what we used to write in our prescription, early OA, moderate OA, severe OA. Now another term has been coined, AMOA. That is obviously based on clinical, radiological and biochemical parameters, but either it is AMOA or it is a tri-compartmental OA. What are the top 4 trends shaping uni knees in 2025? Robotic assisted surgery, probably we'll be seeing in the evening, one. Cementless option, though not available at this moment to majority of us, but in the near future we might have that. Domestic manufacture is on the rise, so we see now a lot of companies taking unis. People who have started doing unis like me have broadened the Cousin and Scott's criteria for UK, which were very stringent, and now the indications have expanded to a certain bit. What are the benefits of partial knee? Well, you don't damage any of the ligaments, so kinematics and proprioception are all preserved. We are trying to preserve almost 3/4 of the normal knee. The functional outcomes are better and earlier, and conversion to TK may not be very difficult, very easy, but not very difficult, conversion of a TK to a revision TK. Over the past decade, the change in focus of the patient's expectation also has been there. Rather than survivorship or functional score, now the patients want satisfied, they want activities of daily living, they want to be happy with the joints. So what are the myths and facts regarding uni? It is not indicated in young active. Well, it is definitely indicated. Some results of unis are there. Is equal to doing a robotic knee. Karthik just mentioned about doing a robotic knee, but still we are taking all the ligaments. He was retaining the PCL, but we are taking almost a normal knee out. And restricted activities post UKR. There have been instances when people have gone doing skiing, doing running as well. So there is a wide range of bone loss anteromedially, and all these are candidates for uni if properly diagnosed. So the take-home message is 20 to 40% of our TKR patients are actually candidates for uni. We have got excellent long-term survival now, almost 28 years long-term follow-up is there, papers are there. And patient satisfaction, once you do a uni, then you'll realize. Partial knee is for all ages. It's not a time-buying procedure for total knees. It's not a stopgap arrangements. So there is no age criteria. If you want to have a longevity with a good patient satisfaction, in indicated patients, definitely uni is the choice. So people who are doing only total knees, now it is the time to change, and probably part of your practice will be shifted to unis. From this to this. With this, I thank you. Thanks Ortho Trends for inviting me.
Thank you, sir, for such wonderful presentation. Moving on, I would like to invite Dr. Rajesh Verma, sir, on the podium for his presentation on patient selection dilemma. Are we missing good UKR candidates?
Good evening, everyone. Thank you so much for having me here. So it's a very pertinent topic about unicondylar knee replacement, or what we favorably called as a tuxplasty nowadays. This opportunity came to me 10 years ago. I usually do spine surgeries, but then I offered the training of Oxford to my colleagues. Everyone declined, that said, no, this is not good, it should not be done, there are so many problems. Then I had to adopt this training. I got myself trained with Oxford, and since then I have been doing unicondylar knee replacement along with lumbar disc replacement, cervical disc replacement. That's the only replacement I do for the joints other than hips. Sometimes decisions are easy to take for unicondylar knee replacement. Like in this case, it was not difficult, but many times in different scenarios also, I have ventured into this subject of unicondylar knee replacement, even in the severely deformed cases. So we need to break the myth, what cases are perfect, where you should do it, and where you should absolutely say no to the unicondylar knee replacement. As rightly said by the previous speakers, approximately 40% of the knee replacements are done unnecessarily, where we can just get away with unicondylar knee replacement surgery. And this is not only in India. In India only we are doing 2% of unicondylar compared to global. And even in India there is a lot of north-south, east-west divide. Most of the uni are done by the Western India. North India are very, very lagging behind. Only minuscule part of the unicondylar are done by North Indians. This is one of the patient. I did TKR 3 weeks ago. And during surgery now, every time I see what was there anything left inside, where could have been done, could we have got away with the unicondylar knee replacement. So everything was intact. These lateral osteophytes which we see on the lateral compartment are just peripheral osteophytes. You can easily do unicondylar knee replacement in such cases also. So it is not, I heard this terminology in my previous session with one of the surgeons who is sitting here. He described this as internal amputation of the knee. We love ACL, we love PCL, MCL, all menisci, but how brutally we sacrifice during total knee replacement surgery when this could have been easily saved. And when UKR are giving excellent outcomes compared to TKR, there are fears about the problems related to revisions, also about the durability of the implant, but I will come to that point also. Even I asked this question to ChatGPT, why unicondylar knee replacement is done very, very less numbers even in India. So other than common answers about the dilemma regarding the selection criteria, most of the surgeons fear about the revision rate. They fear about the longevity of the implant. And I must admit that there is a big training gap, and patient bias is also there. Patients are also not knowing about this problem. They also challenge your decision, said, sir, you are the only doctor who has advised this. Every other doctor is saying about total knee replacement. So you also come on to back foot and say, okay, that's fine, we'll do it. Because most of the surgeons, they will ridicule this idea of unicondylar knee replacement. So basically the selection dilemma boils down to age. Let me break this myth of age. I have done this surgery in 42 years as well as 92 years. So age is not a barrier. Other indications are more important. As far as activity, lifestyle status is concerned, it is not restricted to low demand patients or high demand patients. Body mass index, osteoporosis, combined if you come with a heavy patient with osteoporotic bones, with the short legs, you should avoid it. ACL status definitely for mobile bearing, but not for the fixed bearing implants. FFD and varus up to 10 degrees can be accepted. Osteophytes, pectoral joint status, there are few instances. And whether to do STO or after STO can we do unicondylar. These are the basic selection dilemma. But this slide, everyone should remember, for AMOA, pain should be localized to anteromedial aspect, range of motion should be perfect, more than 110 degrees ideally, deformity should be less than 10 degrees, ligament status, MCL is must, ACL you can accept even if you are doing fixed bearing implant. Bone-to-bone arthritis is must. Left side knee you should do STO, right side when bone is touching with the bone. Varus up to 15 degrees, as I told you, after 15 degrees you should be careful. Varus should be correctable. On a valgus stress view, varus should be correctable. Lateral compartment status we always see by the lateral 20 degree flexion. We do the valgus stress that also shows correctability of the MCL as well as non-collapsing of the lateral compartment. FFD, most of the time, not more than 10 degrees I will accept, but sometimes you see these annual osteophytes and ACL changes. Sometimes there are cysts in the ACL that can be decompressed at the time of surgery. Patellofemoral joint, mild to moderate arthritis is acceptable, but not the subluxation or severe bone-to-bone arthritis, especially on the lateral facet, is not accepted. ACL deficiency, I have done in many ACL deficiency with fixed bearing implant, but you should avoid, and it can be seen easily by good lateral x-rays. In this side it is intact, here it is anteriorly subluxated, there is an annual osteophytes, and there is a depression for the posterior component, posterior part of the tibia is also degenerated. MRI is rarely done. I never do MRI, especially when I expect that there is something else like bone marrow edema or some other problems, osteonecrosis, then only I will do MRI. UKR after STO is avoided, best avoided, but sometimes it can be done. Outcomes are excellent, especially with the vitamin E infused fixed poly up to 15 to 20 years. Numbers are scary as compared to total knee replacement, but when you are doing it regularly, your revision numbers will come down. This is one case which I did today itself in the morning. It was looking valgus, but when we did the X-rays, AP standing, lateral and stress view, I was convinced that I can do it. But during operation, I decided not to do uni on the right side, but I did only uni for the left side, and because of the heavy weight patient she was throwing her right leg into the valgus. So to avoid any complications, we did total knee replacement for the right side and left uni. It was done in the morning itself. And seeing is believing. I have done farmers, I have done laborers, I have done elderly, younger, and I am very happy with the outcomes. Thank you very much. And with the Tux robot also in our house, we are much more confident and comfortable doing Tuxplast in more and more cases. Thank you very much.
Implant positioning. I would like to invite Dr. Bhupen Patel on the podium.
Good evening, everyone. I congratulate Ortho Trends for such a good academic event. Now, after selection criteria, I'll go through the techniques, how we accurately place our implants to get good results in UKR. So basically, UKR aims to restore native kinematics of knee. It is not a deformity correction surgery. We need to remember it when we are doing uni. And at the end, varus knee should be in varus, valgus knee should be in valgus. So clinically, if we see post-operatively, patient's limb will be looking like varus. So sometimes patient may have question that it is still looking bent, but they need to understand, and then we at least should explain them or educate them. This is not such a surgery where your limb will be perfectly aligned. In today's era, when we are talking about UKR, we should talk about manual as well as robotics. Alignment in UKR, there is no fixed consensus of degree. Like in varus knee, you need to achieve this much of degree. This is a very in-depth paper which I gone through, and I found that when pre-arithmetic alignment is not taken into account, mild to moderate varus for medial UKR and moderate valgus for lateral UKR produces best outcome. When pre-arthritic alignment is taken into account, superior results have been reported with restoration of pre-arthritic limb alignment and joint line obliquity. So the ultimate goal after UKR, and mostly the UKR will be medial because lateral UKR is very less common. So as we see in the X-ray, in medial UKR, the line passes through the implants. It is not, we are not aiming for neutral alignment. So implant positioning in UKR, we in manual surgery, we start with tibia first, and this is the most important and most crucial cut. This is the most important step. Why? Because the rest of the surgery depends on this cut. In uni, failure is seen usually on tibial side. So I have kept two examples. One is mobile bearing, one is fixed bearing. Both sides have tibial failures. So right tibia cut, right surgery is the dictum. So tibia preparation, we want minimum possible cut. Why? Because we want to be in subchondral strong bone, which will support the implant well. Proper lateralization to get a broad area, adequate posterior slope to get good range of motion, and we need to avoid medial overhang and also undersizing, as the implant should not sink into cancellous bone and should avoid too much internal rotation. So on femoral preparation, we need to keep tide mark in mind. Tide mark is a point where in full extension, tibial anterior border comes in contact with the femoral condyle. So we should not be beyond this tide mark, because if we are beyond anterior to this tide mark, our implant sits, it will hit the patella in range of motion and patient will have pain in the anterior knee. We try to be in center of a condyle and we avoid medial overhang. There should be a medial little bone and implant should not be proud. So what checkpoints we see on trial? So after tibial preparation, femoral preparation, we take trial and we see the loading points between femoral implant and poly in extension and in flexion. There should not be any impingement in extension between the poly and femoral bone. There should not be lifting of trial poly in deeper flexion. So if we on trial, if we achieve this, that on a deeper flexion, if the poly is not lifting, we have achieved a good flexion gap and patient will have good range of motion. We also published our early results of TUX, Tahoe unicondylar knee system, and it shows very good results. So now, unicompartmental knee arthroplasty is robotic technology really much accurate than conventional? And the answer is yes. In many studies, it concluded that the robotic assistance improves the component position, and thus how it will improve the results and longevity of the implants. In this study, they showed that in tibial slope, manually there was a variation of 3.1 degree, as in robotic it was 1.9 degree, and tibial component varus valgus malposition root mean square error was 3.4 degree in manual versus 1.8 degree in robotic. So now we'll go to robotic UKR. How it helps in accuracy? So it will help us by guiding implant alignment, guides about knee balance, and it helps in accurate implant positioning. So alignment and balance guide in robotic UKR is given perfectly on the screen, as what is the pre-op alignment, what we planned for, what was the pre-op graph, and what we achieved. So femoral component planning, in sagittal surface we can match the patient's native bone. On coronal surface also we can mediolaterally match the perfectly to the implant. Tide mark orientation we can keep in mind, so it is not proud anteriorly. Varus valgus positioning also can be done. On tibial side, depth of resection, which is one of the most important factor, is in our hands when we do it robotically. We can perfectly match the posterior slope of the native anatomy, and we can rotate the component and can give varus or valgus position to the tibial implant. And balancing the uni robotically is just a few clicks away. As in this case, it's a little bit lax on the extension side, but is tighter on the flexion side. So we just need to anteriorize the femur and slightly superiorize the femur. This will correct this tightness. And after this, we trial the components and we see that how much range of motion is achieved with the degree of deformity, means how much varus is remaining, and this is showing the solid bar is showing the tightness in the throughout range of motion. So radiological outcome after robotic UKR is good restoration of posterior femoral offset, joint line restoration and replication of posterior tibial slope. All robotic uni X-rays will look alike. They will be like judwas.
Kindly summarize, sir.
Yeah, last. So in summary, UKR is not a deformity correction surgery. In a manual way, right tibia cut, right surgery. And robotic UKR is more accurate in terms of implant positioning. Thank you.
Thank you, sir. Now I would like to invite Dr. Bhushan Sabni, sir, for presentation on UKR intraoperative challenges, lessons and solutions.
Good evening all, my name is Bhushan Sabnis, I'm from Mumbai, and uni knee is a bit of a passion for me. I'm a non-robotic surgeon, so I believe in my own hands and own brain still. That is just under the belt punch, as you can see. But yes, I think robotic has a good role in uni compartment knee replacement. What we need to understand is uni is a fairly different beast. So there's a longer learning curve compared to a standard TKR. It's much more dependent on the instrumentation you use, so simple eyeballing may not be enough. It's less forgiving and it's more of a stealth surgery, it's not a strength surgery at all. So every time I'm teaching uni, I tell my registrars or juniors to use the wrist muscles, not the elbow and shoulder muscles at all. There are multiple small steps, so if you don't follow this domino effect, you get everything falls apart, so you need to follow to the last T to get the best result. Things can go wrong very easily during uni, but if you follow the basic steps, if you tick every box that you're required to, these are some of the happiest patients you'll ever see. Always when you start doing unis, or always when you're in your unis as surgeries, appropriate patient selection is very important. So don't try and do uni for everyone who has grade 4 MCOA with affection of other side as well. At the same time, don't follow some of the newer thinking that you can do uni for a root tear of medial meniscus with moderate MCOA. That means that's an overkill in my book. FFD of 10 degrees, varus of 10 degrees are all manageable with a standard uni compartment knee replacement. I would normally say at least 90 degrees of flexion is important. PFJ affection is generally not worrisome, and age, sex and activities do not have any bearing on the results of your uni compartment knee replacement. So a standard patient who has collapsed medial compartment, who has bone-on-bone arthritis in the medial side, on the lateral side there is no sign of instability, is an ideal candidate for a partial knee replacement. Don't select patients in whom you will struggle to find the knee joint when you open, and in whom the knee subluxes, and these patients generally are left for total knee replacement. When you are doing a partial knee, you always have a TKR on standby for a simple reason that you need to assess and confirm that the medial compartment is the only one which is affected. You can see the lateral compartment is very well preserved in this patient. As against that, this patient was planned for uni, but when I opened the knee, there were big tire tread tracks on the lateral side. These are generally indicators of a lateral subluxation that happens in weight bearing. So these patients are not suitable for a uni, and do not make the mistake of doing a uni in these patients. Generally, you be prepared for difficulties if the bone is too tough or too soft. There is a lot of scarring. Generally, in first couple of 100 cases, do not venture into minimally invasive surgery as such. Be a bit careful managing unstable knees in your first few hundred cases. But most important thing is you need to know the instrumentation by heart. You don't rely on the company representative to tell you what to do. You tell them what to give you. That's the kind of confidence you should have with the instrumentation. You need to look at the instrumentation in the tray. You should know what is in the tray and what is required. A very busy slide. I think all of that is mentioned by Bhupen before. But important, it's a gap balancing technique. So everything depends on your tibial cut. So make sure your tibial cut is good. I won't go into details of this because it's already been discussed. The key step is doing gap balancing. So it all depends on your tibial cut. If your tibial cut is good, then everything will fall in its place. But if your gaps are not perfect, if they're both too tight, you can always recut the tibia to a bigger gap. At least 8 millimeter size is the space in your extension. And after that, you can check your flexion gap. If your flexion gap is too loose or too big as compared to your extension gap, you can use a thicker poly by reducing the slope. If your extension gap is too big as compared to flexion gap, you can take out the posterior femur using freehand technique in flex position, and you can also increase the slope. So there are typical things that you can do, and TCAR also works in here. But what you are essentially looking for is an extension gap and flexion gap being the same. This is a tuxplasty design, and 8 millimeter poly spacer should go both in flexion and extension using 2 fingers. So not using your forearm muscle, just finger muscle, you should be able to pull it and push it in. During surgery, it's always important to be aware of what's happening. Now, this is one of my patients only, and something didn't feel right when I was doing surgery. And you can see the tibial base plate has not fit in properly. It is overhanging. This was post-cementing. So I had to go in immediately, take the tibia off and redo the whole thing again. And if you're not very careful, you can get a picture like that. I'll come to that in a minute or so. Lateral unis are a different kettle of fish altogether. The tibial cut is very difficult to manage because sometimes the slope is too high, and a lot of times you will see that your tibia is sitting in air, and that can be a nuisance. But more often than not, you are able to get a good correction doing lateral unis as well. Do not push the knee into opposite direction. So you should not push medial compartment, uni compartment knee replacement into valgus, and a valgus knee into varus when you do a partial knee replacement. Slope is a very key part, and believe me, the slope is not the same in both knees, even in the same patient. So if you look at this patient, the slope on the right side is less as compared to left. This is a bilateral uni, and you have to replicate that when you're doing a uni compartment knee replacement. Same patient, you can see the slope is about 6 degrees, and you have to physically measure it to believe that you have done a good job. So I've increased the slope by about, reduced the slope by about 1 degree, which is acceptable in my book. For unis, the x-rays make a lot of difference. So if you don't take a perfect lateral view, you're going to struggle significantly. That's a good perfect lateral view, but if you get a view like that, you'll always worry that you've done something wrong. The tibia is proud, posteriorly the femur seems to be in the air. So you need to get a good x-ray every time to confirm that you've done a good job. That's the kind of x-ray one would like to see to make sure you've done a good job with a partial knee replacement such as this. I will not go into post-op complications, but one of the worrisome features that you see during uni is having intraoperative tibial fracture. You will need, of course, need to be vigilant about it, and you need to have a backup TKR and maybe some basic plating system such as this to fix it if it happens. Fortunately rare, but the usual mistake most people do is putting the vertical tibial cut too far medially. So you need to go at the apex or just the downslope of the medial tibial plateau or medial tibial spine to get a perfect position. If the x-ray is not looking perfect, there's usually something wrong. Like in this x-ray, there's actually a impending fracture, and this patient after starting weight bearing had a proper fracture. You need to revise them or fix them properly. Femoral fractures are fortunately rare intraoperatively, but again, it's associated with trying to push in a bigger component or bigger poly inside, and these unfortunately will need fixation and a revision fairly straight away. One of the worrisome things that you see with robotic surgery as well as young surgeons is damage to the MCL or damage to the ACL with your saw. So be very, very cautious when you're doing it. Mobile bearing polys are known to dislocate, and you need to be very careful about sizing and balancing the flexion extension gap and not putting them too tight. One of the cardinal sins in a partial knee replacement is valgus overload, If you overstuff the joint, then you are going to get something like this, where the lateral compartment will fail within a couple of years, and these patients are very unhappy, and the knee joint will fail as well. The standard other complications also are important, but make sure you follow the basic surgical technique for whatever system you use. For tuxplasty, you need to make sure that you use the extension gap, the flexion gap minus extension gap only after your extension gap is easy 8. So don't be in a hurry. Ultimately, what I'm trying to say is the unis are a very good surgery, but they take time to master. If you want the patients to show you this post-surgery, you need to do fine movements and not use force. There are different set of complications. You see, this is the same lateral uni I showed. This lady is 47, this guy is 84, and really happy after lateral uni, medial uni for the lady, and they're able to do most of the activities very comfortably. Everyone had told this guy TKR at the age of 84, saying uni is not his cup of tea. He's about 3 years down the line and is very happy about it. A 56-year-old cricket coach has gone back to doing everything. This is 6 months post uni compartment knee replacement. So I don't stop them from doing any activity they want to do, except for maybe a very high impact activity as such. So make sure you do not push the knee in valgus. Don't do significant release of ligaments unless it's very essential. Don't play with the slope, and don't do rotational problems in the uni. Just on a parting note, this is a uni plus ACL as a combined surgery done 4 years back, and so you still can do a uni and ACL together in ACL deficient knees in young people. He's 4 years down the line and is very happy. He's able to do most of the activities comfortably. So select your patients, do your surgeries properly, follow the steps, avoid any cardinal mistakes, and I think you'll be rewarded very heavily when you do a good uni. Thank you.
Thank you, sir. Any question from the delegation and faculty? Thank you, everyone. Moving forward, next is relive surgery on the lateral unicondylar knee. I would like to invite Dr. Harvinder Chadda, sir, and also I would like to invite moderators for this session, Dr. Bhushan Sabnis and Dr. Jayesh Patil, sir.
All right, I'll cover the lateral UKA, and it's also a rare find in my practice. And then whenever I get asked to teach, 3 of them show up, and then I won't see it for another couple of years. I'll cover some of the topics here, but I would really want to start the live surgery so you guys can see what we can do. And my main point is that we can do the lateral uni through the medial peripatellar approach, and it's advantageous to align the tibia, and which has to be slightly internally rotated because it does track and it does cause liftoff on the trial. So and thank you very much for inviting me. The lateral UKA is limited due to the implant design. One of the first times that I really encountered this uni was on the lateral side, where I had only used the medacta because it was specified for that and in the shape. Here we have a round-on fixed bearing, so I was a little bit more confident. And after doing a few medial ones, the lateral one went very nicely, and the fit was based on gap balancing, pretty well done. So the design, it's the same implant is used for both the medial and lateral, and it's reasonable to be an alternative to a total knee arthroplasty. And what I was concerned with, even with the MG2 and the Oxfords, I had used those, people still complained of medial femoral condyle pain, and it was with heavy activity. So here, the resection of the femur, the femoral component, is only about 4 millimeters, where most of the others is around 7 to 9, almost 10. And so now we can almost reasonably do this and have a very quick recovery, but they never complain of pain along the medial femoral condyle after the uni. Usually on the lateral side it's post-traumatic arthritis, and then also the other indication is chondrocalcinosis. Classic indications are kind of irrelevant. Since this is a fixed bearing, I've expanded the indications a little bit more. I don't need an ACL. I don't rely on the weight restriction, although I tend to have some BMIs that are 40. This is what happens without calorie restriction. And so I do tend to limit it in the heavy set patients. And I really want to see that, same as on the medial side, the passively correctable deformity. Fast recovery, conversion rates are about 5% after the first year and then 1% after that. I tend to tell the patients that about 5 to 7 years, if this is going to progress, we're going to be changing over to a total knee. And they're happy with that. Again, most of these are active patients, not so much age criteria here. So here's an example, and we'll quickly dive into the live surgery. This is a patient, here's the pre-op. There is some subluxation of the tibia. I took the bilaterals 3 months afterwards, and you can see that on the normal knee, there's still some subluxation. After the lateral uni, 3 months postoperatively, you can see the subluxation has somewhat corrected. And you can see the lateral view, the slope is slightly more, but it's about 3 degrees, and then the femoral component is matching the posterior cortex of the femur. One other thing, you can see that on the sunrise view, the femoral component versus the tibial component. The tibial component is intentionally interior rotated there. That's what you want to look for, because that lateral side will translate from A to P, and it'll translate about 1.2. And that's the natural motion of the knee, which you have to take into account here. Some of the pearls here is that I use a medial parapatellar approach. I have used a lateral, and it's harder for me to interior rotate that tibial component because the tip of it has to sit behind the patellar tendon. So medial parapatellar approach, release the capsule, and then peel away a little bit of the patellar tendon. The femoral component inherently is smaller when compared to the medial side, so you will get a mismatch. You'll get a larger tibial component than a femoral component. And then the kinematics, again, posterior translation 1.5 centimeters. And this is subjective, but there should be some laxity in flexion. You don't want to make these too tight. As they're going to roll back, you need some laxity. Tibial component, you have to get it behind the patellar tendon, and it has to be sitting behind and interior rotated. So lateral parapatellar approach, you tend to make that error where it's exterior rotated relatively, so you have to be conscious about it. Cutting it, it becomes a little bit difficult because the patellar tendon is in your way. Femoral component is exterior rotated, and it should match the anterolateral portion of the femur. Conclusions, post-traumatic chondrocalcinosis are the main reasons why I see them. And then bottom line is external rotation of the femoral component and internal rotation of the tibial component, and don't overstep the flexion gap. All right. And then I think this has been covered, equalizing the flexion extension gap. What I found with all of these unis, and it's not unique to this one, minimal tibial resection with the minimal femoral resection was the advantage of the tuxoplasty. So if I would take off minimal tibia, I would have to raise the joint line if I were using other components, because the thickness of the distal femoral component is somewhere around 7 to 9 millimeters. So here we have a good combination where we can take off minimal resection not only of the tibia and not sacrifice it on the femur. So typically, if you have equal flexion extension gaps, and here's the key. The distal femur is only recessed 4 millimeters, so it's sitting on that hard subchondral bone. Now we have both the tibia and the femoral components sitting on hard subchondral bone. So that's where the subjective portion of the complaints with heavy activities becomes important. The x-rays I showed you at 3 months, that female, that lady had climbed 7,000 vertical feet the day before she came in to my office. So that's why I used her as an example. Very quick recovery, but she can endure, and plus, there's no atrophy after I see these patients at the 3-month mark. Okay. Manual instrumentation, and then here's my contact. Can we roll with the video? The video? Yes, okay. So, all right. So here's the medial parapatellar approach and capsular release, and then the patellar is sort of peeled a little bit more laterally. We go ahead and take off the excess osteophytes on the lateral portion of the femur, some on the, little bit on the intercondylar notch, and as you take away that capsule, you can fit that smaller portion of the cutting guide into it. Here I align from the AP, and then you can see that there is a parallel on the fibula, so I can also align it on the second plane, and so I don't get too excessive of a posterior slope on the tibial component. So once they're marked, we'll take a section of bone, and here it's under resected. You can see it looks like a meniscus, but that's actually bone. So I'll take off minimal bone. The 8mm spacer obviously is not going to fit. So I have these smaller spacers. This is about it's about a 6mm spacer, but it was more like 4 or 5, somewhere around there. So we took off an extra section of bone, and then now it's at about 8mm. And in extension, there was no laxity. Usually there'll be a mismatch. On the medial side, I'll have 8 posteriorly and then usually 10. And here you had a little bit of laxity, so I think I chose a 9 for the extension gap and an 8 obviously for the flexion gap. That needs to be set first. So then we are going to size the femoral component, and usually it'll reach the top of that. I'll usually use the tibial wafer as a sort of an indicator of where it is. This is placing the intermedullary rod. This will give us the alignment, the flexion and extension of the femoral component. So once you have that, what you want is the spacer, which is holding the cutting guide, to be parallel to the intermedullary guide. There you go. So those two are almost parallel, slight flexion on it. And then the next thing you do is you can translate it, because it's connected to the IM guide, you can translate it laterally. But it'll naturally be too close, so as you can push it over, I usually center it I usually move it to the center of the tibia, so it's not too far medial. Then drill the 2 pilot holes. And I'm not, if the flexion gap is too tight and I've used the, I've taken out enough bone and I'm getting into subchondral bone, I'm not afraid of taking off a little bit of extra posterior femur. It's usually cartilaginous. At this point, we took off the posterior resection, and then now we're milling it. Because the flexion and extension gap were a little off, I took off, instead of 4, I took off only 3, tightening up the extension gap to meet 8mm poly. This is now milling the larger size of the femur, and then it'll sit all the way down and be flush. You have to resect a little portion of this bone from the initial cut of the posterior femur, and then the trial goes in, and then I just confirm that we still have a flexion gap of 8mm. Once we take that out, then I can usually prepare the tibia. And I like to look at the femur in its place so I can make sure I get a little bit of internal rotation. That arm is slightly interior rotated, and it's overlying the patellar tendon. You can see patellar tendon and patella are resected and held with that retractor. And the peg hole is drilled. But it's forcing it, the patellar tendon is forcing it into internal rotation, and that's the position you want. Once completed, I impact it in, set the rotation with the keel, and with the femoral component in place, that impactor sort of compresses the bone. Then we go on to the cementing, and you can see as we put in the tibia, then the femur, the polyethylene, and you can see how it's lifting off the femoral component. The femoral component is lifting off the tibial component. We'll put in the poly, and then unlike the medial side, you're going to have to hold this down in flexion, because now the in flexion, the femoral component is sitting posteriorly about 1 centimeter. So we'll put that in, and then I will use, once it's impacted, I'll use a curved osteotome to hold it down as the cement sets. So that's me holding pressure until the cement hardens. This is the final product here, and there's the patella. I wanted to make sure you guys see that it was off laterally. All right. And I think that is repeating. Okay, we're all done. The video is repeating. Questions? Thank you.
How much looseness do you allow with the practice? How loose it should be?
So in extension, it's usually slight laxity, 1 millimeter. In flexion, I keep it around 2 to 3. So usually I'll pass like a little spacer, 2 millimeter spacer that I have. And I don't do that for the medial side, but on the lateral side, I'll keep it loose.
What about the medial?
Medial side, I tend to keep a little bit of laxity, only because I want it, the alignment to be on the medial. Okay, so I'll have both laxity, about 2 millimeters on both on the extension and on the flexion gap. So very slight, it'll keep the axis medially, and so you're not going on the midline. But there, on the lateral side, it's a differential. Tighter in extension than it is in flexion.
Do you pressurize with a higher size poly when you're doing it here on the stage?
Yes.
Do you pressurize with a higher size poly first and then put the final poly one size smaller?
I don't, because the osteotome, I can wedge it in there and then really hold a lot of pressure. I don't tend to do that. On the medial side, what I'll do is I'll put the tibial component and the polyethylene, and then put the femoral component over that, and then put a little spacer in there.
So how do you decide the in keeping the internal rotation of the tibial cut? With the sagittal cut when we take, so you keep it at the center of the head, pointing the sagittal blade, or how you manage that?
For that cut, generally I'll overcorrect just a tiny bit, but it's internally rotating, and it'll go right in between. And the ligaments will let you guide it so it doesn't go too far medial. Okay?
So that means you want to keep the tibial component slightly internally rotated.
Right. So as you come in, the patellar tendon is in your way, so you naturally internally rotate the cut.
Okay, the patellar tendon just
is lateral.
Okay,
but
so
because it's there, it will internally rotate you.
Okay, so you don't have to. If we are using a retractor on
Yes.
the lateral side, so that prevents the patellar tendon from this making it internally rotated.
Yes, but it's the actual patellar tendon that's in the way, but it's forcing you internally rotate. Not so much the lateral patella.
Don't you keep intentionally in internal rotation?
Yes.
Or the patellar tendon helps to keep in internal rotation?
It does, but if you look at it the other way, if you go lateral parapatellar approach, the cut has to end behind the patellar tendon. So it's in the way, right? Here you can move it out of the way, and you can strip it just a little bit so it doesn't get in the way of the blade that comes in.
And how you manage the external rotation of the femoral component? That with the intramedullary rod that you told.
That'll be internally rotated on the tibia. And what was the other question?
External rotation on the femoral component, how do you guide?
So it has to, on the anterolateral portion, it has to match that. So you'll want to try to not be too far medial on that. So it's all on the lateral side that you want to match it after you take off the osteophytes.
Any further questions? Thank you, sir, for such wonderful demonstration and engaging session. Moving forward, our next talk is revision of unicondylar knee replacement, when and how to convert to TKR. I would like to invite Dr. Narendra Vaid, sir, on the podium.
Yeah, so UK, when done, most of the times the forgotten knee score is excellent and patients are very satisfied, but sometimes things can go wrong. So now with the increasing use of uni, there will be more sort of revisions also. About 10 to 15% may require revision in 10 to 15 years time. If you see the long-term survival rate of uni, it is fast approaching the total knee replacement. Even the mobile bearing as well as the fixed bearing, they are showing excellent results in long-term results are there. Survival rate after 15 years is around 94%, so it's main causes. Uni is an excellent procedure, but it is hard to get it right, and you should have adequate training, and then properly you have to take it. You should not treat it as a very surgery, take it lightly. Accuracy is the most important determinant for survival of unicompartmental replacement. So if you see the failure patterns, if the uni fails before 2 years, then it's mostly bad technique, judgment errors, bad ego. Sometimes I say it because we tend to sometimes over prescribe uni and do these unis when their defect is going posteriorly also. Ideal indication is anteromedial, and sometimes bad selection of patients. These are the main causes below 2 years, and then other causes are progression to the other compartment if it is beyond 5 years. Diagnosis is pretty simple. If there is any instability, swelling, decreased function, range of movement, X-rays are very evident. They show loosening or subsidence of tibial side. These are the most important things. Must rule out any infections by routine protocol of diagnosing PGI, and you have to keep armamentarium. It's not really difficult to diagnose badly done unis, and in which these things you can see all the causes. The cuts are bad, they are too deep cuts, and these are bound to fail. Progression of arthritis on the other side, you can see there is overstuffing of the medial side, and then this has progressed to the lateral compartment, and this definitely requires revision. Sometimes the implants are loose, and then proper cementing techniques are not done, so implants come out very easily. Here you can see both the implants were very loose, so after diagnosing and ruling out infective pathology, we had to do a revision in this particular case. Bearing dislocation is a common cause for revisions of mobile bearing. As I told that if it is not properly balanced, then this can be disastrous consequence can be there. Infections, you may do single stage or 2-stage revisions. If you are knowing the organism, it is only single organism. There is no multiple bacteria involved, no fungal infection, or there is not a major bone loss, then you can attempt single stage revision after doing thorough synoectomy and change the operation theater and take it for a single stage revision. Sometimes, during surgery, the collateral ligaments can get damaged, and they will have instability in which you have to do a revision surgery. Polyside breakage, we have seen quite often, if the balance is not proper, then poly breakage, and especially the mobile bearing, have been actually documented. Tibial side collapse, very common, because if the patient selection is not proper, means when I started doing unis some time back, then our indications for BMI were very strict. I used to have selection criteria up to 32 BMI. Beyond that, uni was not prescribed, but now I have extended it. But you should remember that the patient should not have a small tibia, and BMI should not be high. If the bone is porotic, there is a small size patient, osteoporotic patient, very likely that the tibia will collapse and then there will be a problem. So when to convert doesn't require much intelligence, you should do, it's quite obvious, and you should do a full length x-ray, CT scan to see the bone stock, check exactly what is the bone loss, and then keep your armamentarium ready for the revision surgery. Most of the times these can be managed with primary TKR, and if the bone resection in the initial surgery was minimal on the tibial side, you don't require augments also. But if it is a deep cut on the tibial side, you may require augments and stems, so you have to keep it ready. There are some very few cases I had to keep a hinge also ready for cases where the collateral ligaments were damaged. So, removing the implants are sometimes a challenge. Bone defects, landmarks are lost. So these are some of the challenges when doing a revision surgery. So when I remove the femoral component, I put this guide and then cut the femur, taken in situ, put the intramedullary alignment rod and then cut it. And then with a narrow saw, you release, you cut the bone from all the sides of the tibial lug holes and then femoral lug holes, and then it can come out very easily. On tibial side, if the resection is minimal, then primary cut can sometimes take care of this thing, tibial base plate removal. You should be, you should know the primary design. Sometimes the keel can be a bit deeper, and so you should be, ready with the alternative sort of strategies. Sometimes when the cut is deep, then I take an intramedullary entry in the tibia and take a step cut to put an augment in the first go itself. So these are some of the some of the guidelines for avoiding bone loss. Don't use a high-speed brush. Use narrow osteotomes, and you can stack it on each other so that the tibial base plate comes out quite easily. Generally, primary implants are sufficient for revision, but if required, if the cuts are deeper, then you may require augments or wedges, and stem components may be required. Hinges, if the collateral is damaged or the tibial cut is too deep, or if there is any ligamentous imbalance, the hinge may be required. So these are some of the challenges for doing it. Some of my revised cases, you can see the tibial cut is very deep, and so we had to keep an augment ready. And even the femoral bone loss also was very much, and so I had to use a stem component. Again, a badly done uni with a varus cut on the tibia. We had to use a big wedge on the medial side to correct it. Keep a semi-constrained liner also here. Another case with malrotation and edge loading of the tibial component because of malpositioning of the femur. Keep the stems and wedges ready. Here there was a big bone loss on the medial side. You can see that it was all poly type of implant, and we had to use a big wedge on the medial side. The poly has actually, bearing has dislocated, so here we used the uniform 10 millimeter wedge for tibial stem to bridge the gaps, but it was tackled with primary. Another case where we had to use a wedge. Rarely the bone loss can be massive, and when you have to use higher constraints and stems also, and it can actually damage, have a quite significant bone loss. There used to be sometimes, I have not seen it in India, but there was a technique described as a unispacer where a mobile component was put in the medial or lateral compartment, and that used to destroy a lot of bone. Something like that has happened here. Post-operative, generally it's a standard rehab protocol. Range of movement is encouraged, weight bearing immediately started. So if you see the outcomes, they are, they generally equal the primary total knee replacement results. Sometimes there can be problems with range of movement, which can be restricted later on if there was a lot of tissue scarring. So generally, to avoid that, I always use robotic technology. I think robots are more relevant as far as the unicompartmental replacements are necessary. So you get a uniform sort of preparation, and it is absolutely standard. And always the component positioning is absolutely right, and there is no chance of going wrong in any of this thing. So I think for uni, if you are planning, then definitely resort to technologies. Patient selection of uni is very important, because that is a time, if you don't choose a patient properly, then that is a time when you have actually increased the chances of revision. You have to plan, you have to take out the implants meticulously, avoid bone loss, and then convert it with all the armamentarium at your disposal. Thank you.
Thank you, sir, for such academic session. Moving on, I would like to invite Dr. Karthik Selvarajan for his talk on restoring functional and kinematics with unicondylar knee arthroplasty.
So it's heartening to see a good crowd for the last talk of the session. And believe me, it's an important talk, and I'm going to actually tell something different from all the previous speakers. Kinematic is the go-to word now. Everyone is talking about kinematic all the time. And what about kinematics in the uni knee? So that's what we're going to look at. Now, uni is a kinematic surgery by design. So as emphasized again and again by all the previous speakers, we're not going to correct the deformity here. We're going to maintain the native alignment in this patient. And so neutral or a perpendicular cut and symmetry gap is not applicable to UKA. You're never going to do that. The goal is actually to restore pre-arthritic alignment, as Bhupen told and others emphasized. So these are the three things we are looking at in a patient: the patient's native morphology, native alignment, and balance. Now we have to restore the native morphology of the patient, native alignment of the patient, and by doing that we have to achieve a balance. That's what you're going to achieve, all these three, and it can be done very nicely with kinematic bar functional alignment. Now these are the various different alignment strategies. There is a very nice YouTube video by Vijay Bose on YouTube. You can have a look at it if you want. So what is neutral in uni? Neutral is not a 0-0. It's not a straight line with a perpendicular cuts. It is basically pre-arthritic alignment. So by choosing UKA, you already made a conscious decision to restore it. So you have to know what is the patient's pre-arthritic alignment. And we all know, so therefore a neutral alignment is a flawed concept in uni. So we all know about the CPAC. So try and find out what the CPAC is for the patient, and your aim in this surgery is not to achieve a straight line like this, but actually to do this, to give the patient's native constitutional alignment and just replace or resurface the damaged bone. It's basically resurfacing. So why kinematic? Basically the cut is parallel to the native tibial joint line and slope. It restores joint line obliquity, preserves constitutional alignment, and more natural knee kinematics. Definitely PROMs are more, and midterm outcomes there is no increased failure. Obviously robotic actually helps us. If you do with the caliper, it is called kinematic, and if you do with robotic, it is called functional. You can do it either way as you want. So how do you do it? You actually position your implants parallel to the cylindrical axis of the femur and perpendicular to the longitudinal axis of the tibia. So it's actually a true resurfacing operation, and it restores the native joint line and orientation of the implanted component. Now how do you do it? So this is the cylindrical axis of the femur. This was described in the 1970s by Cartier, and this has been in vogue for 40 years. This is not new. Kinematic alignment is not new in uni. It has been in vogue for a long time. Now this is the alignment of the medial side. This is the axis, perpendicular axis of the medial side of the tibia. So you are not drawing a line in the center of the joint, but you are actually drawing a line along the medial side. And this is the cylindrical axis of the femur. So your implant has to be positioned according to this. And how do you take the cuts? It's not a perpendicular cut. It's actually a slight varus cut. That's what you're going to do in kinematic UKA. In a mechanical UKA, obviously take a perpendicular cut to the mechanical axis of the tibia. What happens with that is you end up actually cutting more bone on the near the keel side, near the center of the tibia, or more bone laterally, and that actually puts a lot of stress here. There is a lot of load transfer to the cortex, and it has been shown that so this is how the cut is taken. So if you see, this is the cylindrical axis and this is the longitudinal axis, and this is how a kinematic cut is taken. This is how a mechanical cut is taken. They are different. They are different, and you can see which looks prettier. Definitely this is much pretty than this. So this is what you should be doing. So these are the three things you have to be looking at. This has been emphasized in the previous talks. You're looking at the tibial coronal alignment. The coronal line slight varus is acceptable if the joint line is oblique. You keep that in mind. This is not good. This is going to put lot of stress here. Load transfer is not going to be right. Patient is going to get a lot of pain and remodeling in this area. There can be a fracture as well. And joint line, if you take a deep cut, take a low cut, you're going to actually distalize the joint line. That is going to again create abnormal force stresses, and posterior tibial slope, you have to maintain the posterior tibial slope. So lowering the joint line is not good. Cutting the distal, tibia to distal is not. So there's so much repetition in all these talks, because these are the most important things when we talk about uni. So the tibial component has to be sized and positioned to load the cortex, not the cancellous bone. So definitely it preserves bone stock. If you take a slight varus cut, a varus up to 6 mm is 6 degrees is accepted in many studies, and it has been there for a long time. So you study the pre-arthritic alignment and do accordingly. It physiologically loads the tibial metaphysis. Again, slope, if you maintain the slope, the soft tissue balance is physiological throughout the range, not only in 0 degree and 90 degree. You want to have a balance throughout the range. And biomechanically, implant is placed to load the trabecular bone, not along the lines of the trabeculae. So this is a nice study by Kamanega et al., where it shows that the keel to cortex distance, if you take a valgus cut, it's going to be very short, and it might lead to fracture and pain later on. So that is this is a very good paper by Peter McEwen in Journal of Isocos. I urge you to read this paper. There can be pitfalls with kinematic UKA. Extreme tibia vara is a no-no. You can't do that. You might end up with a bad resection. Again, overly aggressive primary tibial resection should not be done. It has to be accurate, balance has to be checked, and angulation has to be within the published limits. That's most important. So kinematic is a little sort of unrestricted, but if you take a functional robotic, you are playing within the range. So you can have a little bit of varus, so don't worry about it. Definitely the scores are better with kinematic or functional UKA. So UKA will fail if varus is more than 5 degree. UKA will fail if valgus is there due to disease progression. This is a wrong concept. This can be only interpreted by knowing the pre-arthritic alignment. Keep this in mind. So these are my cases. So if you look at this, this is how normally you like to see a very straight sort of thing, slope restored. So these are patients where I've put them in a slight varus, but we have maintained the joint line obliquity here. And we are still our patient population is very small. We are studying the functional outcome in our patients, but maybe in a couple of years, in a few years time, I'll be able to tell you is there a real difference in, but definitely you're taking less bone when you place it in slight varus on from this lateral side, and it looks very physiological, and the joint line obliquity is good. So restore what the nature gave and balance what the patient needs, and future of UKA is definitely personalized. Thank you very much.
Any questions? Thank you. With this talk, we come to end of this academic session. Now we have industrial workshop around the various corners from 6 to 8. After that, we have a dinner. So hopefully we will start early. Thank you.